Conference, a keynote talk by Neil Hens. I think I probably don't have to introduce Neil to you because you all have read his publications, saw his presentations, or maybe attended one of his workshops or courses. I'm really happy that Neil is here for the full 2 days, because when I got interested in infectious disease modeling, I first visited one of his courses, which helped me a lot with my later work, because there I learned the basics of infectious disease modeling and the application of social contact data. So Neil is a full professor of biostatistics and infectious disease epidemiology at Hasselt University and holds the chair in evidence-based vaccinology at the University of Antwerp. He has over 15 years experience in human mathematical epidemiology. He pioneered research in the analysis and application of social contact data in infectious disease modeling, and to consolidate his innovative and interdisciplinary line of research on modeling infectious diseases, he received the prestigious Consolidator Grant Transmit from the European Research Council. He also coordinated the Horizon 2020 EpiPost project aimed at studying the COVID-19 pandemic. He has over 250 publications in both statistical and epidemiological peer-reviewed A1 journals. Neil is also the head of the Center of Statistics at Hasselt University and vice director of iBiostat at Hasselt University and Leuven University, and of the recently established Data Science Institute at Hasselt University, which brings together over 150 interdisciplinary researchers, including 27 professors. Together with Philip Beutels, Neil leads the Inter-University Research Group CIMID at Hasselt University and University of Antwerp. He has been consulted by ECDC and WHO, for instance, about the Ebola epidemic in West Africa and the Democratic Republic of Congo. And of course, he was an advisor of the Belgian government on managing the COVID-19 pandemic. So welcome, Neil, and I'm really excited to hear your talk about data collection, analysis, and application in modeling. And I forgot one thing. He's also a great basketballer. I recently read.
Was. Thank you. Great honor. What an introduction. And now I have to live up to that. And the basketball is in the past, by the way. I'm now coaching. Happy Pi Day, by the way. I don't know whether you realized, but it's Pi Day today. So, today I'm very honored to be here. I've seen great presentations yesterday, and I'm sure I'll be seeing great presentations today. And when Alexander asked me to think about what to present, I had many different options, and I'm not sure I've taken the right option. So feel free to criticize what I'm going to talk about. Feel free also to reach out for whatever issue you can think of. Basically, we're very open about what we do. My background has been told, and I will focus on COVID-19 in just a moment, but I've been involved in many advisory boards and so on. And actually the way it all started is pretty funny in a way, but also not so funny. It's by a colleague of mine, Hermijn Goossens, and those working in antibiotic use and resistance on the European level, they would know the name, I think. Hermijn Goossens at the University of Antwerp. He was on television, and he said to the person on television, if you want to know when the peak will hit Belgium, basically, when the peak of the COVID-19 pandemic will hit, you have to ask Neil Hens. So I got a phone call from one of the ministers, then I got a phone call from the prime ministers, and then it never ended. Well, at least I feel it's a bit over today, but still, some things are still ongoing, and gladly so, actually. What is important indeed is that I'm now director of the Data Science Institute, so a lot of management responsibilities, but the core of the Data Science Institute is actually this data science cycle. And yes, you have many different versions of this on the internet, but this is the one we live up to, and it's maybe a bit small in writing, but let me go through it, because I think this is also the build-up of the presentation and also what we do is really resonates what's provided here in the data science cycle. So first of all, you need to know the problem and you need to understand the problem that you're facing. And there a lot of confusion is already taking place sometimes. So you need to contextualize what the problem is. You need to think about the wicked problem you're addressing. And then of course, and then we go to the second box on the right, then you need to get the information. You need to wrangle the data and so on. And typically we're okay with that, but we're really on the verge of what we can do in terms of all the information and exploiting the information that is out there. And then the box on the bottom right is modeling, exploring, and so on. And that's really, that has been our core business in the Center for Statistics. But when we mounted up to this Data Science Institute, that was really the asset, is putting this into this data science cycle. And then, of course, evaluate the models. And that is something that doesn't always happen. And that's also a difference, I feel, between statistics and sometimes the modeling community as a whole. Simulations are not always present in modeling work, whereas in statistics, this is kind of a default. And there's something to learn from there, I would say. And then the last part is, how do you disseminate all of this? How do you actually close the circle? Not only getting back to the data and indicating what data do we need to collect to do better, but also to policymakers. What do you need and how do you communicate to policymakers? And I think we have learned a lot during the COVID-19 pandemic, but there are still quite some steps to take, I would say. So I'll go through this, take you on that journey, and sorry for those who have heard some of the parts of this talk before, but I'll try to kind of go fluent through the first part, and then I'll give you some ideas for future endeavors, I would say. The overview you can see here. So yeah, I'll start with a brief introduction. I'll start also and indicate epidemic phases, and this is really ongoing work. Then I'll talk about an ecosystem of models that we've been developing. And then, yeah, the focus of understanding. And understanding, as I said, towards the design of new studies, for instance, but also towards policymakers. And then on some current projects, and some of that will tie in with what you're doing. And then, of course, also I'll talk a little bit about the ESCAPE project, which is the follow-up of the EpiPost project that I'm coordinating and collaborating with many different people. And we'll have outreach events and so on. There have been outreach events already, and we will continue to do so to unite this modeling community in Europe and beyond. This is something you all know, I think. The basis of mathematical modeling is attributed to Daniel Bernoulli's work. What I like about that is that it also stresses that what we're doing today in terms of scenario modeling and so on is something that Daniel Bernoulli already looked at that time from the first days. On the right-hand side, you see a picture from the book of Matt Keeling and Pesh Rouhani. For me, that's a very nice picture to explain to people that mathematically we can do fancy things. And we can model infectious diseases to a great complexity, I would say. And we can, and you saw it yesterday, people are extending. That's not the big issue, I think. The big issue is matching the mathematics with the data and translating data to mathematical models and vice versa. That is, for me, the issue. And sometimes people put the modeling as such as a mathematical problem and then inferring the parameters from data as a statistical problem. Well, I don't think it's clear-cut. I also don't like the fact that some people say statisticians are not mathematicians and vice versa. I think I have a background in pure maths, by the way, so guilty as charged. But I think that background actually helps me still today about thinking about concepts rather than parameter estimation as such. And then I think, the term mathematical epidemiology is one of the terms used for our discipline. And the goals are quite clear, I think. It's to improve our understanding of disease transmission, forecasting and scenario modeling, and I think these two are very different in nature. Sometimes we actually use forecasting for scenario modeling, but then the discussion is actually hampered a little bit because if we develop models, mathematical models, and we look 2 months ahead, that's not really forecasting. That is what happens if all the conditions are still maintained. Then you're actually asking yourself the question, what will happen in the next 4 months? But in a pandemic, things will change, and we've seen that. And therefore, whatever you call a forecast will not be happening as such. Now, there is some subtlety in there, because there is a transition period where you go from forecasting to scenario modeling as such. I will not go into detail too much about that, but I think we need to make that clearer, because people have, the general public actually has a wrong perception about these models, as do quite a few politicians, I would say, honestly. The data-driven side of this, data is really key. At the same time, data are always undergoing issues. I mean, in terms of complexity, the data problems are really not so easy to deal with. And we do fairly well, actually, with the data that we have, but we can still improve quite a bit. And in 2019, I co-edited a book with Leonard Held, Jaco Wallinga, and Philip O'Neill. And we had many different contributions from people all around the globe, where we actually asked people to contribute one of their latest data endeavors, let's say. I had a part on serological data. It's not a big surprise, maybe. But still, the things that were kind of picked up in that book are still very relevant today, and they were very relevant during the pandemic as well. And I think we need more of that, maybe books that actually summarize these things, new contributions and so on, related to the data. The key thing, validation, I'll come back to that as well, is a very important aspect. But let's get going on the epidemic phases first. Now, this is work in construction. It's not, I'm always in doubt where to put some of these things, because you could put everything everywhere, but let's go through this. And it's a bit small, but in the columns, you see the different phases of a pandemic. You know. In the rows, you see models, data, and management and policy. And this is just a brief recap of what data do you need at what time, and what can you do with that. And you can do much more with that, but I've kept it very brief here. But this gives you an idea about what are the data needs at which moment in time, and we need to develop this further as a discipline. This is for SARS-CoV-2 or respiratory viruses, but we need to think about, is this realistic for other viruses and so on, or bacteria and so on. But it gives you an idea that every phase of a pandemic, an epidemic, needs different information. And it's kind of cumulative as well, because the data that we need at first instance is also the data that we need a few months later. Maybe we often don't think about that, but generation intervals or serial intervals, and then translating them to generation intervals using the incubation period, that's something that was critical at the first step in a pandemic, to know what the proportion of pre-symptomatic transmission was, for instance. But it has been critical when Omicron came about, because the generation interval for Omicron is shorter than for the other variants that we've seen before. So, and that changed the game, let's say. And that's something that we need to think about when we're dealing with a pandemic. A new variant comes along, we need to ask the basic questions again, all over. Actually, a new variant is somehow a new pandemic happening in a way. So I think this is useful. I think we need to expand this. Love to have input on this one. I think we need to really come up with a big table there with realistic goals as well. There has been a huge genomic data collection effort. And the question you can pose today is, the money that goes into that, is that well spent? Did it really have to be that big of an effort? Question mark. Well, stay tuned. There is a paper coming out by Emma Hotcroft and colleagues about that. So how it all started for us was a visit to Jaco Wallinga in Leiden. We were collaborating on a project on epidemic trees. And actually, we were estimating the generation interval from symptom onset data at that time. We were dealing with bubonic plague at that moment. no SARS-CoV-2, but when visiting Yako at the end of January 2020, we switched gears quite quickly, and we actually got some very good data from China and from Singapore, and we could actually work on estimating the generation interval. Yako, Jantien, and others have actually already worked on the incubation period at that time, and that information we could gladly use in the estimation of the generation interval, which as such is a topic you can also have a whole lecture about, I would say. There are many intrinsicies there that I will not go into this right now, but the key thing is that if you can estimate the generation interval and if you can estimate your incubation period, you have a good estimate of the proportion of pre-symptomatic transmission. And that's exactly what was shown in this diagram by Christoph Fraser and colleagues in 2004. Factors that make an infectious disease outbreak controllable. You can change that title, and you can actually go for a title, Factors that make an infectious disease outbreak uncontrollable. And if you know that it's not to be controlled by simply isolating symptomatic individuals and so on, of course you need to do something else. And that something else, that something else is no regret measures. I've put no regret measures between quotes. No regret because I think some options we've taken are not the right options at that time. Although I'm quite mild for policymakers as well because the evidence was very thin at that moment. But for instance, what we've done in Belgium is we closed the schools. And actually the way that went was because basically in France, schools were closed. The southern part of Belgium looks at France. That comes into the political debate. So the schools in Belgium were closed, and actually the Netherlands experienced something very similar. But we shouldn't have closed schools at that first instance. There was a little bit of evidence in that direction, data from Southeast Asia and so on, from the Diamond Princess, that you can actually use to really advocate not closing schools. We had a lot of trouble reopening them because the priorities were set differently by the policymakers. So in that sense, yeah, no regret measures. You have to take them, and yes, you will make mistakes. But the key question I think we should be better prepared for is what are the implications after, and how do you actually unlock your society again, and what is the order to take? That are things that we really have to delve into deeper. But we have a lot of data now for SARS-CoV-2, but we don't have the right data all the time. And also that is something that we have to be concerned about is, can we set up surveillance systems to collect the right data for the next pandemic? And now I'm also talking about mental health and so on and so on. So there are other factors at play that really have to come on board. So what did we do as a group? And in Belgium, there are not too many modelers, which is a good thing and a bad thing. The good thing is that I think we have some experience. The bad thing is that the responsibility is, of course, all directed to you, to your group doing this. But fortunately, I have a great team. Together with Philippe, we're leading this inter-university research group. It's very informal, but because we don't want paperwork, basically. The CIMID consortium has grown from 4 people nowadays to about 30, 35, depends on how you count. And we're also attached to bigger institutes. So we have the Infectious, which is a vaccine and infectious disease institute, where we now have a Vaccinopolis, for instance, where vaccine trials are actually run. And on the other side, we have the Center for Statistics and the Data Science Institute that then brings in the statistical expertise. Now, in terms of models, what we developed right away were short-term prediction models. And then my colleague Crystal Faas has done the greatest deal of that work. Crystal is an expert in spatial temporal modeling, not particularly in infectious diseases, much broader than that. And then the other models that we developed were mathematical models and tools. And first of all, a metapopulation model. That's a model that we already were, that was ready basically. We did apply it already for influenza in Belgium. We were actually adapting this to France in collaboration with Vittoria Colizza. Yeah, we tried to actually get that model working for Belgium. Well, it didn't work, I can tell you, it didn't work. We were a bit stubborn, and finally we do have a publication from that meta-population model. But the fact that it didn't work, it worked in China, but that's kind of easy. You go in complete lockdown, so you actually isolate a patch within that meta-population model, and therefore it works. But when connectivity is still there, a meta-population model is not always easy to fit in a generalized epidemic like SARS-CoV-2. I think that's the main reason why it didn't work. The other question that we're now posing is the resolution. At what level do you have to define your patches, for instance? So there are some developments still we're thinking about, because we think meta-population models are very useful, but at the same time, it didn't work for Belgium. And at that time, we also got feedback from Victoria, it didn't work for France. From Mark Jitt, it didn't work for the UK. So it's a commonality in terms of getting these meta-population models to run. It's also not so easy. It's computationally quite complex because of the mobility that you have to include. So yeah, we had another model on the shelf, let's say. We had an individual-based model, STRIDE. And STRIDE is a model that it's really a model that uses these contact data. We actually have contact data going into it, and we're actually comparing it with contact data, with the contact matrices, as you all know. So that is quite well developed and was actually the PhD of Lander Willem. And we've been building on that model for 2 decades, I think, almost. The idea of that model is really to be data-driven. And today, that model is still very much operational, and we're extending it. At that moment in time, we had that model ready for 3 million people. We scaled it up to 11 million, population of Belgium, simply for science communication. There's nothing in terms of thresholds and so on in terms of population size, but simply to make this a little bit more convincing, let's say. I'll come back to that very shortly about the results. And then we had a third model that was developed from scratch, a stochastic model, because the meta-population model actually didn't work. Victoria did the same thing, and that became what we call the Belgian reference model. So that was the model that anyone else had to fight to get attention from the Prime Minister, let's say. And there are pros and cons to that. But we developed that reference model, and we extended that reference model step by step. In the background, we were running next generation principles and so on. That was something that we did not communicate about. We're actually now in the process of writing it up and trying to translate that for the future. And then contact process models. And what I mean with contact process models is also at the very individual level, you're going to look at contact processes together also with infectiousness processes, actually. You put that all together, and yesterday we heard some talks going in the same direction, let's say, in terms of developments. And we use that to inform policy in schools, like looking at repeated testing and so on in schools. That didn't take place in Belgium. Well, at least there was one site where it did take place, and we did some further studies there. But in general, that did not take place because logistically that was not possible. But some other areas, countries have looked into that as well. On the right-hand side, you see that it's very important for model development to fit the model to data, validation, forecasting, and scenario modeling. And then the internal and external validation, and I'll shed a little bit of light on that. But I'll probably be too brief about these things in the interest of time. Maybe just one that I like very much is this cliquet diagram. This is a short-term prediction model that's behind it. It's very easy to understand. At least we've been able to explain it to policymakers, and they followed our reasoning. And on the y-axis, we have new hospitalizations daily growth. So you just basically model that with a count series model, statistical model, and then new hospitalizations on the x-axis. And then, of course, you can predict how many people will end up in ICU. And that worked very well. 2 weeks ahead, we could actually have very good estimates of the hospital capacity that was needed at that time. And each point is a different date with a different report. And if you go through that circle here, let's see, that one over here, that circle, it circles here from 15th of December to the 30th of January, and you're actually on a downward trend. What does that mean? That transmission is actually decreasing, and therefore fewer people end up in hospital. If you would be on the other side, if that would go up, then you're of course in trouble. Then hospital capacity will not be sufficient anymore. And actually the shaded areas over here, these reflect the different phases that hospitals used to make beds available or to reserve beds for COVID patients. This has been very useful, not only at the federal level, but also at a hospital-specific level. And one of the greatest feedback that we got from one of the hospitals in Charleroi was that, well, basically based on our modeling work, we predicted that they would need an additional 60 beds to fill with patients. There would be 60 patients coming in, with some uncertainty, of course. They actually indeed did foresee 60 beds. They had to fill 58 at a certain point outside intensive care, so with respirators and so on. So basically, if you're ever asked the question, can modeling save lives? Yes, it can. So that's one of the biggest compliments I say for this. In that paper here, we criticized the second wave. And I can tell stories about the second wave in Belgium. It's really a political mishap, I would say. Advisory boards were actually scrambled. There were people coming in from different stakeholders, let's say, not all with the right mindset, and that actually we learned some lessons from there. With the change of government in September, October in 2020, things changed. Our Minister of Education now, Frank van den Broeke, is also an academic. That helped, also asking very tough questions. But it really helped, actually, in terms of managing the pandemic as such. But the second wave in Belgium was way too high. We lost too many lives at that moment. The first wave, that's really because of introduction. That's the key asset, and then waiting a little bit too long to instate a lockdown. But the second wave we could have foreseen, and we did foresee it. And I can show you very briefly a graph of this. So let me run through the different models and just highlight one or two things per model. We know key player is age. So I have to say, I'll come back to the infection fatality rate because we've actually estimated that very early on in 2020. And the reason why we could estimate is because we went out and collected serological data. We were not waiting for our Public Health Institute to do that. We got an anonymous gift of a substantial amount. And when I say we, it's actually Pierre van Damme, my colleague in Antwerp. And the first thing we've done, we said, we need to collect serological data. We need to know what's going on. And that's why we had one of the first estimates of the infection fatality rate in the world, basically. And I'm not exaggerating. The problem is that Eurosurveillance took a bit longer to publish the paper, but the preprint was out very soon. So there's another complication there, I would say. But it was already published by Levin before we actually could publish it. So Levin, in the overview paper there, Belgium is one of those dots on that paper. And then, of course, we used Polymod and comics, and I don't have to introduce Polymod, I think. But it's indeed in my ERC grant that we started collecting social contact data. Also, the Polymod data were not readily available to everyone. And so typically Joël Mosson got an email saying, I want these data. And then Joël sent it to me, Neil, can you provide the data? And but that was not really a very good way of doing that, I think. And so the idea within the Consolidator grant was actually we first done a systematic review on all the social contact data out there. And then we started collecting these data, asking people to contribute their data in a format. We helped them providing the format. We decided on the format in a hackathon. Sebastian Funk's social mixer package actually tapped into that format as well, and so on. So all of that is really a collaborative effort, no strings attached, just bringing people together. Let's see what is smart to do and so on. And we actually, when people made their data available, we took no credit. We just said, okay, your data is now available. The original author list, you get your data handler to Zenodo, and you get a DOI for the fact that you're sharing your data now. Then, at the beginning of the pandemic, we said, well, that's one thing, getting these data, and they're on Zenodo. That's very useful, but a lot of people will not find these data, or they will have a difficult time getting to these data. So we developed an app, Socrates. And that app, you can actually load in your data, you can construct matrices and so on. So it's actually a visualization of what Social Mixer also can do. There are a few tweaks to that. But this was really useful. And as soon as this came live, the downloads of the data sets went way up, and I lost track, basically. But 3 months ahead, 10,000 downloads of just these social contact data. So that was enormous. We also, we looked at, so there are different tabs on this graph here, over here. And we also provided a little bit, based on the next generation principle, we actually provided people tools to investigate in a very rough way, let's say, how certain interventions would play out in terms of transmission and so on. And I think that was also very useful for people to work with. As everyone started, I think we all started with pre-pandemic contact data. We also did that for the 3 models I described earlier. And we start tweaking the parameters, school contacts to 0 and so on, ignoring compensation, because if children have to stay at home, then maybe grandparents will take care of the children and so on. Now, of course, if there is a lockdown and everyone has to stay home, that's not true. But all of that, we started to tweak the contributions of the social contact behavior by location and so on, by age. And that's how we implemented it in the model. That's, of course, a little bit, you need to know what you're doing, but still there is no validation in there. And that's why comics came in very handy, of course. Comics was set up in the UK, in the Netherlands and Belgium first, and then expanded, thanks to ECDC and the European Commission, to many more countries. And indeed, other countries like Germany, with Veronica and others, you actually started doing this as well. The questionnaires actually were also distributed worldwide. So in Canada, they use the questionnaires and so on, in Japan. So that's really nice to see. All the questionnaires were distributed. And so that was really work that primarily the London School led, with John Edmonds as work package leader there. And we were happy to contribute and facilitate from the Hasselt side. That's what we used in these models, and we started validating what we've done. Are these parameters the right parameters and so on? And that was really crucial, I think, at a certain point to investigate what would happen after. So, maybe just go back to the metapopulation model. I already indicated that story was kind of a failure and a success at the same time, acknowledging that metapopulation models don't always do the job, or at least the specific configuration that we had. But it's kind of reassuring that Mark and Vittoria found the same thing, basically. But lessons learned is that you should not go with one model only, of course. And this is put very strongly here. We're very glad with the individual-based model we had, very much data-driven by these contact data and demography and so on. And I don't know whether the concept of the household bubble crossed the border, but we try to think of how can you actually fight loneliness. First lockdown, imagine you're a 70-year-old person and you're living alone and all of a sudden everything is closed and you can't go out and so on. How do you cope with that? And we wanted to solve that to some extent. And then household bubbles, connecting to another household is something that from a network point of view sounds very logical as long as you do not mix all the households and so on. But that proved to be a very difficult thing to communicate, at least, honestly, for our politicians. They messed it up at that time. And that was summer of 2020. All of a sudden, our Prime Minister said, every individual has the right to see 15 persons per day. So on average, a Belgian contacts 16 persons a day, according to Polymath. So you're allowed to see 15 persons a day. So we're back to pre-pandemic setting then. And then, of course, yes, although it was a summer holiday, it did go wrong. The principle behind the bubbles is much more important, and there we have lessons to learn, I think, in terms of science communication. The principle is take your stable contacts and keep them stable. That's the essence there. And yeah, you can be a little bit creative on how you do that. Students that go to the university, spend their week there and going back home and so on, they need kind of this, the period where they don't meet anyone to see whether they haven't been infected and so on. So they need to have this safety period in there. That are all possible solutions, but I think sometimes we were not as creative as we could have been. We also had some contact tracing results there that were used eventually in how contact tracing was done in Belgium, at least in the retrospective way. But I think that was also very useful at that moment. So at a certain point, contact tracing could not follow anymore. What do you invest in? Do you trace a few individuals with all the contacts, or do you trace the index cases and then try to communicate to the contacts of those index cases? And the second option, based on this work, has been chosen, and that was the right option to choose. This is the reference model. This is how it looked like in 2020. We can have a few discussions about that, of course. This had 10 age categories. Some people said that's too much. In hindsight, yes, maybe we have overdone it a little bit, but it was really useful when vaccination came into play to have 10 age categories as such. We fitted the model to hospitalization data and deaths because those were very stable time series. And then at that time, that was April 2020, we already showed that, this second wave will actually happen. But then a lot of people did not look at that. And actually, we're not very eager on doing this, because this is way ahead in the future. But qualitatively, this is something you have to take on board. So gladly, this never made it to the public in terms of the profiles as such, because then they're going to say the peak will hit at that moment and it will be that high and so on. That's not the idea, but that the second wave will actually occur when in September schools reopen. There was no doubt about that actually. And it was, I can tell you the children were not really the cause as such, but it was really the adults that actually fired up the pandemic in October 2020, from 18 plus onwards, I have to say. And then we developed the model further. We first had an all or nothing vaccination in there. Then we went to a leaky vaccine approach. Step by step, we developed the model. And we did not maintain the other models anymore. Also Stride, the individual-based model, it was just computationally too complex to do and to adapt all the time, because that's really what you need to do here. You need to adapt. You need to calibrate to growth rates, cases, to genomic surveillance. The calibration was done to hospital admissions, load, and early serology, the serology that we collected thanks to that anonymous gift. And the forecasts were based on comics data, looking back at the validation as well as, again, tuning, of course, depending on the decisions that were made. Nevertheless, the information from comics actually went back into the model, and we got, I have to say, fairly good results, let's say, but on a short-term horizon. I don't have to explain you what comics is about. We're still working a lot on comics, and the data, the last data batch is not yet on Socrates, but it will be soon. A few issues with capacity at this moment, but I'll have two people working on that. And also, if you have data to share and you want to share it on socialcontactdata.org, we're going to refurbish the website as well, so that it's really a collaborative effort. Everyone can be on there basically, and get credit, of course, to what you're sharing. In the interest of time, I'm not going to talk too much about contact process models, but we've used that to study antivirals. That's for the future. It's together with Johan Nets, who is in Belgium one of the people that pushes for antivirals. And we looked at different exercises, what antivirals could do in closed communities and so on. All of that is based on one engine, the contact process model engine. of Andrea Torneri. We also used it as a school simulator, so controlling SARS-CoV-2 in schools using repetitive testing strategies. This is also what Vittoria Colizza has done some independent work related to that as well. So it was very nice to see that that's all in agreement, let's say. And then we've also been asked by our Minister of Health to look at the COVID-safe ticket. I actually wanted to stay away from that because I thought that debate was a little bit, going in the wrong direction. But actually, I think it's kind of interesting. So looking at events in isolation and whether or not vaccination should offer you a COVID-safe ticket, a green ticket, let's say. The answer is no. You should actually test everyone. If you really want to minimize transmission, you should test everyone. That's the bottom line, basically, and that's what also came out. The problem is a little bit that the CST has been used as a means to get people vaccinated. And we followed there the example of France, where this really was happening, let's say. But there are some difficulties when you're implementing this. And it's for sure also because the vaccine, it gives temporary protection against transmission as such, and not for everyone. So that's the key thing. That's the key issue, why it doesn't work to give a green pass based on a vaccination, whether or not people are vaccinated. Again, I'll not go into detail too much about that. We also done a first evaluation, looking very critical on the modeling work that we've done. This is too much to go through. Yes, we've been wrong, I think 2 times, and comics was extremely useful to understand what went wrong. One example is the drop after the second peak in November 2020 that stopped at a certain moment. People changed their behavior. Sooner than the measures were actually relaxed. And that's a lesson that we've learned there, that you need to take that behavioral component very serious in the modeling work. And it's kind of natural. Everyone says it's over, we're past the peak, we're going down and so on, so people feel relieved and they go and mix again and so on. And that's what we've seen. And that's something we did not anticipate at that moment. And I think the other one that, the alpha wave, the higher burden, I gave a press conference with the Prime Minister at that time. I think what went wrong there was that some politicians started to take this as a strategy. We had a few lines, and there was one of the politicians, I will not call names today, that said, we're going to follow that strategy. We wanted to follow that line, and that went wrong, big time. And one of the reasons was because the information on the higher burden of alpha at that time, there was a little bit of higher burden of alpha, nothing compared to delta, but still, that actually came through only quite late. So the UK was leading the dance in those estimates and so on, and so we also used that. And then we had to actually implement an Easter pause, as it is called. We're lengthening the Easter holiday as well in 2021. But all in all, I think we've done a fairly good job, like in hindsight at least. But it wasn't easy, not at all. And I think what could have made our work much better is having serological data throughout the whole pandemic, because we only had few waves in 2020, nothing in 2021. So we had to propagate what we learned from 2020 to 2021 to 2022. And still, at each moment, we were knocking on Cienzano's door to collect new serological data and so on. We were not on the same page at that time. We're on a better conversation right now. Until last year, that was the last moment that we've done something related to that in terms of advising for boosters or not. And actually everything turned out to be much better than we anticipated, so that's really good news. And also even today, it's way better than we would anticipate it. And the main reason for that is the immunity landscape has become much more complicated. We don't understand it as much anymore, I think, honestly, but it's pretty high. And that is actually helping us right now. That's why we're in safe waters for the moment, I would say. That understanding, that's crucial. and we don't always have the good data for it, and certainly now when the critical phase is somewhat over, you know, investments are dropping, surveillance is going in a different direction. The surveillance is certainly not in terms of coverage as broad anymore as it used to be. Still, we can do very useful things. And one of the things that we're now doing retrospectively is looking at the next generation approach. And we've been using that, first of all, to unravel age-dependent susceptibility and infectiousness. The problem is that you have an identifiability issue. I will not go into the details now, but that identifiability issue, it seems that the results are fairly robust against that identifiability issue. So that's kind of a lifesaver there. And we use those estimates. Also, other people have used those estimates, and it's still quite consistent with the data as they observed it in different countries as well. So this was based on work in Belgium. And this is actually something that is just submitted. The idea here of this next generation approach is actually the following. Let me very briefly explain. We have a reproduction number. We have measures of sensitivity, so the sensitivity as such, which is actually expresses if you have a certain age group and you start to perturb that age group in terms of its contribution to transmission, will that have an impact on the reproduction number, yes or no? Yeah, that's the question that you're trying to answer with the sensitivity measure. And how big will that impact be? That is elasticity. So these are mathematical concepts. The basic paper has been published in Theoretical Biology. Of course, it hinges on the contributions that were on the previous slide. But the idea is that, like, for instance, these three plots, on the x-axis you have sensitivity, on the y-axis you have elasticity. These different bullets here are the different age groups. So, for instance, children from 0 to up into 18 years, these are 3 dots over here, they have a very low sensitivity and a very low elasticity. So don't bother. They're safe. You can actually relax things there if you want. That's actually, and this was indeed, at the start of the pandemic, this was really what's going on. Who are the ones that were actually, responsible? That's the wrong word. But who are the ones that were transmitting most, let's say? That's the 18 to 30-year-olds. And when you look at this period over here, this was the period when schools actually were in place. And there, children, all of a sudden, children were the drivers. And that was a moment where vaccination was already widespread to a large extent. But the only ones that were not vaccinated were the children. So it's also not a surprise that the children as such were at that moment, they were the drivers. There were 3 moments in Belgium where children were the drivers. And that's not to point fingers, but that's something that you have to take into account. And when people say you have to keep schools open as much as possible, we actually had a kind of a negative experience in Belgium. We were negotiating almost, indeed, at certain points with the Minister of Education, saying, this is what is happening if you now do not intervene in schools, and we had solutions in place. If you do not intervene in schools, what will happen now is the children will all get infected. They will actually infect their teachers. Teachers will stay home, and you will have to close the schools anyway. 2 weeks later, exactly that happened. So they did not follow, and that's their right. I mean, you give advice, they decide. And then afterwards, actually, this was really what happened. Teachers had to stay home, schools were closed. And you get the same detrimental effect if you would have closed the schools or have half-term education and distance education and so on. So lessons learned with this technique, and we hope to actually make it into a science communication. We hope to make it into a tool that people can actually use. We still have some steps to take because this is mathematically a little bit more involved, but I think we can get there. But more details, if you're interested, feel free to drop me an email. Let me wrap up because time is progressing, but we are also looking at AI and disease modeling right now, not machine learning, not predictions. I don't like that too much. The neat thing about infectious diseases is that you have mechanistic reasonings behind it. They work very well, even if the data are sometimes a little bit biased and so on. And yesterday, the discussion about the contact data, even they're biased, but still they're so useful, even when they are biased as such. And no, this is about reinforcement learning and learning policies through reinforcement learning. And this is also about presenting people with Pareto fronts so that they have some options. And you can actually have different trade-off, multi-objective optimization through reinforcement learnings or multi-arm bandits and so on, so more the AI tools that you can use. And you can actually present options to politicians, saying if you're more in that direction, then these are the options you can choose from. But be transparent about it. And that could actually help them. And this is now what we're now having the dialogue with them to see whether they are actually eager to follow this. And it's actually not the politicians themselves we have the dialogue with, it's the people of the federal institutes that we have the discussions with. And they're very eager to bring this on board, this multi-objective optimization. I promised to talk a little bit about how you can actually inform data collections with mathematical models. In a nutshell, I think we're not, it used to be the case that serological surveys were done and carried and we said oversampling children and then we're happy. No, it goes a little bit beyond that. Depending on what parameter you're interested in, using a mathematical model, and it could be a very simple one, but using a mathematical model could actually give you a little bit more direction of which age categories to test, how many tests to be taken, and so on. And yes, we got €500,000 for the serology, for 7 rounds of a substantial number of people to be tested. But actually, we made it worthwhile by doing this, and this was developed before the pandemic, saying, given that we want to know the prevalence in a certain age group, we're going to sample the right number of people in that age group. Given we want to know the force of infection in a certain age group, we're going to sample a different number of people in that age group. And that is something that, and these are simple mathematical models, but you can actually think about the bigger mathematical models also to inform your design. We're not doing that enough, I would say. There was an epidemics conference, not this one, the one before, where Mark Lipschutz and I, at the same point, we did a review and they did a viewpoint on we need to do this much more. And Mark has put this into his research very much, and we've been doing that a bit. Mark, all credit to Mark, he has done a great deal of work related to that, and it really actually saves a lot of money, and it informs good data collections. And if you want to know more, you can read this paper. I can send it to you. But we can really be smarter about the data that we're collecting. This is an example of hepatitis E. I had a colleague in Antwerp said, I want to test for hepatitis E. You still have some serological samples in your freezer. Yes, okay, what do you want to know? Well, this is the perfect design for the money you have to do that. And that's actually, we have a new discussion, ongoing discussion for hepatitis B at this moment. But we also done that, and this is the paper in Eurosurveillance, but for the serological data in Belgium as such. Let me really move to the end now. This is just an overview of current projects. Let me highlight maybe one or two. The contact behavior, because a lot of people are here are looking at contact behavior. Please reach out. If you want something, you can get it. If you want to help maintaining the socialcontactdata.org website, or you want to give it some new life, yes, please. We've published a paper in JASA on households and representativeness of households. So yesterday was a discussion about that. Teaming up 2 samples, one which is biased and one which is representative, you can actually connect them statistically. You can rectify the bias by having this representative sample. With, still, there are some assumptions that you're making, but the assumptions are not too bad. So there are options for a biased sample to be rectified as long as you have a kind of a marginal representative sample to rectify it for. And I think that was a really nice work together also with Pavel Krivitsky. We're looking at repetition and clustering in contacts, and yes, we're looking at frailty. This There's this first publication by Jan Tien Bakker. I was involved in as well. But we have done the similar study in Belgium. It was postponed because of the pandemic, but we now have the data and we will actually share this as soon as possible, also via Zenodo and Socrates as such. And then maybe the other things you can read, and I'm happy to share the slides if people are interested as well. The last thing, Escape Consortium, different partners, different, of course, different objectives. I just want to go quickly through the following. So we want to have a blueprint development, science-based blueprint development. We want to indicate what data to collect, what tools can be used according to these epidemic phases. We really need to advance there, I think. And then the key thing, I think this is one of the most interesting and crucial work packages. What do we call success when managing a pandemic? What is success? Keeping our hospitals at bay? Is that a success? I think we can be a bit more ambitious. Yeah. So that is certainly something that we have to look into, we have to discuss. And of course, this needs to be a discussion with all the stakeholders involved. And then the last thing, and that's a very difficult one, creating an intelligent community. And that's not going out in the public and saying to whatever person you meet on the street, saying, this is what is happening. No, you need the person in the middle, the science journalists, the policy makers, and these connections that we're currently shaping them. So be tuned. You'll likely get an email asking with whom you have been in contact in terms of science journalists, and we're trying to make this a European story, really. So to see what are good practices in terms of science communication and building these trustworthy relationship with science journalists. That at least if they know that somebody is saying something, that they have this trusted source that they can consult and say, hey, do you agree and why do you disagree, for instance? I think that is crucial in a crisis. Then I'd like to end with a take-home. This is a paper that we wrote. This is kind of the closure of EpiPose and the start of Escape. So Mark Jitt leading the work in health affairs. So let me just highlight. Modeling definitely has given us insights. And yes, we can apply that in future health crises. We need infrastructure. Yeah, we need support for modeling, infrastructure for data collection, sharing systems, model development, collaboration between groups. I mean, it's kind of a no-brainer to say this in this audience. MONID needs to be supported further, and we need that for all the different countries, and then also to connect between countries and so on. The many connections that I had before the pandemic actually returned to be very instrumental at different phases during the pandemic, just by writing a quick email to someone in Japan asking, hey, this serological study that was published on Japan, is that the true thing? It's crap. Send. Okay, trust. You know that that person is not going to cut. I mean, yeah, you know from just that simple sentence, I'm not going to look at it anymore and I'm going to go forward. I have many things to do, but at least that is clarified. And I think that is really crucial. I'll stop with this one, and thank you for your attention.
Yeah, thank you very much for the fantastic talk. I think the importance of data cannot be stressed anymore, and thank you all also for structuring the whole process of data collection, data analysis, then informing models and going back to the data for understanding the outcomes of models, for understanding what went wrong and what worked pretty well. And I think there are a lot of questions, I'm sure. So
I think so, for this very, very nice talk. Also, especially the results about school children are, I think, very interesting. So you showed that in November 2020, the contribution from children was relatively small compared to the contribution from other age groups. Can this also, so you would say one should therefore not close schools on the one hand, On the other hand, could it be that they also were more diligent in the mitigation measures? Were there masks or other measures in place, testing or masks at the schools, that they very systematically helped to reduce infections, whereas maybe at workplaces that was less so implemented?
Yeah, and the experience in Belgium is that the prevention at workplaces and so on was well done. It was really well monitored, it was well put in place and so on. There was much more diversity in how control was managed in schools. And that was really, it was also regional differences and so on. So I would say the masks is a difficult question. How do you measure that mask wearing is really effective or not? We didn't have the studies to back it up. We did see a few indications when we monitored incidents in school-aged children at certain localities, for instance, that mask wearing was helpful. Yeah, I think the main reason why children were not the drivers at that moment is because the older population was still quite susceptible at that time, even after the second wave. And that changed in 2021, where then the children came up as being more the drivers at different instances.
I've also a question for children about schools. So our experience was that in maybe Easter 21, they were much more tested, and therefore the dark figure was much smaller for children than for adults. And at that time, I think their influence was overestimated because they were just better tested. Is this also your experience? Or?
No, this is something that we were worried about at a certain point, but it was not like our testing strategy really changed from one day to the other, let's say. On top of that, we've also done sensitivity analyses where we try to correct for that and then see whether that changed our sensitivity indicators, and that was not true. So we feel that our results are pretty robust and it was not impacted by testing. But it's also, yeah, it's always something that you need to follow up on. I think the method that we're trying to develop seems it's quite robust against certain items, but I think this context is really very important, and that's why we are kind of struggling to get the method out, because that contextualization needs to be there as well, indeed, in relation to efforts that have been taking place in schools, for instance.
Thank you very much for a nice talk. I have just another comment about children and schools. So it is more about changing a couple of numbers in the contact matrix, because people are very protective of their children and very emotional about this topic. And actually, for example, in Hungary, the schools were closed due to the overwhelming public pressure. So there was no really option not to close them. And this is such an issue can generate so huge waves in society that can easily undermine your whole pandemic strategy, independently of what the models show, what changing the contact matrices. And another comment, quick comment on what is success. So for politicians, success is keeping their popularity and stay in power. And this is just something to keep in mind when in an advisory role. So to understand what they consider success can be something very different what you would consider success.
Of course, yes. For the second point, point well taken. We realize that very much. For the first point, we really wanted to touch upon the role of children, not because of the sensitive issues around it, but really just, and not pointing fingers to children, let that be clear. But we need to be honest in the way we communicate. And if there are societal values that we need to bring onto the table, like saying children have to go to school, that's our priority number one, I'm fine with that. It's not up to me to make that decision, but it's up to me to be very clear about the epidemiological impact of different groups. And so I think, and that's where we make the bridge to multi-objective optimization. If you value that children, regardless, have to go to school, then if that is your constraint, then we have to work with that constraint. That's a political decision. That's not my decision. I can have my personal idea about that, with 3 daughters. I don't have to say more, but I think we need to separate that. And what I felt during the pandemic was that there was this yes-no kind of debate. Schools open or not, that's it. There was no other debate. I think we can be smarter. I mean, in Belgium, we have quite a few schools that can do remote teaching very well, very well. People of higher socioeconomic standards and so on, they cope with that to a large extent, not everyone, let that be clear. But if you go to other regions of the country, don't do that. Don't go there. They need to come in person. And these are these vulnerable groups that we need to take into account when we're making our decisions. And that hasn't been done throughout the pandemic. And for political reasons, it's best to have a uniform set of rules, let's say. But the question to me, is that the smartest way of dealing with this? It's a very difficult debate as such, but we have to have that debate, I think. And I feel we didn't have the time to do that during the pandemic, or this was rushed and people were very emotional about everything, and then they started to distort the evidence, the epidemiological evidence as well as the other evidence that was out there. How many times did we hear in 2020 that the number of suicides went up? We heard it a lot, on the contrary. So, and you don't, and let that be clear, you don't have to underestimate what this pandemic caused, let that be clear. But I think this needs to be a good debate, a debate with the right numbers and so on. And we didn't have the right numbers during the pandemic, so let's make sure that next time around we do have the right numbers, that at least we can make informed decisions about these type of things.
Thanks, Neil. I have a question not about children. Thanks for this masterclass of what can be done. If you have the resources in place, both in terms of existing models that you then recycled, and in terms of brain power, unfortunately not many countries in the world have, either. So if you were in a situation of a country that doesn't have those resources, where do we need to place our bets? I know you're going to say, in both directions, but if you had to prioritize, would you prefer to have a situation where you have the expertise of modeling, but hardly any kind of off-the-shelf models, or where you don't have that modeling expertise, but an international community that has off-the-shelf models that are ready to use by, not quite so expertly modelers?
A very good question, Stefan. Not having the models shouldn't be an option in the future, because we should actually provide the models to the community, regardless of where they are. We had very good collaborations with people in South Africa, in Cuba, in Spain. A lot of people asked for input. We didn't have the time to give input, and that's a shame. But nevertheless, one of the colleagues did not focus on Belgium or Europe, said, I'm going to solely focus on the people. We have quite a big network. We have many people in the South that we connect to. And we have quite a bit network about that, and we're sharing as much as possible. So that shouldn't be the problem. So the other point is that we need capacity and expertise to be built up. And that's capacity building, and that is going very slowly. Even in Europe, it's not well divided, I would say. So we need to actually, this is what we need to do at this moment. We need to educate, that sounds so negative. We need to collaborate with people so that they can bring up their expertise, and they don't need to be expert in everything. Within the EpiPost consortium, we had these scientific meetings, and at several instances, somebody said, hey, we're doing this. Oh, great, you're doing that. We don't have to do that anymore. And for certain topics, that's fine as it is. So we need to connect much more. And we need to, I think, we can leverage a lot from what was done, but the capacity building is the crucial component, I think. So we need to, we really need to go one step beyond, let's say. And I think the community that is now being built up in Germany, and it has been said yesterday as well, reach out to others. This is not a national thing. A pandemic is a global thing. So we need to learn from each other. And yeah, the open science, our models are, I mean, we will make them available as quickly as possible. And London School is also doing that, and others are also doing that. So, and that distinguishes the groups. There are several groups around there that have the expertise, but not all are really able to share, because there's also the opportunity to share. We're not being, I don't know whether a lot of people are being paid here to do science communication. Anyone? One person. That says it all. We need to invest in science communication. We need to invest in making models readily available. But in an academic trajectory, that doesn't always count, and we need to change that.
Maybe two short last questions, one from Julia.
Thanks a lot, and I mean the plea for the collaboration, I guess, goes very much in my side as well. I wanted to go back to the scenery of the different data needs and model needs that you need during an epidemic. And I actually want to sort of go further, and we've been thinking about that a lot, obviously. As you might know, there was the epidemic phases that was in the very beginning in H1N1 pandemic, and then we changed it that actually a pandemic does not, it's not one wave only, no? I mean, it's very granular in different parts of the pandemic. It hits very differently, and we need to take that into consideration as well. And actually even going further, that it's not only, there is also the baseline, not necessarily for a new virus but there are the other diseases that also need to be monitored, and how we can plug it in so that we are better prepared for these different needs of what we want to answer, the different data, and then the different models that come in place. So I mean, making that even larger, and there, I mean, I'm happy to link up with some earlier work that we did to try to sort of say what are the questions that we need to answer, what are the data that we need to answer, and I guess the next thing is what are the models that we need to put in there. Yeah. So I think that's a very
true. And this table just fitted one slide, but this is a table that will not fit one slide. I think, yeah, valid point, absolutely.
You've talked about science communication, and I'm wondering if you have thoughts about how we should express uncertainties to maybe people who are used to thinking of uncertainties as the same as errors, or say, oh, if the uncertainties are large, this is useless. Like, is there advice in general for communicating uncertainties?
Yeah. Very good question. Yeah, what stressed me the most sometimes is that we provided our curves to the Afspraak, which is a popular show on the Flemish television, I would say. Then they took the prediction line, but they didn't take the uncertainty into account. First of all, they need to show the whole thing. And actually, we turned that around and we left the prediction and we just gave uncertainty bands. That's one way of doing that. I think we first have to start communicating uncertainty, and then, only then, they will actually have the incentive to ask us what it means. So I think that's the first thing to do. And then explain it with a few toy examples, what uncertainty really is about and so on. We need boring science in newspapers, in media and so on. But media is that's not their market value. They want to have populist articles and so on. We have a few exceptions in Belgium, 2 newspapers that I'm more positive about, but we also have the newspapers that are underneath, I would say, but most people read those, unfortunately. So we need to get this on television. We need to communicate this much better. And in the meantime, because we also need to bring this into our educational system. That's the best way, but that takes too long, basically, maybe to really result. And think about climate. It's the same discussion, actually, but it goes slower, a little bit slower. Now it's speeding up. So, but first of all, get uncertainty out there.
Yeah, Neil, thank you very much again for the fantastic talk and also for your contributions to MONID as a member of the Scientific Advisory Board. And yeah.
Thank you very much. Thank you.
Yeah, okay, now we continue with the second oral session, moderated by Nele.
So I have the honor to chair the session of agent-based models. We have 6 great talks, focusing on different aspects. As we're quite a bit behind schedule, I ask all speakers to keep their time. So the first one was already highly advertised yesterday. It was from David Kerkman about the highly detailed agent-based model.
Das sind Sie nicht. Das sind Sie nicht. Kerkmann, ich hatte das PDF geschickt. Ach so, okay, das war das PDF. Okay. Ja, das ist das PDF. Okay, mal gucken, ob es jetzt. Das läuft, sieht man jetzt nicht hier, sieht man das so. Ja, geht. Okay, alles klar.
Okay, thank you very much for the introduction. So today I sent the slides via PDF, so that hopefully none of the formulas or anything gets messed up. So yeah, I'm also quite tall, but I'm not that good of a basketball player, but that's not that relevant here. So what is relevant is the implementation of the agent-based model that we develop, and I want to give some insights on what we do and what we focus on, and to show you what kind of things you can do with this model and how precise we can do stuff. So a short overview. First, I'll go again over the setup and focus a bit on the different things as compared to yesterday. And then I'll go into detail on 2 things. First of all, it's transmissions and infections. A second one would be the testing strategies and non-pharmaceutical interventions and in what detail you can implement them in the model. And then I'll go over some implementation, some initialization details and some details about the software and the hardware. So you've seen the slide yesterday, so just as a brief introduction, this is the basic structure of the agent-based model. So we have agents that can perform some decision-making, they have some properties assigned to them, and they can move freely, not really freely in the world. But there are these different lines here that connect the whole scheme, and we built that system up in a way that is highly modularized, meaning that this is not only an agent-based model that can be used for retrospective analysis of COVID-19, but it also should be used for future pandemics by just swapping out some of the modules. So for example, if you have a different pathogen, different infection, the idea is that you can swap out this infection model, and then you have you don't have to build a completely new model, you just have to plug in the correct infection model for that new pathogen, and you're good to go. The same can be said about the decision-making, so the behavior part of the model, how people move in the world, and also how policies and interventions are defined and how they act on the on the persons and on the locations. I want to go into a bit more detail now on the infection model. So one thing, okay, then the writing is a bit small maybe, but one thing that is very interesting to us is that we do not have only infections on a very coarse level and say, okay, you get infected, and now from this point on, or after some certain time, you are infectious and can infect other people with a certain probability, but we would like to take care of each individual and actually model their individual infection course. So to that extent, we have modeled the viral load that's actually active in the agents. So this is an overview of this, how this could look like. So in practice, this is actually a bit more stratified. So the variance is a lot higher than that. But this is what you normally see as a course of infection. And then from that, we can get the infection probability and the amount of shed, so virus emission that you get from the persons. So as a proxy for the viral load, you can see here on the bottom left the plot of the CN or ZT values compared to the actual amount of virus shed, and you can see there is quite a high variance in that. So one thing that also is very important to us is that you can introduce the aspect of super spreaders into your model. That was a very common theme where you have people that have a very high amount of total infectious shed during their infective period. So next thing is how we deal with testing strategies and non-pharmaceutical interventions. And I put a definition here of what we think a testing strategy should look like, and it's supposed to be a set of testing schemes that are very much specified in time, a testing method, and or in place, persons, and or other factors. And we really have a module here that can cope with basically any testing strategy that you can come up with. So these could be static or dynamic, meaning that some examples here would be all people that go to work between day 3 and 5 have to get tested with an antigen test, so we can easily implement that by setting that up. Or some people, you can set some proportion, for example, in the specific age group 5 to 15 will voluntarily get tested before going to events if they feel ill. So we don't only have forced testing, but also voluntary testing included. And also that, for example, that most people will get tested once an infection is detected to be able to move again in the, or to go outside. So this was the so-called Freitesten, right? So all of these things you have seen, and there are many more ways of including testing strategies that you can include in the model. And a similar thing is for non-pharmaceutical interventions. So since we have locations set up as individual items, so to say, where people can go to, we don't have to somehow estimate a contact reduction number or similar things that you have to do in ODE models or so, but you can do these on a very individual level. So if you say all schools require the usage of a mask, you can put that in the location and say you have to wear a mask there. Or other examples here is that the capacities of stores and restaurants are reduced by 50%. So that would mean you can directly implement that and say, okay, the actual amount of people that can go there reduces by 50%. And then you can see also what comes out of the model. So you don't have to inform about a specific parameter on how the contacts are reduced. And the third thing is that, for example, here individual workplaces are closed and remote work is active, so this is also something easily implemented. So for the initialization, I will go quickly over this. So we have a synthetic population for Brunswick here, so I originally planned to make some more details on Brunswick, but due to limited time, that will not be the case today. But we have some household distributions, this is very common, and some mapping of home, schools, and work locations to the persons. And also we have the daily activity, so the mobility of the people that are inside the city and the surrounding area to mimic the behavior part in terms of mobility. And then lastly, one important thing is the HPC thing. So our software is written in C++ mainly, and this is available open source on Memilio. You can find the link here. We had an open release of version 1.0 in December, and a couple of days version 1.1 was released, and everybody can actively participate or use our software. You can check this out on this link. And also, one important thing is that this is actually readily available to work on the HPC clusters. So what we use or commonly work on is the Eureka cluster in Jülich, which is a high computing cluster with 480 nodes that have each 128 physical cores and 256 logical cores, and we are able to perform these simulations in a highly parallelized way, both with OpenMP and MPI. And we can have some numbers here also. So for 250,000 agents, which is a city-scaled model, we can have a day simulated with 1 hour time steps in about 15 seconds, or 1 time step whenever you want to choose that in under 1 second. And to do a whole sample set of 128 runs only takes 32 minutes also as well. So we can have results rather quickly of also a whole simulation batch of the agent-based model. And with that, I want to thank you for your attention, and I'm open for questions.
So are there any questions?
You said that one goal is that you can easily substitute modules. And is there described interfaces? Would it be easy for somebody else to just download it, say I want to change that, and then he can just plug in his version of that module? Is it easy?
Still active? Yes, now it is. Okay, thank you. So this is the goal, yes. So a couple of things have to be added, but in general, the idea is that you have a couple of predefined sets of models. So for example, the infection model, you could have a couple of things that are common. And then if you want to add something else, you would just have to write a little bit of code that substitute that part, so that there will be an interface which gives you on what you need to define in order to have that, and then you should be able to plug that in.
Any other questions? Otherwise, I would just take the time to welcome Johannes Horn. He has a talk about modeling the impact of mass gathering events.
So, mein Name ist Johannes Horn. Ich arbeite momentan in OptimAgent. Ich habe früher auch an Impfmodellen gearbeitet. Heute will ich aber einen anderen Teil vorstellen meiner Arbeit, nämlich Restart, was Sie gestern Abend auch gehört haben. Es geht grundsätzlich darum, okay, ich rede auf Deutsch, Entschuldigung. I should speak in English, or? Sorry. Sorry. Completely confused. So now I want to present my work about the impact of mass gathering events and its effect on potential future pandemic. We have tried this model on a big arena in Leipzig. We have 3 different scenarios which indicate the density, how the people sit. For this, we measured with the contact tracers the number of contacts each individual has at average over the whole crowd, so both the distribution and the average number. In addition, we used a mathematical model for the aerosol to encounter for not proximity contacts but aerosol contacts, and also measure them also regarding the different densities. These information from the mass gathering events we put into an epidemiological model. We then used the model population for this, and then specified the other contact centers because we wanted to calculate the excess number of cases, not only in the event itself. And to make it also a bit more applicable, we also included testing, quarantine, and contact tracing. The basic model is a SRA model. We started there quite easily. Today I would make it more complicated because most people, at least a huge part, didn't die in hospital, but this was a simply escalating model. So there's only resistance or it's escalating. The complete course of the disease was separated according to the stages of asymptomatic, light, and severe. Anyone passes through all the stages, but only the most severe cases can be hospitalized, can go to ICU, and can die. The model population was the model population of Leipzig, separated in 5 years age groups. and these were put then into an agent-based model. The different type of contact settings were household, school, and work. For us, is school a type of work for children? Then the random, meaning any other leisure contacts, and the contacts themselves in the mass gathering event. So how did we define them? So each person is exactly in one household. The distribution was used from the Saxony for whole of Saxony. We so far didn't get it from Leipzig itself. The school and workplace settings, so anyone under the age of 60 was part in either a school or a workplace. And the number of contacts were applied from using from Polymod. In the school settings, we have, for simplicity, for every setting 0 to 9, from persons 0 to 19 age of years, is either in daycare or kindergarten or school. And each class consists of 20 children and 1 teacher. This was the first way to make it simple. It can be adapted much more complex. Workplace settings simply the same. Everyone is in exactly one workplace, and the sizes are given according to what we know from the whole of Germany. The other setting is simply according leisure. This is the only setting where we implemented the age dependency, which you can see also in Polymod. This is simply because there we have information. We have less information about households and workplaces. And also, if you're looking at Polymod itself, if you only look at the household and workplace contacts, you don't see so much the age dependency. It's really mainly in the other contacts. So we made it simply. So we practically used all contacts which are in Polymod and used the household, school, and work for the defined contacts we had in the model. All others were moved in the other transport leisure contacts because we didn't know how to differentiate between them, and the numbers weren't also that big. This is, as everyone knows, the age dependency, which is only applied to the random contacts in our model. And finally, we now have testing. Sorry, there's something missing. So there are 4 reasons in our model to be tested. Person showing symptoms, person is contact or positive case, so contact tracing. Person takes part in a mass event. This was at the start of the pandemic, so we assumed, like in our model event, everyone has to take a test, otherwise he cannot go to the mass event. And then finally, random testing. Generally, this is applied to the model, and a person cannot be tested either because he is not one in the 4 category, or simply the rates are too low. Quarantine at this time of the event, it was quite long. This was later changed in the model, but I start with the first one. The general thing what came after we implemented the model to our mind is that if you sum up all contacts over the whole population, then the number of contacts in the mass gathering events are quite small. Many people assumed they were much bigger. This wasn't the case, and also the excess cases were quite small, at least if we do not get to the amount of mass gathering events before the pandemic, and especially if the density in a scenario is also for pre-pandemic reasons, and also the assumption regarding the aerosols are less favorable. Only if at least 2 of them are true, only then it really is substantial. So future evaluation, we want to evaluate directly each test itself, how much detection is possible if under certain conditions I test a person, and also the overall strategy, and also we want to make the model bigger, so federal state, and in fact even whole Germany might be possible in the small settings, and also use other information about contacts. and maybe also include some new settings. So thank you. This is my presentation.
Let me start with one question. From your results, would you recommend not forbidding mass gathering events in a pandemic as long as workplaces and so on, schools and so on are still open?
I wouldn't recommend it because, as I said before, if you don't change anything, and especially with the large aerosol and really the density you have per pandemic, then you really have an impact.
Yeah.
But closing it completely, even without less persons and less density, is a bit, you're creating here much pressure where there's on other areas there isn't any pressure at all. And also another point, we didn't model it, but later also find out most contacts, and especially the not traceable, are not happening in the event itself, but either at check-in, check-out, or at the traffic to the event.
Yeah. Okay, thank you. Are there any other questions?
Sorry, do you have super spreading acknowledged in the model? Because that's one of the crucial components when you're looking at mass gatherings.
Yeah, yes, in theory, because we didn't have super spreading as person, but we have it indirectly over the aerosol. So it's not necessary via the aerosol that you're close to the person to get infected, and yes, this can happen.
Okay, one more question.
Did you consider different strains and how this might be affected, the spread of different strains for these large gathering events?
We didn't look directly into, we changed the R0 to look at different strains and also included then, of course, change the hospitalization rate to adapt for different strains. But the model itself is mainly to use against one strain and then adapt it to another one. Of course, it's not very computationally intensive, so you can do it on any laptop, despite the 600,000 person.
Okay, thank you very much. And now I welcome Johannes Ponge, how to make large-scale individual-based infectious disease models fast.
Perfect. Yeah, we like to keep things consistent, so my name is also Johannes. And yeah, we did have two very applied examples of agent-based modeling. I will provide a more methodological talk here. It's on how to make agent-based models fast, and ironically, I have to do this in 7 minutes. But I will give you some short overview what our context is. So I'm working in the Optim Agent project. You have heard of this project before, yesterday and today. And I'm in this part in the center here, in the sub-project that is actually building the simulation model. And you see that we have a very comprehensive population model of, well, ideally 80 million agents going into here. Pablo presented this yesterday in the talk here. We want to have behavioral adaptation included and put on top of this population. We want to have epidemiological characteristics, for example, on the basic immunity levels of the current situation in the population in our model. We will have contact parameterization, and we will use these results to inform policy making, and in the end, enable simulation-based evaluation of NPI effectiveness, and also with regards to economic, social, and health costs. So you see, with this complexity of this intended model and the size of it, runtime performance is a crucial problem. And, there are multiple things that you can do about runtime. You can reduce the calculations that you have to make to as few as possible. And the ones that you do after that, you could try to make them, well, calculate them concurrently. But there are some problems with this, and we will go into detail in this talk. So our basic model layout that we came up with in the OptimAgent project is this. It's basically a network, a big network, superimposed on the population. A node is an individual. A red node in this example would be an infectious individual, and one of these edges would be a contextualized contact, for example, a household contact or a workplace contact, which is not necessarily an infection, but people could have transmissions on these routes. And one way to reduce, well, calculations necessary is to use discrete event simulation. So what you can do is you have a queue of things that will happen next here, and they do have an attached time step when this will happen. Here, time step 1. And what you then do is you just work on this list and you process the first event, infect individual 9, and then generate what will happen next based on this event that you just processed. So the new event might be individual 9 will infect individual 5 at time point 3, and eventually will recover after a week, if this is days, so at time point 10. You take these things and then you enqueue them again, and then you work on the next event, do this the same way as before. So this is very efficient because you only simulate infectious individuals and nothing else. And the problem is, well, it's hard to parallelize. You cannot do this concurrently because there is a chronological order to this list. So you cannot calculate multiple of these things at the same time. One way of still doing this in a discrete event simulation is you segment the model geographically. So you have multiple regions that you can calculate concurrently. You give each of these segments its own event queue, like this. And if, to not have one section of the model run off too fast, you just process things in a safe time window, which means you could, for example, take the incubation time as a slack and say, if the incubation time of your pathogen is like 2 days, you try to synchronize a 2-day time window in all these model sections. And you exchange events through messages. So if you should infect a person in a different section of the model, you send them this event. Well, this is, parallelization with very few to non-conflicts as you wait for each other. The problem is the load balancing might be difficult. If these regions, for example, were German states and you had an outbreak in Bavaria and no infections in any other state, then all of these other things, there's nothing happening. We're still processing all the events just in one part of the model. A way that we came up with is the active settings approach, which we call it like that. So we segment the model in a more vertical way here. And what we do is we partition the model by setting: households, workplaces, schools, and we mark the settings that could have an infection as active, which is the household, well, over here, no, here. This is an active household, this is an active school. This leads to very good load balancing, but it induces assumptions about the models. We can calculate all these households at the same time. We can calculate all the schools at the same time because we assume that nobody is in the same school at the same time, in 2 schools at the same time. Nobody's in 2 households at the same time. And we can calculate what happens in the household in 1 day, concurrently. It doesn't matter if we calculate household 1 first or household 2 first, because there is no interdependency. But yeah, it induces this assumption about the model that we do have this kind of partitioning. So what we did is we developed evaluation criteria to compare these different approaches. We talked about load balancing and model flexibility today. There are also some other criteria here, and we came up with a grading scheme from 1 point. This is a non-acceptable loss compared to a non-parallel implementation to, well, there's little to no loss if we apply this parallelization scheme. And the results are this. You see that we have the first approach that I talked about in the top row and the last approach in the last row. We actually came up with 2 more of these ideas. And we found out, well, no strategy does it all. There are always trade-offs. But we think the second one that I just presented has at least no non-acceptable rating in any of these categories. And also some first implementation results show that, well, with an example of 5 million individuals, we can do this in 15 seconds, simulating 4 months of a disease spread, which I think works quite well in a very simple model. The more complex the model gets, it will take longer. So I'm cheating a bit. I will leave this on while I'm taking your questions. If you take anything home from this talk today, it would be the conclusion that we draw from this paper is design a model to be fast, not build a model and then making it fast. Thanks.
Yeah, thank you very much for this very, very nice design talk. For the load balancing, have you just considered the load balancing as it was by design or also dynamic load balancing?
Well, we don't send loads across the cores, if that is what you mean.
I mean, so you recognize there are 2 cores idling and
yes.
1 core handling too much? And
yes, right.
Okay, thank you.
Another question?
Yeah, thank you. If you parallelize by activity type, does that not mean that in terms of speed up, you're stuck by the number of activity times? So essentially, you can never be faster than a factor of about 8, even if you have a computer with 1,000 CPUs?
Well, what we do not do is have 1 core work on all the workplaces and have 1 core work on all the households, but what we actually do is we have all the cores working on all the households, and then all the cores working on all the workplaces and then working on all the schools. So the parallelization is across one of the types of the settings. So 100 cores could calculate 100 households at the same time, because we assume no people are moving between households in one time step. And then we calculate all the workplaces, then we calculate all the schools. Then we move on to the next step, and then we do the same thing again.
Okay, I don't see any urgent questions, so thank you very much.
Thank you.
And now we come to Franciscus Krakowski with a post-hoc analysis of COVID-19 mortality in Poland.
Okay. Good morning. Thank you very much for invitation. I would like to tell you a little bit about our model, which is one of the large-scale agent-based models implemented at the very first stage of the epidemic in Poland. We have a full representation of 38 million agents in the model, and it is one of not numerous georeferenced model covering entire territory of Poland. We have all the needed features in the model, and the model was running operationally together with Kruger's model for the Polish Ministry of Health and Polish Prime Minister. We were in the advisory boards, getting quite hardly to the awareness of the politicians that those models could be helpful. So this is a big story, a big adventure that is behind us. The model is synchronized with GIS software, and we can look into a detailed structure of households, seeing even the people who are in the household. We even gave them the fake names just to treat it more personally than just the numbers. Of course, in the model, we have all the features that were mentioned here during this conference. So we have age, gender, we have geographical position, we have assignment to the contexts, so we have school, workplaces, means of transportations, universities, and so on. Those are contexts or the settings where the transmission occurs. the model accumulates the whole history of the immunity of each agent. So it accumulates the infection of the first, second, third variant, and of course the fact of vaccination. And in order to handle the infection probability in the later phases of the epidemic, we have a waning immunity function implemented, and of course the cross-immunity, which is responsible for protection for the other strains. So now I am inviting you to the movie, which is the movie from our concatenated simulations and forecasts, which were published and were passed to our government. And what we see here, we see 3 panels, which the left is showing the new cases, the real cases, not the confirmed one. So, you know, together with the dark figure, the one in the middle is showing the need for hospitalization beds, and the one on the right, COVID-19 related deaths, as it is computed, shown by the model. But the model the movie is composed of the most accurate pieces of the forecasts that were produced during those 2 years of the fight against the pandemic. So let's see what's happening. We start in March 2020, and we do not experience any serious, how to stop the movie? No, so I want to stop the movie at certain points, and it worked yesterday. Let me try, because this is crucial for the, or I'll try to speak fast. Okay, so we are experiencing in the spring no wave. We are reaching the autumn of 2020, unfortunately very deadly, and then it was slashed by the lockdown. Then we are seeing the alpha wave, and we are waiting for the delta wave, which is coming in a different situation, because many of the people are already vaccinated, and it's followed by Omicron wave. And we see that the conversion rate between the number of infected people onto hospital beds and deaths changes along the pandemic. Okay, so this is the overall picture, and I would like you to show you some insight, very quantitative insight, one of the insights that we have on the entire course of epidemic. And I'm struck by the fact that no many people are saying the story of the epidemic from this perspective. So I'm dividing the whole COVID-19 epidemic into 3 phases. One is before vaccination. There is, after that, a very rapid process of vaccination. And in most countries, we reach a vaccination plateau, where there is no additional portion of population willing to be vaccinated. And in different countries, the levels of vaccinations were different. And in Poland, the numbers of excess death were the following. So in the most deadly wave, the first one, we experienced 70,000 deaths. It was followed by the alpha wave with 50,000 deaths, and those waves happened in the situation where there were no vaccination, no protection of the community. And next we have a Delta and Omicron waves, which were quite huge, but with the lower number of deaths. And this is a scheme of the possible ways of paths that could be made by different regions of different countries during the epidemic. So the bottom line, which is called O, which stands for the optimal one, is that we are keeping the immunization of the population low, low, low. We are waiting for the vaccine. We are doing the vaccination process, and then we release all measures, letting the population to be infected and going up with immunization to the 100%. The one marked with the number, with the letter C as the catastrophic one is the permitting to the population to immunize naturally, so not by the vaccine, before the vaccine appears. Unfortunately, some of the countries in Europe went this C way. Most of the countries went the M way, so the middle way. It was also Poland that we reached the level of around 35% of immunized people before the vaccine came. Then we had a quite rapid process of vaccination, reaching the 60% of vaccination, but together we had higher immunization, which is quite well confirmed by the seroprevalence study. This is in comparison with and good agreement with our model. So it shows that if you are looking at different factors which are responsible for excess death, we need to consider separately the phase 1 and phase 3. Do not mix it together, because different factors are having an impact on the death rate. That's it. Death rate during the phase 1 and phase 3. So, okay, so maybe I will skip here, last slides, and I'm open to questions.
Okay, thank you very much. So we have only time for one short question.
Thank you very much for the very informative talk. I wanted to ask how you define the transportation or the travel status. Is it just the distance traveled, or is it relating to the means of transportation, like public transportation, thereby altering the probability of getting infected?
In our model, we have two kinds of travel. So one is a daily commuting, so we are going to work and back, to school and back, and long distance travel. And long distance travel is related with permits for infection in the means of transportation. So the agents are grouped into small packages numbered from 2 to over 10, and then they also distribute the virus in the place they went to. So those are two different mechanisms.
Thank you very much. Next speaker is Till Krüger, factoring out the contribution of households to COVID-19 prevalence. Okay, I just heard Viola is taking that. The last talk of this session is from Beate Jahn about evaluation of vaccination strategies.
Yeah, welcome everybody. So I would like to give you an introduction into our evaluations on COVID-19 vaccination strategies when we consider that we would actually need an adapted vaccine. And this is a decision analytic approach. I'd like to thank my co-authors from UMIT Tyrol and also our co-authors from the Drahtwarenhandlung Technical University Vienna, Nicky Popper and his team. Nicky Popper is also here, so if there are some more technical questions, I will refer to him. We don't have any conflict of interest. What is it about? So there are several variants of COVID, the SARS-CoV-2 that have been developed, and now step back and assume a situation where we have vaccination coverage that is still challenging worldwide. So a situation where we don't have enough vaccines and we don't have our population vaccinated to the full extent. However, there is a new variant of concern coming up. And it is kind of obvious that we would need to have a new vaccine, a vaccine that is here symbolizing the current vaccine, but a new vaccine adapted to the current variant of concern that comes with a different effectiveness, sterilizing immunity, etc. And our research question at this point was, to identify the optimal vaccination strategy for COVID-19 vaccine adapted to a hypothetical variant of concern, focusing on age-specific prioritization during the period with still unvaccinated age groups and initially limited vaccination doses. We applied agent-based model that incorporate contact network structure and concurrent infectious diseases. I don't go into all these details. What we wanted to however, show with our analysis how we can capture best uncertainty about the variant of concern that we in the very beginning will have, and also uncertainty about the vaccination coverage when the new vaccine would be available. And how did we now structure it? We thought about like the base case where we just continue with the current vaccine, continue vaccinating our population. And then there are two further scenarios where we only would have and apply then the new variant of concern adapted vaccine. And in the situation one, so in the scenario one, we would continue vaccinating with the new adapted vaccine those people that are not yet vaccinated. In the second scenario, to be presented to the decision makers, we would continue but revaccinate with the new vaccine first the elderly, so more vulnerable groups. And then in the third and fourth scenario, we assumed that we would have both vaccines available, the old and the adapted one, that in scenario number 3, then we would provide the variant of concern vaccine and the new vaccine and the current vaccine to yet unvaccinated. However, in the fourth scenario, then we thought of, okay, another alternative would be to provide the new adapted vaccine to the elderly, so colored in yellow, and the current vaccine we continue to vaccinate yet unvaccinated individuals. So you see already it brings quite some complexity to the decision making here, and these are our results, or this is our approach, how we can synthesize the results and the information in order to make it accessible for communication. And what you see here is the scenario where we assumed a 75% relative reduction of effectiveness of the current vaccine to the variant of concern. And our main outcome is the relative reduction of death, hospitalization, critical hospitalization, and confirmed cases in comparison to continue with the current vaccine. So what you see is a very busy heat map. And just to guide you through, first here displayed kind of how we incorporated the speed of vaccination, so at which level would you be. So we assumed that in scenarios the 80 plus individuals or the 65 or the 50 would be vaccinated already. And then we distinguish in the scenarios that the variant of concern the infectivity would be similar, here displayed by 0, or we would see an increase by 33 or 66%. And then there comes another layer of complexity, the severity of the disease that could be also increased for the variant of concern as compared to the former one. And now what we see is that really it depends on the outcome you look at. And looking at hospitalization, we would prefer to the strategy number 1 to provide the adapted vaccine to yet unvaccinated individuals, followed by the scenario where we would provide the adapted vaccine and the new and the current vaccine to yet unvaccinated, but only if we have individuals 65, only if we would have the individuals, only if we would have the infectivity similar or only an increase with 33. However, if then the infectivity would be much higher, we would prefer strategy number 2. And looking at death, also here we see quite some variation. And if we would assume now that the individuals 65 and plus would be already vaccinated, we clearly see that independent from the other factors, we would prefer vaccination strategy number 1. But if only the individuals 80 plus would be vaccinated, then we would prefer to actually use the new vaccine to re-vasculate the elderly. And this is how you can go through all these results step by step, and also here then the scenario where we have a 50% relative reduction of effectiveness of the current vaccine to the variant of concern. And the picture is a little different, and I don't have time to go into all the details now, but maybe to sum it up, that our model, it comes still with some limitation or our modeling exercise, but what we clearly see that the decision on how to now distribute the vaccine, the adapted vaccine to your population strongly depends on the combination of effectiveness of the current vaccine for the variant of concern, vaccination coverage, and vaccination and the variant of concern infectivity, less, however, on the additional information on variant of concern severity. However, with this, we were able to provide a framework of these kind of analysis that could be applied in future pandemics. And we are still working on how to modify the presentation to make these results even more accessible for decision makers. Thank you.
So let me start with the first question. Did you ever try to put your model on the real historic data in Austria or Germany to see what a optimal vaccination strategy would have been?
No, unfortunately, this is a really fascinating question, but we did not have these resources yet, maybe.
Thank you, Beate, for the nice talk. I have basically two questions. One is, could we get rid of one layer of complexity, of one dimension, because most of the current vaccines are bivalent vaccines, right? We have the last strain and the newest variant. They are both included in the new generation of vaccines by BioNTech as well as by Moderna. So I think we could, reduce the complexity a bit.
Oops.
And the second is, how realistic do you think a vaccination rate of 80% is, and especially in people who did not get vaccinated so far? Because my impression is that last winter we had a 5% uptake of COVID in Germany, and those people who didn't get vaccinated so far, I think they have a particular mindset that wouldn't make them prone to get vaccinated in the future. Thank you.
Yeah, good point. So first of all, we were discussing whether we can reduce the complexity with our scenarios, but would be good to see or to have at least 3 and 4 then. To skip, to focus more on the others when the effect is still included in the vaccine. However, with the participation rate, so what you see here, this is just simplified, that we say, okay, the population 80 plus has been vaccinated and population 65 plus and so on. Within the model, we do assume that there is a certain participation rate in each age group that we would not cover anyway. So with our vaccination strategies, we only cover this percentage of individuals that in principle would participate. So it is not assumed that in the end we would be able to vaccinate all our 80 and 65, because we know that this is very theoretical. Thanks.
Hi, my name is Niki Popper. I wanted to add something to your question. At the moment, we try in a new project to find out, as you mentioned it's also a little bit what you said, there are some people who might not get vaccinated. So what we do at the moment, we get realistic, with interviews, we get realistic information, what do people think about interventions also for vaccination. And from these interviews, we get new scenarios for the simulation. And our teams are working so quick that Beate not always knows what we are doing. So we are working at the moment on these scenarios. What would have happened if people would have get this scenario based on the realistic scenario, of course, there's the calibration, the parameterization for the historic data, and now we try to find out different scenarios for other vaccination strategies and what would be the impact.
Thank you very much. So with this, I close the session. And since you noticed that we are already behind schedule, we agreed that we slightly shorten the coffee break to 20 minutes. So we meet again on time at 11:50. So at 11:50, the next oral should start.
da kommen jetzt noch viele. So, okay, I think we can get ready to get started, and we see that last-minute measures such as reducing the time in the coffee break are not always leading to very high compliance with everyone. But to not take away from the time of the presenters, I would say we immediately get started. The first talk is by Leonhard Stellbring, Comparative Modeling of Pandemic Behavior, Static versus Dynamic Agent-Based Approaches.
Yeah, thank you, Andre. I'm hoping, okay, perfect. We can see the slides. I want to give a kind of introduction to the topic of this session and briefly talk about the question, how does agent behavior contribute to infection spread? And I'm sure I don't have to tell you, but modeling behavior is essential and very important, especially during a pandemic. And one thing you can see is that even simple implementations of behavior can show very complex interactions between said behavior and the spread of infection. And for this, agent-based modeling is a great tool to capture the heterogeneity in behavior that results from context dependency. So, for behavior, social norms and situational context influence how people behave, especially for health behavior or protective behavior. And some models try to capture this by having health behavior being either present or absent, but you could say that this is kind of an oversimplification. And some other models try to capture this more as a stochastic process where different situations can lead to different behavior in response to contextual changes. And for lack of better terms, in my case, I call the first one static behavior models and the second one dynamic behavior models. So what did I do to compare these two approaches? I modeled either one of them in an agent-based model using a small world network. And in the static model case, the behavior is fixed from the beginning and doesn't change during the simulation. And in the dynamic model, the behavior can change during the model run. I also employ a Barabasi-Albert graph to represent the social network, and assuming a communicable disease such as COVID-19, I also use a basic SIR model. So in this case, we always start the simulation with a kind of superspreading event where the node with the highest degree centrality is the patient 0. So transmission in this case happens between a node and a random neighbor with a certain probability. And in my case, it's health behavior is defined as a reduction in that transmission probability, so very simple. And I also manipulate parameters like agent attributes and disease attributes. In this case, agent attributes are then the percentage of agents that act protectively, and the behavior factor, which is basically just how much the transmission probability is reduced, and for the disease attribute, the transmissibility. All other parameters remain fixed, so I can try to compare these models. And from initial simulation results, I saw that dynamic behavior led to lower numbers of infected agents, but this was very importantly only for uniformly distributed behavior. So in the case of then implementing behavior in a normally distributed way, this effect disappeared. So here you can see that basically the results between dynamic and static behavior are very similar. But something else came up during the simulation results, and that is that a smaller number of agents that behaves more protectively is more effective than if all agents behave a bit protective. So here you can see that for the case of having the behavior factor of 0.25, so this is basically less protective agents, and here on the right, agents behaving more protectively, then here you can see lower numbers of infection actually. And what I want to conclude from that is that especially in Barabasi-Albert graphs or social networks, highly connected nodes influence the result very much. And in this case, uniformly distributed behavior, the assumption of that does not really hold. But the effect of a small amount of highly protective people is very large. And you might see, or something you can think about is, for example, seroprevalence studies show that still roughly 30% of people never had a COVID infection, and this might have been in effect of such clusters of highly protective people, leading to that result. And I want to conclude then with that behavior can have a massive impact on the spread of disease, and that is why we need a lot more data and focus on understanding the mechanics behind agent behavior. Yeah, and with that, thank you for your attention, and I'm open to your questions.
Yes, thank you very much for being very much on time. Are there questions from the audience? So maybe as a question while you are still thinking about your question, I was wondering, when you said uniform behavior and normally distributed, what does that relate to? Is it like across agents or across time or across scenarios?
So it's across agents. So in the uniformly distributed case, basically an agent could behave very protectively in one time step and then not protectively at all in the other scenario. So there's no kind of coherence between behavior. And I wanted to represent it better with the normal distribution in the sense that there is some kind of changing behavior, but it's in a smaller range, so to say.
So would you say that is more realistic then?
Yeah, but I was also thinking about the next steps already, because one effect that I would be interested in is that if you behave very protectively all the time, but then for one event you are not behaving protectively, this, I would assume, has a way bigger impact on the result, especially for networks where the highly connected nodes are so important for transmission.
Okay, thank you. Are there any questions? We would have time for one very short question. Okay. Yeah, thank you again. Actually, a follow-up question, because I did not really understand the answer. So the agents have uniformly sampled, and they have then this or that behavior, and they have it across all the runs, or is it across the runs that the same agent is sampled uniformly with different, or normally with different behavior?
No, it is really across runs. So during a simulation run, agent behavior can vary a lot. So there's no kind of, I said coherence between the behavior of one single agent. So it might differ a lot.
Okay, and inside one run, how is the behavior from agent 1 to agent, I don't know, 1 million? Is this distributed to any?
No.
No, okay. Okay, thank you.
Thank you.
Okay, thank you very much. And Unless there's another question, no. Then thank you very much, Leonard. And up next we have Lilian Koyan, Modeling Intervention Compliance Behavior, Insights from a Cross-Sectional Survey.
Yes, thank you. Thank you, Andre, and thank you, Leonard, for giving a great introduction to my talk about why behavior is important and about why data might be important. And this is a very data-focused talk, because I am talking about the insights of a survey where we were testing a model that might help us represent behavior in a way that is kind of plausible, but also doesn't make the model too complex, because as Johannes talked about today, this is a very big challenge. I was wondering why everyone is struggling with this. I'm struggling now too. Okay, maybe like this. Okay, yeah, I'm also working on Optim Agent with a huge model, and much has been said about that already. We also know behavior is important now because of heterogeneity, so on and so forth. Because we want to look at interventions and evaluate interventions in Optim Agent, we also think that representing behavior and specifically compliance with those interventions is very important, and look at what are the mechanisms behind that compliance, while at the same time balancing the model parsimony with predictive quality, because a very complex model might be good at explaining behavior, but not very good when it comes to computational costs. So what do we know about behavior and health behavior? A lot, turns out. So there are many existing theories of health and social behavior. On the left, you can see an attempt at model integration. Most of these models assume some kind of bounded rationality. They assume that in decision-making we are somewhat rational, but increasingly that there are models that allow for us not being as rational in our decision-making, that it's maybe more driven by affect, more driven by habits. But this is what we know from theory. And then when we look at the evidence, specifically from the COVID-19 pandemic, all of you know there have been so many studies, and there have been many psychological and social scientific studies. And the COHERE project is a very great project that has done a large meta-analysis of these factors. And they found that the factors that are correlated with health behavior are mostly consistent with the existing theory. So we go from there to this hypothesized model. You have blue and red boxes, and the blue boxes I will talk about first. They are, well, a simplified integration of existing models like the theory of planned behavior or the health belief model. You have the perceived risk of the disease. You have attitudes towards the intervention, subjective norm, what are other people doing, opportunity and capacity to comply. Am I even able to afford the interventions? Am I, do I have the opportunity? And then habits. Do I have already an established habit that might help me or preclude me from doing the intervention? And then we have the red boxes that are like the system level variables that then come in the agent-based models. What is the actual disease threat that might be operationalized as death numbers or disease incidents? What can I observe? Are others complying? That's also kind of plausible, right? So if everyone on the bus is wearing a mask, you might wear a mask as well. And then what is the government response? Of course, it matters whether the government says, well, you have to wear a mask now everywhere, or whether the government is like, do what you want. Then, to test this model, we did a survey. You can see on the right the flow of our participants through the survey. It was cross-sectional, and we had a scenario where we presented the participants with a novel influenza. And we also had some manipulation of the three factors I just introduced, these three model system level factors, but those are only for context. They do not go causally into our model. And the NPIs we looked at for compliance were mask wearing, social distancing, and testing. So, some descriptive results. We actually asked 3,000 German adults, is broadly representative for a number of factors. But first all is the manipulation was unsuccessful. So we said like there is a high incidence and there is a low incidence and people's risk perception was exactly the same. So, but that does not really say anything for our model, only that maybe the context differences might not be inferable from this survey. So what about our model? Yes, the model worked quite well actually. So opportunity and capacity to comply is the only variable where we do not find a relation. By the way, we did partially square equation modeling for this analysis, which is just fancy regression basically. And attitude has the largest impact, followed by the subjective norm. Again, what are others doing? What do I think others want me to do? Then the habit of the intervention and the perceived risk of the disease. Okay, so far for the data and our results. Where does that lead us for modeling? So there are many potential avenues for modeling, of course, but if you want to keep it small, as I just said, one possibility would be to keep attitude kind of constant. And that is not to say that attitude is always constant, but I think we can reasonably assume that if someone is against, at the start, very against masks at the start of the pandemic, that won't change over time. What is very dependent on like the context and the network are what is the government response at the moment? Is there a mandate? Is there a recommendation? What can I observe from other agents in my network? Do they comply or not? And what is the perceivable risk for me? We also think that opportunity and capacity does still matter, but we just maybe didn't have the right method for that. And for the method, there's also a limitation. Of course, you have to be cautious when interpreting our results because this is cross-sectional data and this is self-report data. For future work, of course, we're going to test this. We are also going to compare it with other models of behavior. And then a very big point is to experimentally validate both the model results and the assumptions going in. And with this, I am at the end of my talk. I hope I didn't talk too fast, but this is the model again, and now I'm happy to hear from you and hear your questions.
Yes, thank you very much. I see we already have some questions.
Hey, thank you. Thank you for the talk. I was wondering, so you said there were some issues with the survey, and particularly the interpretation of the incidents. Is there anything in particular you could identify which was causing that issue? And are there any plans to redo any of the survey responses?
Yeah, I think this is, thank you for the great question. This is mainly due to the method, right? So if you just tell someone in a survey, well, the incidence is very high, it might not really materialize. But doing it in an experiment, maybe in a more, well, salient manner, that might be a potential avenue. Thank you.
Thank you, very interesting data. I have a question about the survey. Was it like a discrete choice experiment or some kind of choice survey, or how did you get to the weights that you have for the different?
No, it was not a discrete choice experiment. We had like a between subject design, so everyone was presented with exactly one scenario with these 3 manipulated variables, although, as I said, that didn't end up mattering. And then we just asked them, well, basically, we surveyed them on the different variables using established scales and then estimated a regression model. That's how we came to the results. Thank you.
Thanks, Lilian. So this is a model that is kind of describing the whole sample you looked at. Did you try to look into whether there might be different groups? So I can imagine that some people react to risks, others more just copy behavior of others. Is it possible to categorize people in different ways and perhaps get an idea of which age groups, groups that may be more or less vulnerable, perhaps respond to different incentives?
Thank you for the excellent question. This is definitely something we are wanting to do in the future. We just got the survey results in January, so that has not been something we were able to do yet, but this is definitely something we want to look at because we are also looking at heterogeneity in behavior and whether there might be some different mechanisms with different groups.
Thank you, very interesting. I wonder, is there also real data that you can actually show how good people really adhere when they cross something in a survey? Because, I mean, that's very subjective.
Yeah, thank you for the question. That's like a general problem with the social science, right? So there is a big debate about the veracity and the validity of social science measurements. I am not aware of like a general method where you can like really get down to business, but I think going in the direction of experiments maybe and looking what are the results we can see there, that can go a long way.
Okay, thank you very much. I especially find interesting that at least if government is important, that our work is actually mattering. So thank you, Lina, very much.
Thank you.
Next up, we have an online presentation by Veronika Kucina, a generation of consistent agent plans using strategy patterns and axiomatic logic. We can see you, but not hear you yet. So I see you're not muted, but we can't hear the online yet. Oh. Is it running on this machine? I don't know. No, it's not. Can you hear us? Can you give us a sign? We cannot hear you. Can you give us a thumbs up if you can hear us? Okay. That's good. Maybe the suggestion is, did you pick the right microphone? But I see your microphone moving on your computer, so I think it should be working. I think this is a local problem.
I switched to another microphone.
Yes,
maybe that did something?
Now we can hear you.
Ah, wonderful. Then I'm terribly sorry for the technical issues. It wouldn't be a hybrid conference about technical issues. Then I should try to jump into it very quickly. And I'm heartbroken that I cannot be with you in person. Just quick confirmation, you can hear me, you can see my screen, yes?
Yes, we can.
Okay, great. So I will talk about the generation of agent plans using strategy patterns and axiomatic logic. So going more into the methods part. And first of all, a brief reminder of agent architecture. And I go for the example of the beliefs, desires, intention architecture. As a quick summary, we perceive our environment and adjust our beliefs or knowledge about the environment, the situations, and combined with our desires, so our goals, what we want to achieve, we analyze the situation and come up with intentions that describe how do we want to achieve a goal state. And then we put it into action, and these actions, they influence the environment, etc. So it's a cyclical process, and the part that we are looking at is passing from the current situation to the intentions we want to take. And the question is, what plan satisfies my desires and makes sense? You are about to see in a moment what I mean by that. And before I go into that, let's look into the pre-generation of plans using strategies. That is our approach, because this whole BDI cycle with the deliberation and what makes sense, what doesn't make sense, it can be a very computationally intensive process, and especially if you have a lot of agents. So we just outsource a part of it. And first of all, strategy. That defines how an agent will act under certain circumstances if the situation arises. So we have a situation that is followed by a reaction. But the reaction is determined by the strategy, and the strategy that was decided on during deliberation. And this process of the deliberation, that's what we want to approach. And some properties that we demand of strategies. First of all, we need a countable number of them. And if they're not binary, we need discrete levels. And typically, some strategies will be mutually exclusive or always co-occur with each other. You're about to hear something about that on the next slide. And the most important bit, strategies need to cover all possible situations. So at any moment in the simulation, the agent will know, okay, I know what to do. And what we need to do is we identify all consistent combination of strategies. And how do we do that? Well, let's introduce the use case, the personal protection measures during the pandemic, so it's a bit easier to follow. And as an example for strategies, like if I feel sick, I quarantine, or I do my best to follow recommended health protection measures like wearing a mask correctly. And obviously, there are some situations that are inconsistent, like if I put high effort into self-protection, I cannot simultaneously refuse to protect myself or similar. And in the same vein, we also have strategies or actions that are very likely to co-occur. Like if I take a test when I'm feeling ill, it's also very likely that if I go somewhere to an event or location that requires a test, I will comply with that because obviously I don't mind tests. And what you can do is a fun, colorful matrix where you see which strategies will always, never, probably, or unlikely occur together. Please ignore the numbers, please ignore the colors. Just you see you have a grid of strategies which go together, which don't. And then how do we actually get from this colorful matrix to a list of consistent plans? And with consistent plans, reminder, it's a valid combination of strategies that covers all possible situations. And how do we get, first of all, we need to form levels if necessary, if we have numeric strategies, so that we have binary strategies in the end, because then our plan is a vector of true and false. So is the strategy being used or not? If this happens, do I do that or do I do that? And then using logical expressions and not, etc., we can simply filter out the combinations that violate any of our logical restrictions. So while it's a manual process to decide which individual strategies can never or must always occur together, we can at least automate the part for okay, we build every single combination and then we just filter out. But that doesn't solve the question, how do we get our agent to choose the plan? And there are some approaches. As one possibility, you can just build a decision tree. If you have clear theories or good available data and there's a strong distinction between options, then that's a very good approach. If your theories are rather vague, if you kind of don't have data, or if many plans are very similar, then that's not the best decision. I mean, how would you explain the difference between someone deciding to put a lot of effort into their self-protection and just put a medium amount of effort, but then also reduce their context? Like, what's exactly the difference between that? So in that situation, maybe it's better to just score and choose. So you choose a scoring method and each plan has a score, example, based on some score of individual actions, and then you calculate what's the score of the agent. And then you just pick a plan with a matching score. It's quite good if you have formalized theories and if you have a lot of plans that are similar and actually kind of equivalent. And it's not really good if you have theories that don't even have numeric elements, or if you don't have any data to compute the components or to compute the score of the agent. And then thirdly, maybe it's something entirely different, because the choice of mechanism, that must depend on what data do you have, what types of decisions and options need to be made, and also what underlying theories do you work with. In our case, we decided for the score and choose method, at least in our model in the SAMSEC context. And yeah, some preliminary lessons learned. What we found using this method, first of all, the objective was that we want to reduce computation time, because that's the main issue. Agents take a lot of time if everyone is deliberating and everyone is filtering through all of these different options and combinations. And the good is the computation of the individual scores and then selecting an appropriate plan did not actually lead to an increase of computation time, or at least not very noticeable. We did some profiling and we found, yes, the objective was actually met. Our model did not get slowed down by our agents choosing their strategies and their plans. And also looking at the infection dynamics, they are altered by the behaviors and their related parameters. So there is a noticeable difference by incorporating these behaviors. But there are also some unresolved issues. I wouldn't call it the bad, just the unresolved. And that's how do we actually score the individual behaviors, like how adaptive, maladaptive, or whatever is wearing a mask with a lot of effort or just sloppily pulling it with your nose hanging out. What's exactly the difference? And how do we evaluate it? Is it like the cost, effort, effectiveness? How do we handle this? So that's often a very subjective handling, as well as just what behaviors are always together, never together. And then also data. Even if we have data, how exactly do we incorporate it in the formation of strategies, in the formation of scores? How do we use it for validation? But the main point is this at runtime deliberation has similar problems. So what we see especially is this method of going for strategies and just letting agents pick something that matches their current state of mind. seems to be working, but it does not solve other problems that are commonly encountered by agent-based modeling, but at least it doesn't add any additional problems and even can speed up models where decision-making just takes time, but where essentially each agent has the same set of actions to choose from. So that's something to consider, and thank you all for your attention, and I am open to questions.
Yes, thank you. While you make up your mind, I have one for you. And I was wondering, so if you run the simulations and you have several strategies, does it turn out, if you score them, that there's a set of strategies that seems to be superior or most prominent? So have you looked into what the agents are actually doing then?
Essentially, you have to consider strategies. I'm using the word rather liberally because I'm going at it from the programming pattern perspective. So not really a strategy as in a set of like policies as we would know in reinforcement learning. So essentially it's like individual actions which just represent, okay, I do this, I do that. And we found that there's not really a dominant like plan or setting because it very strongly depends on how we actually compute these scores. So as soon as we like increase some kind of how much weight does trust in a source have in the perception of something, so how the score of the agent is computed has a huge influence, of course, on what actually the outcome is, which is kind of the point because just representing, because the idea is here. So that's the most important bit, that we did not really find large differences in that regard, and that strategies being chosen or the actions being chosen largely depend on how the score of the agent is computed.
Okay, thank you. We have time for one short question. Okay, I don't see a question right now, so thank you very much, Veronika.
Thank you.
And I think we can then move on to the next talk. Thank you. And now I have a question. Is Sally Lago here by now? No, okay. Then apparently she didn't get here in time, so we can move on to the next talk, which is Matthias Horn, Mathematical Modeling of Pneumococcal Transmission and Disease. Oh, you are there. Wait, then I'm very sorry. Obviously, this is not Matthias. So the next talk is Sabine Wüst, Modeling the Influence of Environmental Stressors on the Spread of Communicable Diseases.
Zumachen? Oder? Gut. So thanks for the introduction, and well, thank you also for the possibility to give an oral presentation here. My name is Sabine Wüst. Nobody of you knows me because I'm from a completely different community. I'm an atmospheric physicist, I'm an experimentalist, and yeah, since some years one of my minor fields of work is now the influence of the atmosphere on health. So the influence of environmental stresses on health, and in this presentation I will show you some results from a DFG project, which I work on together with my colleagues Bianca Frischholz, Michael Bittner, Leona Hoffmann and Jörn Rittweger, which I'd like to acknowledge here. So, the outline of my presentation is the following. At first, I would like to give you a short motivation why we think it might be a good idea to model or to care about the influence of environmental stresses on disease spread. Then I'll come to the introduction of a very simple modified spread model and tell you some or give you some qualitative results before I go to the outlook. Well, at first, I should maybe define what are environmental stressors. Well, environment is everything which surrounds you. I'm an atmospheric physicist, so you will live in the troposphere, so the lower part of the atmosphere. Environmental stressors can be everything there, so it can be gases, NO2, nitrogen dioxide, but also PM2.5, particulate matter, with a diameter of less than 2.5 microns. but it can also be temperature, humidity, so meteorological variables. And those environmental stresses, they can lead to permanent or acute stress on your body. And in this talk, I will focus on the respiratory system. There are some studies which already investigated the influence of environmental stresses on COVID cases and also on influenza. And the main idea behind it is, if I put a system under stress, acute or permanent, it will have less power to fight against communicable diseases, so it will be weakened. And the overall goal of our project, which will certainly not be answered completely because it's very complicated, is we would like to investigate and model the influence of environmental stresses on the spread and severity of influenza and COVID-19. And as a starting point, we choose to model the influence of temperature on the spread of influenza. So we simplified the approach. Well, I'm an experimentalist and I believe in data. And so always a challenge for the quantification of results in general, and I believe also in this community, is the databases. We think that we have a rather good databases here. We had an internal DLR project starting 2019-2020 where we cooperated with the AOK Baden-Württemberg. So AOK Baden-Württemberg has about 4.2 million, let's say, customers. And we have data since 2010 concerning influenza and since 2019-20 concerning COVID. And one of my colleagues, Jörn Rittweger, he did a multivariate statistics, which you can see here. He analyzed influenza incidence with respect to different environmental stresses. Here you have the temperature, here you have the number of incidences versus precipitation, NO2, and particulate matter. So this is one part of the project which we will also be using in our project now. And then we acquired a DFG project, and in this DFG project we will, he does multivariate statistics with respect to COVID-19, and we try to model the influence, amongst others, of environmental stresses on the spread of COVID-19. So the model scheme is a modified SER model. And I say modified because due to the databases, we can subdivide the group of infected into people who are not able to work, who are in the hospital, and who are under respiratory therapy. And I don't go into detail now, but of course you have some additional equations there. And we included, and that's, I say we, but I should say Bianca, included the influence which Jörn found out in his publication, so the influence of temperature on the incidence here in the first equation. So she mainly modified the rate with the temperature here. And those are, which I show now, are some qualitative results, so please don't pay attention to the numbers, only pay attention to the relative course. We have here the different colors which refer to the different groups, and we have a starting date, the 15th January 2010. And we fed into this model temperature data, daily temperature data from the Copernicus Atmospheric Monitoring Service. And the second example is for a start date of the 15th July 2010. The yellow line shows you the susceptible, and the green line shows you the exposed, the red line shows you the infected. What you see when you compare both plots is that the maximum comes later and is also lower. So with this, I'd like to conclude my presentation. I showed you a first case study or a first approach in order to model the influence of temperature on the spread of influenza. Of course, what we need to do, what I didn't told you, or what I haven't told you, is that we had a kind of mix-up between COVID and influenza rates. We have to use realistic influenza rates and check the results for plausibility. And then, of course, we can try to integrate other temperature-dependent rates, For example, here we can try to include the effect of other environmental stressors, NO2. And this is especially of interest because some of those environmental stresses we can influence as human beings. We can influence the amount of NO2, we can influence the amount of particulate matter, because those environmental stresses, they are produced via combustion. So, for example, if I see that those environmental stresses, they heat up the pandemic, I could try to reduce them, locally maybe. So that's the main idea behind it, that's the main outlook, and yeah, the other things are clear. You can also try to couple it and make it, a spatial approach. And with this, I'd like to thank you for your attention.
Yes, thank you very much. We have some time for questions. Okay, I already see some hands.
Hey, thank you for an interesting talk. So I was wondering, so you're trying to look at the impact environmental stresses on, it seems like the susceptibility of people, so whether or not these environmental stresses affect the susceptibility of people to these pathogens, right?
Do you mean that we differentiate between the susceptibility of different human beings for environmental stressors? Is that what you mean?
I'm not sure. I don't know. I mean, my question is, so there's a difference between these environmental stresses may affect the person themselves.
Yeah.
So they might affect the respiratory tract, for example.
Yeah.
But it's also shown that for influenza, for example, environment has a big influence on the transmissibility.
Yeah.
Are you able to tease out, to separate these into what's affecting the person and what's affecting the actual pathogen?
I think we are not able to differentiate here, but maybe we can discuss this question later in the coffee break. Thanks.
Sorry, maybe I missed it. You work in like an environment here where we live in houses and cars and so on, and
No.
I mean maybe, or we do. I think we are in a house right now. The question is if it's
but
warmer.
we only look at, we don't look at the environmental stresses which are in the house. We only have information outside.
Correct, but the majority of transmission happens inside.
Yeah,
so,
I know.
So I wonder what the, like, I mean, you maybe have more influence on the humidity than you have on the temperature really when you're in-house. And I mean, there is a lot of other things that contribute, like whether you have a ventilation that goes around or it's in-out, if there's a moisturizer or not. I wonder how applicable that would be because, as said, we talk about household size and so on. The majority of transmission will happen in a completely different environment.
Yeah, as a physicist, I have to say that we make the assumption that we have a certain amount of ventilation. So this is certainly, temperature is certainly not the best example for this because we have heating in winter. But for example, if you have NO2, so if you live at a large street and if you open your window, you will get NO2 in your room. And sorry? Yeah, okay, yeah, sure, but I think that are details from my point of view. But I know that they are valid.
Okay.
And I think candles produce mainly PM 2.5 or PM, but we can discuss this also later.
Thank you for your very interesting talk. Just since we're just mentioned NO2, from the plots I was a little bit confused because it seemed like there was a negative relationship between the NO2 concentration and the influenza cases. Did I misunderstand? But you were saying that the NO2 is an environmental stressor that would increase.
Yeah, concerning NO2, there is some discussion. Also in other studies, I saw a negative correlation, and I asked my colleagues about it, and they say that if you have a certain amount of NO2, it works. It works protectively. So you are used to a certain amount, and if you are in this amount, everything is okay, but afterwards it goes up. But that's only what I can tell you from secondhand. So.
Thank you for the great talk. Would this capture natural experiments, such as the introduction of low emission zones?
Yeah, it would. Sorry, short answer. I forgot to tell you that I'm a mathematician.
One last question. Yeah, thanks for your talk. I just wanted to ask, some of these environmental stressors may be linked to
each other?
To each other, but also to behavior. So something like temperature may make people meet up more, and that increases the transmission, and then it's not the temperature itself, but more the behavior of the people. And I don't know about things like PM, whatever.
2.5.
Exactly, but have you tried to look into how these are linked, so that maybe some of these are not stressors, but just correlates?
No, not really, and I don't know how to get it out of the data. I mean, that goes a little bit into the candle question. If I'm used to set up a candle during the evening, I certainly change the amount of trace gases or of PM in my room. Yeah, I don't know how to get it out of the data.
Okay, thank you very much for
Thank
your
you.
interesting presentation. And now we do have Matthias Horn. Thank you very much. Mathematical modeling of pneumococcal transmission and disease dynamics in the German population is the topic of Matthias's talk.
Yeah. Yeah. Thank you for the nice introduction. My name is Matthias Horn. I'm part of the Prognosis Consortium, and I want to start by giving a brief biological background for my talk. So, Streptococcus pneumonia is among the most common causes of bacterial pneumonia worldwide, and as you are all aware, probably it causes both CAP and IPD, like for instance primary sepsis, which is associated with a high mortality rate, especially among older adults. And there are approximately 100 known serotypes, and healthy children are the main reservoir for spreading the infection to other individuals. So this is why vaccines are widely administered, but unfortunately they protect only against subsets of those serotypes. The most important milestones of the vaccination history in Germany were the introduction of a universal pediatric vaccination for children younger than 2 years with the 7-valent pneumococcal conjugate vaccine, PCV7, in 2006, and followed by the replacement of PCV7 by PCV13 in the year 2010, of course with a broader serotype coverage. And very recently, PCV15 was now additionally recommended for children, and PCV20 was introduced for adults. It should also be mentioned that since the introduction of those conjugate vaccines in 2006, a substantial relative reduction of vaccine serotypes was observed in both carriage and disease, but unfortunately this came at the cost of an increasing contribution of non-vaccine serotypes. So in order to better understand the underlying dynamics, we applied mathematical modeling, And this is the model structure of our epidemiological model. And as you can see, we subdivided those 100 serotypes into 7 distinct serotype groups, G1 to G7, motivated by the composition of different vaccines. Like, for instance, this group G1 contains all those serotypes that are contained in the PCV7 vaccine. In the model, we also consider double carriage, as you can see here below. But in this case, the forces of infection are multiplied by case carrier, multiplied by competition parameters C, because we assume that it's much less likely or less likely to become a double carrier than becoming a single carrier in the first place. So loss of carriage is modeled by this parameter R. I denotes the age strata, and of course, to get back to the susceptible state, it takes a two-step process here. The model is implemented as a set of ordinary differential equations, but since very recently also as a set of ordinary difference equations with a time step of 1 day. To also describe vaccinations in our model, we amended the model by 2 additional states, vaccinated by PCV7 and vaccinated by PCV13. And transitions between those states are described by vaccination and waning rates, respectively. We also model the impact of a vaccine on carriage of given serotype groups, and the model is fitted to carriage prevalence data from 2006 until 2019. So under the assumption of continued PCV13 vaccinations until the year 2031, we predict that IPD case counts due to any serotype in children younger than 2 years remain largely unchanged, as you can see here. We also predict a 20% increase of total IPD cases in older adults between the years 2016 and 2031, as you can see over here. There will also be a continuous increase of non-PCV13 serotypes in both pneumococcal carriage and IPD, and as depicted by the color cyan, serotypes included in PCV20 but not in PCV15 are predicted to cause approximately 1/4 to 1/5 of IPD cases in older adults. And with this, I would like to conclude my talk. I've shown you a mathematical transmission model that is able to predict pneumococcal serotype carriage, prevalence, and IPD case counts specifically for the situation here in Germany. We also aim to predict serotype distributions over the next few years under the assumption of a continuation of the PCV13 vaccinations, which we now know has recently changed. Our model predicted a continuous expansion of carriers, carriage, and IPD by the additional serotypes that are included in those next generation vaccines, which somewhat supports the recently changed vaccination schedule here in Germany. And it should also be noted that we excluded potential temporary or permanent effects due to the COVID-19 pandemic in our model, and particularly the counteracting measures. And this is something that we are currently working on. And I would like to give a brief outlook because it's still heavily work in progress. We are currently in the process of adapting our model to the recently changed vaccination recommendations, so we want to include those 2 new vaccines. We also would like to predict cap case counts in a similar fashion to the IPD cases that I've shown you in my talk. We are also in the process of attaching a hospital burden model in cooperation with our partners from Aachen. And finally, we would like to investigate the effect of large-scale NPIs on carriage and pneumococcal disease. And with that, with that, I would like to thank you all for your attention, and I'm happy to take any questions.
Yes, thank you very much. Do we have questions from the audience? While you make up your mind, I have a question. And I was wondering, you showed young age groups and older age groups, and I was wondering, in the model you do represent the other age groups as well?
Yes,
okay.
yes. In fact, that is, we have 8 different age groups, starting with children younger than 2 years, and then up to the last age group are people that are older than 85 years. So I only showed some results for the sake of time, but we really consider different age groups, and the choice of the age groups was actually done in close cooperation with biological partners, so that it really also makes sense from a biological point of view. Yes.
Okay, thank you. There is another one.
I was wondering, so you're projecting forward in time for the German population. Are you also including demography changes in these projections?
Yes, we did. There are some models, some projections that are provided by the German Office of Statistics, which we took into account for our projections, right? Yeah.
Yeah, thanks a lot for our presentation. Can you briefly comment on the whole topic of parameter uncertainties? I mean, it's a very comprehensive model, obviously, with also with secondary infections or secondary carriers basically being involved. So how well are these reduction factors, for instance, determined, and how does this influence the predictive power? Thanks.
You mean uncertainty in the model? I didn't understand. Yes. Okay. Yeah. We also did a sensitivity analysis in our model to look at different different contact matrices, for instance, and different values for these competition parameters, and we actually found that our predictions are quite stable, actually. Yeah.
Thanks very much. You skipped over the carriage data a little bit.
Yes.
Can you tell us a little bit more where the data is from, what the power is, different age groups included, yes, and the model actually fitting that?
Yeah, this is really an important question. Thank you very much for that. Unfortunately, there are no really good carriage studies, especially for Germany, and to be honest, I'm not aware of any carriage studies at all that had to look at the whole population. So what we did here was we took case counts, reported case counts, basically for IPD and CAP for Germany, and we back calculated carrier percentages for different serotype and age groups from those disease counts, of course, including confidence intervals, because this is also associated with a certain or with a uncertainty here, and yeah, genau. That's what yeah.
Okay, since I don't see any more questions, thank you very much, Matthias. And since this was the last talk of this session, we conclude this session, and next up is... Next up are Alexander, Berit, and Raphael.
Yeah, now after 1.5 days of great presentations, oral talks, and also poster presentations, Berit, Raphael, and I would like to give a short update on ongoing activities within MONID and also some planned activities. And I also included some slides which I couldn't present or start yesterday. So the agenda is the following. We would like to show a few numbers of the MONID conferences in 2023 and 2000. Then present some about joint activities within MONID. Raphael will then present a planned activity, a planned teaching activity called MONID Academy. Then we will present another project prepared. Probably you got already a mail or joined one of the workshops of prepared. And then I would like to show the old MONID logo because now you know the new logo, so I would like to show the old logo. And then, we would like to invite you to the MONID conference in 2025. So first, the numbers, I think I mentioned the numbers yesterday, but in 2023, so last year, we had around 130 registrations. We had 19 posters because we didn't have any oral talks and we only invited young researchers, but then we got some complaints from senior researchers that they also would like to present something. So this is something we changed for this conference in 2024. As you just heard, we had a lot of oral presentations and we still have quite a few. But we still had these elevator pitches we also had last year and the poster presentations. And in 2022, around 165, not around, but 100, we had 165 presentations. What surprised us a little bit, the large amount of abstract submissions, which is great, of course. 83 abstracts were submitted and 70% of these were submitted by young scientists, which is also, really good. Then we had 24 oral presentations, and some are still coming, 14 by young scientists. We have 55 posters which are presented, 42 by young scientists, and then yesterday we had the elevator pitch sessions, and nearly all elevator pitches were done by young scientists. Then, again, I already thanked you yesterday, but that it was such a great summer school last year that we want to thank you again. So, thank you very much to Andre Viola for organizing the summer school last year, which was a great effort. And here you can see a few pictures from this summer school, which I couldn't present yesterday. Then we would like to inform that we started or initiated a close collaboration with the RKI. We had a workshop last year in October, but we discussed two topics. The first one was data availability and project plans, and the second one were the scientific collaborations. And the bolded parts, these are activities which have already started. So we have established liaison function for data availability and content-related questions. So in January, we sent the first data request from MONID to the RKI, and it's still processed at the RKI. Then regarding the scientific collaborations, we are in the planning of a joint project. The RKI asked us to support the cost-benefit analysis of their wastewater surveillance. And like I said, this is just in the planning of this project. And then this year we plan to organize some regular meetings with the RKI on certain topics. Then, as you know, we do this joint scenario modeling. We have done 3 rounds. The third round we have completed by the end of last year. And we looked we aimed to estimate the burden of COVID-19 and other respiratory tract infections in the winter 2023 and 2024. For COVID-19, 5 modeling groups participated in the scenario modeling, and 4 scenarios were defined. They differed regarding the immunity in the population, either low immunity or high immunity, and with respect to the hospitalization risk, either the low hospitalization risk or an increased hospitalization risk compared to the Omicron variant. And the results of these simulations were that the hospitalization burden is manageable over the last winter, which was obviously the case, and but that we will see significant staff shortages due to high infection numbers. And then we also looked at RSV. There was one modeling team who provided a model and did the simulation, and they used population-based immunity and sentinel surveillance data and found that the infection numbers will be comparable or were comparable to the 2022-2023 season, but with a later peak. And I think this was also, I mean, you know the numbers probably better than I do.
That was very much in line with what happens. Yeah. Okay, so great to be here. Welcome from me as well, and and I'm really glad to be here finally. So Alexander has just said we do scenario modeling. We have done the 3rd round, as you all know, or most of you will know, and we thought that it's now a bit of time also to evaluate that. So we have started activities to evaluate these joint scenario modelings, and we are presenting this here just for anyone who has not heard that. We've sent emails around, but anyone who hasn't been getting these, please, if you are interested in joining this group of the evaluation of the whole thing, then do come to us and contact us, because we are doing it a bit in 2 ways. Basically, we are of course trying to evaluate how did we actually do in the different scenario modeling rounds, and what did we predict and what then came true, and why might that be, also dependent on the different models we have. But we are also, and I think that everyone has gotten already, sent around a survey where we are trying to understand why do people participate in the scenario modelings and why do they not participate, and what can we do to support that. And we do think this is really important also going forward to understand these things, just so that we can have more people joining these scenario modelings. I wanted to make you aware, and these are just some examples of that. So out of MONID, we of course have several of the consortia who are also generating really, really needed data. So population-based data, but also other types of data. And we are now providing these data more and more also in real-time format. And if you as a consortium or you as a group are doing similar things and providing real-time population-based or other forms of data that are model usable in this type of continuous format, please inform us so that we can also put that on the MONID website, for example, and make sure that it actually has a chance to then go into the modeling that we do. Then we, of course, have some ongoing work in the working groups that we have, and just for everyone a reminder of these working groups and the different contact persons. So if you are interested in these different groups, please come to the respective person. So we are looking a lot into research data management, and Tim and Alexander will be able to guide you through that. Andre started an activity trying to provide reporting guideline and risk of bias tools, which is really, really important if we want our models to be usable also in guidelines, right? Because that is, of course, the translation that might happen for infectious disease models to be then also used in infectious disease guidelines. If we want that to happen, we need these risk of bias tools and we need the reporting guidelines. We also started a working group on contact behavior, and I think there was already a poster presented on that, and I just presented the evaluation group for scenario modeling.
Yeah, then of course we we wrote a strategy and we discussed the strategy, the MONID strategy, with the scientific advisory board, and came up with an updated strategy which you see here. And this strategy we will then discuss with the ministries, in particular with the Ministry for Research and Education. So our strategy is, of course, based on the overall MONID aim to strengthen the modeling capacity in Germany with different sub-aims like strengthening pandemic resilience, reducing the disease burden, and so on. And of course, we would like to improve research, but for research, we need also to strengthen the infrastructure and the capacities. And I think when we've completed this updated strategy, we will circulate it around in the steering committee, and after that we will send it to the ministry. Then, as mentioned already many times, you know, we have initiated, or not we have initiated, but our young scientists have initiated the Young MONID initiative, and we will have a panel on this later on, but we would like to show it again because we are very proud of this initiative. Okay, and then?
Yeah, this is one other activity that I would really like to invite all of you. This is a bit of a stress test activity, and it's one of the examples of where we are now really nicely collaborating with some of the larger infection research institutions and other German institutions. So this is a collaboration with the Network of University Medicine and the project that it has that is also on modeling, which is prepared, where André Karch leads the modeling part. And there, what they are doing is basically providing use cases as a form of stress test for different systems. And we are able to take part in one of these, or also two of these use cases. And in this case, an influenza use case, as you can see here, so an influenza pandemic use case. And for us, I think, as MONID, it's a really nice opportunity to have some look at the structures that we have built and how we think they might fare in the next pandemic. So we have had one meeting where we explained the whole thing, and we will now have regular meetings on this and try to really understand, so probably until June, when we also need to feed this back to prepared, and really try to understand, so 4 different phases of, let's say, a next early pandemic, what would be the resources, what would be the work, what would we need from MONID, what do we still need to do?
Yeah, we wanted also to inform about this MONID Academy, so this is joining the efforts in education. So like these plans we had for a long time, and we have clearly a lot of resources and a lot of people who can contribute, and we hope that we can start something where we can contribute. It will be a virtual offer, so I mean different institutions can provide some input. Maybe there will be also parts. Initially we thought about virtual offer, but yesterday we got also from our scientific advisory board several inputs which maybe also suggested that having some meetings would be also good. So we will discuss how to put it together, but it will be a good offer for all doctoral students being in the consortia, and hopefully something which we start now and will continue in the next funding phase. So we will ask the participating institutions what they can provide and try to make a framework out of this. And then once it is there, you can maybe kind of register those of interest, or they will be always circulate information what is available, and then you can either participate on single time port, or maybe we will also try to provide certificates so that you can use it in your doctoral teaching programs where you in your sites, because maybe you have to have some kind of certificate. So we have to figure out what is necessary. It is not the idea that we have doctoral students work centrally at the MONID, but in all the institutions we will just provide educational offer under this MONID Academy heading. So much for now, and this information will follow. Okay. So you want to say this?
No,
This
you
something?
want to
Me?
say-
No,
Yeah.
Okay, but okay. So this was kind of hot information yesterday because it was from our meeting on Tuesday. So we are now in Optimum Agent so far with the big agent-based model we're working on, then we can share it. I mean, it's still not, it needs some final touches, but then it could be also used by the community. And we actually, what at least I realized, that we went a little bit beyond our expectations. So first we wanted just to have a kind of maybe model and then write down how to make this model, but what now came into existence is more like a language, or something which can be developed further. And I have to add something because in the meantime, I already heard from Martin that they have also kind of framework on environment. So we will probably, so this is basically the information that something like this came into existence in our consortia. And we will somehow have to share this information. So we had educational workshop on how to use our model, but the next time we will do it together with Martin probably, and maybe there are also others who formalize so much, I mean, who developed their models in the way which can be used and developed further by the others. So this is, we didn't exchange so much information about this until now, but from the last year of this funding phase, it would be very nice opportunity if we can kind of use this joint resource and see how to develop it further. And even probably it would have some links to the initiative from the WHO, which we heard yesterday. So I mean, it would be maybe usable beyond our, even beyond our consortium. And also we talked about this with our international partners, so they might also maybe join in these efforts. Thank you for this.
Okay. Yes, you can see here, this is a new logo. And if you thought this is somehow familiar or you somehow have seen this before, this is the old logo. So it's a slight update, let's say. And so that you don't mix it up, I wrote below that on the top, that's the old logo, and on the bottom, that's the new logo. And then we would like to, of course, invite you to the MONID Conference in 2025. It will be held in Berlin in February 2025, of course. And we aim for an international conference and hope that we get around 250 participants. It will be again over 3 days, but this time we won't have the internal research group meetings. Instead, we have the joint meeting over 3 days because we would like to have even more oral sessions and poster presentations than this time. So yeah, I hope.
Clarify that it's not in this building.
I wanted to say yes, of course it's in this building. We booked this building already. And no, it's unfortunately it's not in this building, or maybe fortunately, I don't know. So yeah, thank you very much for attending the conference. I mean, we still have an afternoon, and now we come maybe to a very important part. We would like to give the poster prizes to the young researchers. So we planned with 2 poster prizes, but we had a shared second prize. So now we give only 1 prize. No, of course we give 3 prizes. And the second winner or prize I mean, first I read the title. It's Modeling Infection Spreading and Countermeasures in a Pandemic Situation Using Coupled Models from Inan Bostanci and Christina Meyer. Yeah. So, yeah, if you are here, please come up.
Do you have make a copy? Just one.
No, we are very flexible.
Du musst ein Foto immer machen.
Ja,
Also
okay.
immer mit dem Übergabe sozusagen.
Genau.
So. Das muss sie einfach teilen.
Yeah, you don't have to share.
Congratulations.
Yeah. And now the other second shared prize is for impact of demographic developments on the future burden of pneumococcal disease, presented by Maika Harun Sarayan. Yeah, and so now we come to the best poster. I mean, the price is the same for everybody, but still the best poster. It's for refining ICU capacity models, the imperative of advanced approaches for peak load predictions by Eunice Müller. Yeah, and then I would also like to remind you on the prize for the best oral presentation by a young researcher. Please don't forget to vote. You have only one vote. You have to scan the QR code first. And voting is open until 5 p.m. After that, we close the system. Okay, then I think we can head to lunch or... and before lunch, don't head to lunch. We would like to make a photo with everybody first. So, Carla, do we go outside or make the photo inside? Okay, I think then we make the photo here because it's really a nice room, because outside the weather is not so great. So, yeah.
Middle of the room, and we make it somehow from here. So we have to go down.
So welcome everybody to our afternoon session with the topic data acquisition and fitting. First speaker of this session is Jan Moring from the Fraunhofer Institute for Industrial Mathematics. He represents the ZEMSAI consortium, and the title of the talk is Estimating the COVID-19 Prevalence from Wastewater.
Why is this different? Okay. So welcome everybody from lunch, and to some extent this is now the natural continuation of lunch because this is about wastewater. And yeah, this is joint work with my colleagues from Fraunhofer WM. And the results you will see here were also discussed in the MONID modeling group, sorry. So, okay. So the scientific question we want to answer in this talk is, can we predict the prevalence of some pathogen in the population from monitoring the wastewater? And we do not just want to answer the question, oh, it goes up or it goes down, but we want to answer the question, if we measure that amount of viruses in the wastewater, what will be the prevalence, the related prevalence in the population? So it's really a numeric correlation we want to find out. And the answer is not general, but at least it has worked once for COVID-19. And of course, it will not always work. There must be satisfied some preconditions. The first precondition is that the monitoring system of wastewater is calibrated at the beginning by some sentinel study, or by some representative cohort study. The next thing which must be satisfied is that the pathogens in the wastewater are correctly normed. This must be done, to our experience, with some omnipresent virus like the pepper-mild mottle virus, for instance. Then it can work. Of course, it must be statistically fine. This means the number of wastewater plants and also the number of participants in the cohort study must be sufficiently large. And what you also need, and this is where we as Fraunhofer ITWM come into play, is you need in the background a simple model which links the two time series by fitting, especially which finds the scaling factor and the time shift for the two time series. So I give now the example we are involved in, or we are still involved in. This is the example of the land of Rheinland-Pfalz. And there the wastewater is collected by the Landesuntersuchungsamt in 16 wastewater plants. And probes are taken twice a week. And they are all analyzed by one laboratory with the same protocol. This seems to be important for me. Then the second ingredient is this cohort study, and there we are lucky to have this very big CentiSurf study organized by the University of Mainz, where we have up to 12,000 participants, which have been selected representatively from the 5 biggest cities in Rheinland-Pfalz, and they apply self-antigen tests twice a week at the first phase of this study, which lasted from December 2022 to April 2023. And then in the second phase, which started in June last year, they only tested themselves once a week, but still it's very valuable data. And now we come into play again. This is our epidemiological model Here you see it. And you see it's an Einstein model. It's just as complex as needed. So very simple. It has two state variables, the newly infected and the protected. And then we derive some quantity which is infectious. And the main assumption is that the two time signals which are measured, so the prevalence and the viral load, that these two quantities are just scaled or shifted versions of the state variable of our simple model. And you can see these parameters, tau and alpha and so on. They are very few, and you can all fit them to the measurements. How does it work? So the first step, so our goal is now, this is defect, but this is not, okay. The goal is to predict the prevalence from wastewater. Now the first step is calibration. In the calibration phase, you need the two signals. And you see the dots are the measurements, and these continuous lines connecting them, they are the fitted model, which are scaled or shifted a little bit. Now we know the scaling factor and the shift factor, and now we come to a situation where we assume now, in fact, we have the data. We have the data from the second phase, the CentiSurf data, but we assume now we don't have it. We want to have this procedure if we don't have anymore this the CentiSurf data, because it's quite expensive, and we want to have a situation where we only need the wastewater because it's cheaper. So assume so this is the basis of this delta fit. So we have this measurement data, and, and also the measurement data from here now, from the summer. And we take the old model, continue fitting it, and then fitting this gives this continuous blue line through the wastewater data. And then knowing the factor and the shift, we find this red line here. And as you can see, they match almost perfectly the real prevalence measured in the CentiSurf study. I just emphasize once more, we haven't used it for the fit. It's just for validation. And now I tell you how exciting it is to do prognoses. Sometimes also a little bit stressy. So you see here that the model, you don't see it, and the most right-hand edge of the picture, you see that our model said at that time, we have reached the second wave, and this was somewhere end of October or so. And you all know the real wave was only in December. And so at that time we said, the prognosis says, it is now, it comes soon. And the same situation lasted in the next weeks. Each week we said, oh, the peak is reached, it is done. But the measurement were a little more again. So at that time we didn't even get sequences from the laboratory which could have shown that there's a new virus type, namely the Pirola. But just from, we have a good trust in our model, we said, oh, it becomes worse and worse, always does bad prognoses, so there must be something wrong. And we assumed that there must be a new virus type, and we added it to our model. And now we had this prognosis here. You can see we said it is, the peak will be in about Christmas, and it will be about 5% prevalence. And this is what really happened, 5% about Christmas. Thank you very much.
For the sake of time, I would allow one question from the audience. One.
Mapping would not work as well anymore as you showed. Like, what do you think are the limitations of this very simple mapping?
Of course, this assumes that the amount of excrement is the same for each virus type. If the virus type changes, then this must be recalibrated. But still, if it must be recalibrated once a year for a few weeks, it's much cheaper than having this expensive centisoft signal all the time. So you must see a new wave, you recalibrate, and then you can use again wastewater.
Thank you very much. So the next talk is given by Nina Schmidt from University of Bonn, representing the INSIGHT Consortium, and the title of the talk is Demonstration of an Integrative Modeling Approach of Infectious Diseases.
Thank you very much. All right, so what I want to talk about today is something that combines perspectives of two talks that we have heard today already. One of the talks that we heard at the very beginning of today was an agent-based model. I'll talk a bit about that, and I'm also going to talk a bit about wastewater modeling. I present joint work specifically of the INSIGHT Consortium. Julia Bicker and Andreas Hoffmann put a lot of effort into this, so I specifically want to name their names. The INSIGHT project aims for an integrative modeling of the spread of serious infectious diseases. So integrative here means that we want to integrate several different models, several different sources of data. And the key setup of this first demonstrator study is that we have a transmission model, which is basically the agent-based model of Memilio that you've heard already about today, so a very flexible model that can be applied to various different forms of diseases with stochastic components where agents move in a city, and hence we get very detailed information about the time, the agent location, and the infection status of each of these agents. And this information we then pass on to a second component based on where the agents are and what infection status they're in. We get an amount of influx RNA concentrations into the wastewater system, which is then processed by a very detailed and mechanistically highly informed hydraulic simulation software that has also the network model of a specific location as input. And the output of this is then obviously the RNA concentration that we measure. So to demonstrate this whole modeling approach and to showcase what we can actually get out of the data available and how to best combine the data and model components to get the maximum interpretability and precision in our predictions, we set up this demonstrator study, and the goal of this is really to investigate the influence of different virus characteristics, which might be different forms of diseases, virus variants, viral decay characteristics. So all of this can be modeled by our model components. Precipitation events influence all of this sampling protocols. So when do we take the samples, or where do we take the samples of the wastewater? And also normalization strategies can be investigated from a theoretical point of view with this demonstrator model. So as I said, to analyze all of this, we created ourselves an artificial neighborhood that represents some key characteristics that we would also find in neighborhoods of typical German cities. So we have different residential areas, recreational areas, so different areas of different characteristics where the agents would stay in at certain times of the day and move around. There are around 800 citizens in this artificial neighborhood. And we also, well, it is theoretically possible to sample wherever we want to. We picked 18 different sampling locations to also analyze the influence of the sampling location on the results that we receive. And I'll only present a very small and selected number of results. This is still something that is actively being researched, so we still want to invest some more time into this, but just to give you some first key results of this. So first thing that is obviously of interest is the influence of the sampling location and pipeline flow, it should say. So the black arrows, they indicated the direction of the flow through the neighborhood. So to summarize this briefly, it goes basically from top to bottom, and at the very bottom here in this network, we can assume that we somehow collect all of the RNA that has moved through the neighborhood. And what we can see here is that if we sample at a location at the very beginning of our neighborhood, where we have only the inflow of, let's say, 1 or 2 houses or households, and we look at the time series of the copies per liter for this specific sampling location, then we see a high stochasticity. And the further we go down this neighborhood and the pipeline direction, we see that it all kind of smooths out. And if we have this information available, how the sewage system looks like and how the information flows going through, then we can account for this stochasticity of the process a bit better, because it cancels a bit more out if like the agents move around at the beginning in comparison to at the end of the network. So this is one of the results. Another one that I want to mention is we also are obviously interested in the correlation between the copies per liter and the prevalence. And as you know, we have different sampling locations. So this is what you see on the x-axis. On the y-axis, you see the time lag, because as we've already heard in the previous talk, there can be some time shift between the infection status or the number of infections and what we observe in the wastewater. And then we can just compare these two time series for each location, shift the time series and calculate the correlation. And again, what we see is that and this is what I've tried to highlight here in the plot, that again, for the location at the very end of the pipeline system, we get the highest correlation, and that overall, the trend of this time shift seems to be somewhat similar for most locations. But it still highly depends on the location of the sampling, how this time shift looks like, and how we basically get the best indication from one to the other. So to summarize a bit what I have shown to you and what I haven't shown to you and what the next steps will be. So with this demonstrator study, we could showcase the successful integration of 2 modeling components. One can also identify suitable sampling strategies, where, but also when. This was something that I haven't shown to you. We can investigate the influence of rain scenarios, viral decay, and so on and so forth, and it's super flexible, so we can apply this for arbitrary models and arbitrary diseases that we can measure in the wastewater. As a next big step, we want to aim for the parameter estimation based on real-world data, and I think you all know that this will be a quite challenging task next. So the idea is that based on a network model that we have from Munich and data that we have from Munich, we actually try to infer the parameters of an infectious disease and inform it by not only the reported case counts, but also by wastewater data. Hence, having 2 data sources that will inform our parameters, and hopefully with that overcoming the difficulties that each of the data sources themselves inherently have. So thank you very much for your attention, and are there any questions?
Thank you very much. Questions?
Thanks a lot, great talk and really interesting. I think you referred to it a bit in the last bit. How are you going to deal with population groups? Because the incoming data you have, of course, do not tell you whether the kids have it more currently or not.
Yeah, so the agent-based model is a stochastic model. So by simulating not only once but several times, and introducing a noise model, we kind of try to capture this, but obviously we don't know. Like, we have rough values about how many kids live in a neighborhood, but we don't know where exactly they live, like in what street number they live. We won't get that information. But still, this information that we have, we will encode into the model and hope that the stochasticity of the process will capture the rest by having several simulations.
Thank you for the interesting talk. I don't really know very much about wastewater sampling. Is it realistic to have 18 sampling stations in a population of this size when actually applying this in the real world?
So we have different measurement stations in Munich, and there are measurement stations that are connected to a sewage system where like a larger fraction of the population would be captured, but we also have measurement stations that are somewhere in the city, which would be a smaller population fraction. It really depends on where you put the measurement station, how many influx households you would have in the end, obviously. But we also aim to use this approach for a neighborhood in Munich which is larger than 800 citizens, for sure. Sorry? Like 18 stations for 800 citizens is not realistic, but this was not this was not the goal of this. It was more like, can we find one measurement station that summarizes this well, and where would it be located, for example?
Short question. So I'm happy that you introduce viral decay on the line, and also by temperature dependent?
Yeah, so we can introduce whatever viral decay equation we want to. It then depends on the disease what equation is the best. Obviously, I mean, there are so many processes that happen in wastewater system. Also, if we have like more rain, then like some of the sediments that were further up in the pipe suddenly get flushed out, and we can measure them as well, like having these high rain, high peak scenarios in wastewater samples sometimes. So there is a lot of things to consider, and I guess we have to see, and I think you already did some quite interesting work in that direction, how easy can we make the model while it still would work. And I guess especially with the viral decay, there are a few options to try to make it easier, because if it's underground, the temperature is relatively constant, but yeah.
So let us thank the speaker again. And the next talk is given by Karina Wallravensam, again from the University of Bonn and representing the INSIGHT Consortium. And the title of the talk is Cost Effectiveness of COVID-19 Vaccination Strategies in Resource-Constrained Settings, Data from Ethiopia.
Welcome to my presentation on the cost effectiveness of different COVID-19 vaccination strategies in resource-constrained settings, with a specific focus on Ethiopia. As background, Ethiopia initially received about 2 million AstraZeneca vaccine doses manufactured by the Serum Institute of India in March 2021. For context, the country has a population of about 120 million people. Their plan was to receive a further 7 million doses by May 2021, but this ended up being delayed. So these vaccine shortages raised the question of how best to distribute the limited vaccine resources they had in order to control the public health crisis, while accounting for the fact that many people had already been exposed to the virus by the time the vaccine rollout started. So this presentation will explore the question of how can we identify the most effective vaccine strategies for a specific context, accounting for immune response dynamics, local seroprevalence, and resource constraints there. So looking to the future, answering this question can help us formulate effective vaccination strategies against future waves of SARS-CoV-2, as well as outbreaks of other vaccine-preventable diseases. To this end, we used data collected by our collaborators in Ethiopia on 254 healthcare workers in the Jimma region. These participants had their anti-nucleocapsid and anti-spike antibody levels measured just before and 3 months after their first AstraZeneca vaccine dose in April 2021. We then used this data to compare the cost in US dollars per percentage point increase in the percentage of the adult population of Ethiopia with anti-S antibody levels above 275 binding antibody units per milliliter, compared to a no vaccination strategy for 3 vaccination strategies that could have been implemented at the time. 1, giving 2 doses per person until vaccines run out, 2, giving 1 dose per person until vaccines run out, or finally giving an individual antibody test to each vaccine eligible person and then giving 1 dose if that test indicated a previous infection or 2 doses if not. Meanwhile, our collaborators also created an antibody dynamics model in which the population was divided into 9 combinations of low, medium, high anti-N and anti-S antibody levels. So in this model, an infection would move a person up to the next higher anti-N and anti-S category. A vaccination would just move them up an anti-S level, and then waning would move them down a level. And then depending on which category they were in, a multiplier would be applied to the transmission rate. This model was fitted to several data sources. First of all, the results of a longitudinal serology study in which participants in the Jimma and Addis Ababa regions of Ethiopia had their anti-N and anti-S antibody levels measured in 5 study waves, sequencing results from those antibody study participants, self-reported vaccination data from those participants, and then the national PCR test positivity rate over time. On the cost effectiveness side, assuming a 61.3% of prevalence prior to the start of the vaccine rollout based on the results of our healthcare worker data set, we can see that the cost per percentage point increase in that immune proportion is minimized for the 1 dose per person strategy, that's the light blue line, unless an antibody test with perfect sensitivity and specificity in this case had been available for less than 0.63 US dollars per test, which is quite unrealistically low. And then on the right side, we can see that this conclusion is sensitive not just to the cost per test, but also to the proportion previously infected. So for 61.3%, we're pretty firmly in that top region where the 1 dose strategy outperforms the 2 dose strategy, but had the proportion infected been lower, that could change. We also repeated this for the more effective but more expensive Pfizer vaccine. This wasn't distributed in Ethiopia, so for this we used previously published data from the UK. But we can see, again, the 1 dose per strategy, 1 dose per person strategies outperforming the others, unless in this case the antibody test had been available for less than $2 US dollars and 10 cents per person. Again, we can see that these results are sensitive to the prevalence of previous infection, but one thing to note is that the relative performance of these different strategies isn't sensitive to the number of vaccine doses, but of course the absolute performance would be. So for that, we can turn to the antibody dynamics model. We used this to test counterfactuals in which the vaccination rate that was actually seen in Ethiopia was scaled up by a factor of 5 or a factor of 10. And we can see that for the factor of 10, the Delta wave there in fall 2021 is almost completely eliminated, and the Omicron wave is about halved, although there is more uncertainty in that prediction. This model also, the parameter estimation for this model also predicted that the values of the rates of antibody waning for both anti-N and anti-S were quite slow, and as a result, that by the end of the model timeframe, end of 2023, up to 100% of the population was in the high category for both anti-N and anti-S antibodies, suggesting that further vaccination at this point might have a negligible effect. So taking these results together, Our main conclusions are that in order to come up with the most effective strategy tailored to a specific context, you need centralized testing in order to get an idea of what the previous exposure to infection was. And then finally, and the crucial takeaway is that in a high burden, low resource setting like Ethiopia, it would have been best to reach as many people as possible with the vaccine as quickly as possible, even if that meant accepting the trade-off of only being able to give 1 dose per person instead of the recommended 2. Thank you, and happy to take any questions.
Thank you very much. We have time for some questions. So then let me start with a question. I'm a bit surprised about this 1-dose regimen, which proved to be not efficient for human population, to my knowledge. That's the first question. And the second is, did you also consider non-uniform distribution of vaccinations? Because I would first think when resources are limited, then one should first restrict to vulnerable patients or persons with a large number of contacts.
Yeah, regarding the 1 dose per person strategy outperforming the 2 dose per person, we're assuming here that we have like 70 million adults and only 2 million doses to distribute. Of course, the ideal would be to give 2 doses per person, but in the question of how best to distribute these very limited vaccines, because so many people already have the infection-based antibodies, it was better in this particular scenario. It would have been better to just reach as many people with 1 dose, and then 60% of those would have already had some baseline antibodies, and then together they could get to a higher level, even if they didn't get that 2nd dose. And I'm sorry, I forgot your second question.
Yes, this non-uniform distribution, for example, prioritizing patients with vulnerable and persons with many contacts or something like that?
We did not look specifically at targeting specific populations, so that would be further work. Yeah.
Other questions? Then let us thank the speaker again. Next talk is given by Juri Chefetz from the University of Leipzig, representing the Prognosis Consortium, and the title of the talk is Modeling Complete Dynamics of SARS-CoV-2 Pandemics of Germany and its Federal States using Multiple Levels of Data.
This one is okay. This is a point. Yes, yes, moment. Sorry, wait a minute.
Dear colleagues, I'm happy to present to you our work from EMISA, Leipzig University, the modeling of complete dynamic of COVID in Germany and its federal states using multiple levels of data. So the aim is to describe, to fit complete information about daily data on daily infection rates, daily deaths, and daily hospital occupancy and intensive care units occupancy in 17 federal units during 3 years. So it's nearly 300,000 data points. It's and to evaluate dynamical and system parameters, to evaluate effectiveness of non-pharmaceutical interventions, vaccination, contact reduction, and mask carrying, and to estimate requirement of medical resources for intensive care units. And the aim is regularly predict the pandemic under different scenarios. So there are two the big problems is the bias of reported databases. So there is a big lack in reporting of data, and the DOF cases are censored. So Robert Koch Institute doesn't allow to know when people exactly died because of data protection. And there are changing external factors, which mostly empirical and not rational, such as changing testing policy, which influence dark figures and different variants of COVID, and vaccination campaign and non-pharmaceutical interventions. So the aim is give predictions after the model fitting. So our model is based on a secure model. So we have infectable age compartments, which are stratified by age. There are 5 such compartments, so susceptible and vaccination compartments, and we have a infected submodel. So the compartments which are infected, and so there is a 3-dimensional tensor of such submodels. So 5 age compartments, sex or more virus variants, and immune status. And we have a hospitalization compartments which shows normal and intensive care units. So the input data.
Yuri, could you please speak to the microphone? That's better.
Sorry, I wanted to. The input layer is responsible for external data, and output layer is uncertainty of data. And here you can see the immune status interactions. So we assume that after immunization, after vaccination, there is a perfect protection against death and hospitalization cases, and a large reduction in infections. But due to waning, this protection decreases rapidly in 2 stages, and in the 3rd stage, the probability of die or to be hospitalized is not 0, and the people must be boosted in order to renew the vaccination. So we have 90 submodels, 3-dimension for immune status, 6-dimension for alleles, and 5 age compartments. And here are the fits. The continuous lines are our simulation, and discontinuous lines are the data. So there is 3 years of daily measurements of new registered cases for 17 federal units and 5 ages. The ages are shown in different colors, and you see the second graph is the empirical infecting rate due to non-parametric, non-pharmaceutical interactions, and the third is the distribution of alleles. So you see a good fit of distributions of all modeled 6 alleles: alpha, gamma, delta, and 3 BA1, BA2, and BA5 Omicron alleles. And here are also the similar graphs of fits of hospitalization, intensive care units, and deaths. And here you see the simulation of changes of distribution of vaccination. So after 2 years, there are almost no naive patients. And you can see the results. The left pictures show cumulative deaths for different federal states, and you see that Saxony-Thuringia has the largest death per 100,000 persons, and we think that it is not only explained by behavior and low vaccination, but also depends on age distribution, which in Saxony and Thuringia there are more older people than in other federal states. So we have successfully simulated age-structured model. We coped with imperfect data, delays, incomplete data, changing NPI, new virus variants, and vaccination and immune waning, but we did not yet model seasonality and local heterogeneity. And so our feedback is to be modeled, and we are regularly updating by our predictions for a few months period. Thank you very much.
Thank you very much. Questions from the audience? Yes.
Yeah, thank you very much for the interesting talk. A question to the outlook. If you speak about local spatial heterogeneity, what do you mean by that? It's just demography or also reaction to NPIs?
Local specialists that in different regions of federal lands there are different pandemic dynamics and the interaction between different geographical subjects. In this work, we did not model special interaction between different geographic subjects. We estimated parameters and we constrained individual variability between parameters of federal subject, but we can also model how federal subjects interact due to infection transfusion between them. Yeah, but it is in the future to be done.
How have you tackled different dark figures at different times, or detection rates, let's say?
Well, this is very interesting questions. Holger Kirsten make different modeling of this. So there are Robert Koch Institute and other sources weekly information about dark figures. So there are estimations which we integrate in this model. So every week there are independent estimation of dark figures. So we do not estimate them, we use existing as well as, for example, contact matrix. We try to use full information approach and to use external information as much as possible, all available information.
So, Holger, do you would like to add something? So we used different approaches and different data sets to estimate the dark figure, but indeed that was the most serious issue which we had the most serious headaches about. Other questions? So thank you very much. The next talk is given by Felix Günther from the Robert Koch Institute, representing the Respinau Consortium. And the title of the talk is Fitting a Dynamic Transmission Model of Meningococcal Carriage and Vaccination to National Surveillance Data and the Vaccine Coverage in Germany in between 2005 and 2019.
Yes, hello. Thank you very much, and thanks for the opportunity to talk about this model of meningococcal transmission in Germany, and in particular, how we fitted it to data. This is not really related to RESPI now, but it's rather based on work on a project funded by the GBA, the project called AMSEC. So in our team for vaccine and vaccine preventable disease modeling at the RKI, we conduct modeling projects on immunization strategies in Germany. And these are also used to inform STIKO, for example, in their consultations. This is often done based on dynamic transmission models, and it's really important that these models reflect the epidemiological situation and transmission dynamics in Germany. This is why model calibration is so important. Today's talk will be about a dynamic transmission model for meningococcal transmission in Germany. That's a bacterial infection that can lead to severe invasive disease. The largest disease burden is in young children, but then there's also some disease in adolescents. And there is regular vaccination in infants, but currently there are discussions about whether to also recommend a booster vaccination during adolescence. And then there are two different types of vaccines, a mono and a polyvalent vaccine against multiple serotypes. Today will be mostly about calibration of the model to epidemiological data. How does this model look? It's a dynamic transmission model on the asymptomatic carrier level. Individuals can therefore move between susceptible and carrier compartments, as illustrated here. In the model, there are 3 different serogroups, so there's not only one carrier compartment, but actually 3 different carrier compartments, and we include 86 different age groups indicated by this subscript I here, and one individual can only be carrier of one serogroup at a time. Expected symptomatic disease cases are derived from incident carriers and a so-called case-carrier ratio, and vaccination is included through additional compartments. And one aspect is that a vaccine can reduce the force of infection, as shown here. So the risk of becoming carrier for a specific serogroup, and this depends. So it can potentially reduce this carriage, and this depends on the vaccine which serogroups this might affect. It can also reduce the case-carrier ratio, so the probability of becoming actually the disease, and the protection wanes over time. This is included through additional compartments, and this is also where actually this booster vaccine comes into play. Such a model has a lot of free parameters, and some of them, as for example the vaccine efficacy and duration of carriage, are specified based on literature. Then there's some estimation of relevant parameters like the case-carrier ratio from external data, and during the calibration, we want to estimate parameters that govern the force of infection. We use data for calibration, or we use the national surveillance data on invasive meningococcal disease cases by age, year, and serogroup that are available via SurfNet, and then also account for uptake of this conjugate meningococcal C vaccine by year and age. This is done based on insurance claims data. And for the method that we use in calibration, we use maximum likelihood estimation. Most of you might be well aware of how this works, but like the intuitive approach is to integrate the transmission model for a specific combination of parameters. This then yields age and serogroup specific yearly number of expected IMD cases. These are compared with the actual data, and is repeated in an intelligent way to find parameters that fit the data best. More formal, this corresponds to a numerical minimization of the log likelihood, assuming a Poisson distribution of the observed IMD counts. This maximum likelihood theory facilitates uncertainty estimation, and we use 2 different models for the force of infection in the model with also 2 different specifications, and then select the best model via a model selection criterion, for example, the archaic information criterion, and this is essentially a trade-off between model fit and complexity. So here are formulas for those 2 different types of specifications, models for the force of infection. They are basically versions of standard age-structured models. So the force of infection for a specific, see, this doesn't really work anymore. For a specific serogroup is a function of, in a specific age group at a given time, is a function of context of this age group with other age groups. and then the fraction of carriers in this specific age group. And to give this whole thing a bit more flexibility, we included some additional parameters that we estimate during model fitting. In this first model, we have 2 scaling parameters for the contacts. So these are parameters that are between 0 and 1 and are supposed to scale the observed contacts, Cij, towards contacts that are actually relevant for meningococcal transmission. And then we also estimate parameters, serogroup-specific transmission rates for, and this is then the force of infection here. The second model is a bit less structured maybe. Instead of including serogroup-specific transmission rates, we include sero and age group-specific transmission rates. So here we have now this I superscript subscript instead of these scaling parameters. And for both models, we fitted each model with either 4 or 8 different age groups, so we combine adjacent age groups into either 4 or 8 age groups. So to come to the results, based on the model selection criteria, we selected this model 2 with age groups, and here we see how this fitting worked. The columns represent the actual observed data over time from 2005 to 2019, and dots and arrow bars represent the expected values based on the model. On the left-hand side, we see this here for the whole population, and overall the historical trends in all serogroups were fitted rather well. If we look at age-specific results or in age groups, we observe that it works quite well as well, but there are some problems in some subgroups. For example, here for serogroup C in the 20+, it seems like we're underestimating the disease or the disease burden a bit towards the end of the calibration period. To sum up, we developed and fitted a dynamic transmission model for meningococcal transmission in Germany. This is used then for quantifying effects of new immunization strategies based on simulations from this model. Some discussion of the methods. We used maximum likelihood estimation as a principled approach for parameter estimation and uncertainty quantification. However, it is of course always conditional on the structural assumptions of the model and also on specified parameters. Such a complex model requires specification of multiple parameters, and we can use sensitivity analyses to quantify and investigate effects of these assumptions. And an alternative would be, from a methodological perspective, to use a Bayesian approach that also facilitates joint modeling of multiple data sources and then forwarding of uncertainty through these analysis steps. And then maybe some more general comments. Calibration of complex models sometimes referred to as an art rather than science, but this is, this might sound exciting to some, but it's from a scientific perspective maybe not the most satisfactory description of this whole thing. So I think there's a really important and interesting field. We could use some formalization and best practices on how we really should do such calibration tasks. At the core of model calibration is of course always the data, which we have to really understand really well, and this also calls for interdisciplinary work. And another aspect might be that the modeling and calibration can also inform about where maybe data is still missing and where we should invest some money in gathering additional data to reduce uncertainty in our modeling efforts. Thanks a lot.
Thank you very much. Questions?
Yeah, thank you, Felix, for the presentation, and thank you for finishing the project that I started 4 years ago, 5 years ago. It's great to see it come to an end and successfully so. I have 2 questions. One is that the classical Christensen pedigree of models for meningococcal disease, they always have these kind of incidence approach where they calculate the IMD cases from the newly infected. So the people acquiring carriage, they are at risk of becoming IMD, and as soon as if you're just a prevalent case, you have no risk at all. Can you please elaborate if that's also the case in your model, or whether you chose a prevalence approach? And the second is, did you look at meningococcal B vaccine uptakes? Because if I saw correctly, what I found quite interesting is that the model, I think, underestimates or overestimates the MB cases in
in kind of the last years, and I know it's not been reimbursed, but still there were some extent of Man B vaccinations taking place. Thank you.
Yes, so I think regarding the first point, it's basically the case that we model on the carriage level, and then in the model you can track how many people got incident new carriers over a year, for example, and then you apply the case carrier ratio to it to get the expected number of invasive cases. This is, of course, one of those central structural assumptions of this model and might be a bit different in reality, but nobody, I mean, this is an area where also information is lacking a bit, I feel like. The second point, we didn't explicitly account for Man B vaccination in this model here. I mean, calibration period was until 2019. We have now the official recommendation for Man B vaccination also in infants, basically. This, of course, an aspect that has to be accounted a bit for during the forward simulations now, I think, if you want to really evaluate the effects of vaccination. Thanks.
Can you go back to slide 6, I think? Yeah.
This one here?
So the right-hand side diagrams show that the model fits the data quite well.
Yes.
But as far as I understand, this is the same data that was used to fit the model itself, right?
Exactly.
So it's the training failure.
Yeah, it's the data during the calibration period.
Yeah. Do you also have validated your fit independent test data?
Well, I mean, that's always a bit difficult with this real-world data. I mean, what we could do is, for example, fit the model only for 10 years and then predict, basically. We didn't do this here, no.
Yeah, because, I mean, you often see very severe overfitting, right? And then the predictive power of the model is low.
Yeah, I agree. I mean, the idea here is a bit, of course, I mean, here we try to calibrate the model to the data that's available so that it represents the epidemiological situation in Germany during this period, and then our further evaluations will be based on counterfactual simulations based on these fitted parameters. And there we can also try different scenarios because, I mean, there's also this extrapolation part in the future, right? So I think for quantifying relative effects of different vaccine strategies, well, that's not super common to do these kind of, I mean, we're not doing predictions here for the development in the future directly, but I agree. I mean, it's an interesting point to think about evaluating such models based on holdout samples, for example.
Okay, thank you very much. Let us thank the speaker again. And the final talk of this session is provided by Isti Rodia from the Helmholtz Center for Infection Research, representing, again, RESPI. And the title of the talk is Improving Post-Pandemic RSV Projections in Germany, a Comprehensive Approach Integrating Adaptive Dynamic Modeling and Population-Based Data.
Thank you for the introduction. So I will present our research on RSV modeling, integrated population-based data. So as we all know, a lack of population data and insufficient parameterization of RSV model have made it difficult to estimate RSV infection effectively. And only a few studies have attempted to estimate the high number of RSV hospitalization, especially in Germany. In response to this challenge, our research takes a comprehensive approach by integrating RSV model and population-based data. So we aim to improve our understanding of RSV dynamic by using population-based data and sentinel surveillance data. And we also build a projection for case and hospitalization of RSV in the season to 2023-24 in Germany. Yeah, so for the integrated data source in our model, we incorporated social contact pattern by polymod for the pre-pandemic period and coffee mode for the pandemic period. In terms of new cases dataset, we rely on multiple source to capture a comprehensive picture of RSV dynamic. So first, we use weekly notification RSV data by Surfstat RKI, and then we also use weekly RSV new cases data by ARI Sentinel and GripaWeb. And last, we have the reinfection proportion by Musbat population data from 2020 to 2023. And we also incorporated hospitalization data from weekly reported SARI RSV hospitalization by RKI. And yeah, using ARI Sentinel and GripaWeb data, we calculated under detection factor compared to notification data. So here we have a higher number of under detection factor. Moving on to population data. Here we show the proportion of RSV reinfection in adult based on Musbat population data. And yeah, for our model structure, so we have a compartmental model here, and we incorporated a reinfection process, and we also distinguish susceptible people into 5 levels based on immunity from getting infection. Yeah, for the simulation process, so we have model, and then we fit our model into 3 different data set of cases. So we have notification of Surfstat RKI, and then we have notification with under detection factor, and the last we have population data. And after that, we also fitted again our model into hospitalization data. And yeah, after we obtain fitting parameter of infection and hospitalization proportion, we run the model. We simulated the model to obtain the projection of notification cases, overall infection, and hospitalization. Yeah, this is our fitting result of weekly reinfection proportion for notification data. So here for the figure A, this is the, So figure A, this is weekly reinfection proportion for the pre-pandemic, and figure B is weekly reinfection proportion for the pandemic period. And we have to carefully, because the figure A and figure B have a different scale, so it means in pre-pandemic period, the weekly reinfection proportion always below 1.2%. Meanwhile, in a pandemic period, we have a higher weekly reinfection proportion. So yeah, this is our projection of notification data. notification cases. So yeah, we can see here for projection of notification cases, we can see that children under 5 years old is dominant in RSV infection. Yeah, and this is our projection for overall infection. So we incorporated under detection factor in figure A, and also population data in figure B. So when we incorporated under detection factor and population data, we get the higher number of cases, and we also can see here we have the age distribution of RSV dynamic change differently. And yeah, this is our projection of hospitalization in 3 different data set of cases. So yeah, we have first the projection of hospitalization for notification substat data, and then we have projection for notification with under detection, and then the last this is projection of hospitalization for population data. And our projection is integrated into third MONID scenario modeling statement. And actually here we can see that our projection do not align closely with the data. But yeah, here we calculated the total number of our hospitalization projection, but here in the total, the peak of our projection, it's not too far with the peak of the data. And for the conclusion, our model can describe the RSV dynamic from 2017 until 2023 using both sentinel surveillance data and for population data from 2020 to 2023. And then our projection were in line with notification and hospitalization data, but with an even more delay season in comparison the 2 previous season than predicted. And both population data and sentinel surveillance will be essential for evaluating potential change with incoming prevention strategy. And we would thank to our partner and funding agency, and thank you for your attention.
Thank you very much. Maybe one question from the audience.
Thank you, Isti. I don't want to take up all the question time, but I have 2 questions. One, could you elaborate a bit more on how you calculate the underestimation rate? Because I understand that GripaWeb only gives you the number of symptomatic ILI, ARI cases, whatever, and then just a bit more elaboration. And the second one, I was a bit surprised because in the 2022-23 season, it seems like when you look at the DRG statistic, you see a much higher number of cases in 60 plus and the elderly in general. You can really see that pick up after the pandemic. And I was wondering if you also looked at that data, or if you just used Icosari, and how the differences could be explained. Thank you.
Okay, so for the underdetection factor, actually, so we have the data from ARI Sentinel and GripaWeb, and then we just combine the data, and we just divided the combine data with notification cases from ServStat, actually. Yes. And then for the cases, so for here, we have higher in 80 plus. Actually, we also don't have the exact reason, but we just predict that because in pandemic period, especially in the season 2021, it's the number of RSV is very low, and then we just thinking that because the NPI of COVID-19, then after that in the next season we have more susceptible people. That's why in the next season we have higher the infection of RSV.
Okay, so thank you very much. Let us thank the speaker again. And with this, the session is closed. Thank you very much for the talks and discussions. And I would like to hand over to Berit and Martin, I guess.
Die sind an.
Das an?
Ja. Die sind, ja, nee, das ist noch, weil ich hier bin gerade. Ich kann mich nicht zerteilen.
So I can start while we still do the technical stuff. Just a quick introduction. So a lot of what we do in MONID, of course, is currently on respiratory infections. And we thought it's good to also specifically talk a bit about that, because that comes with specific challenges, and a lot of these we have heard about in the last hour or so. For that, we wanted to get people a bit from different backgrounds, talking about different things, so both interaction, also vaccine modeling, but also then network modeling maybe, but really thinking about how can we parameterize these models, because that often, it comes with a lot of challenges. It comes with interactive challenges, but it also comes with us having the data challenges, as we have seen. And so what we will do for this panel, if we get the technical things done, is that we will have 3 inputs for around 10 to 15 minutes each. We are not under time pressure, so don't worry, you don't have to run through your talks, I think. And then we would have a bit of a discussion around these topics. Before we do that, though, we wanted to remind everyone of the consortia in MONID that are particularly concerned, I hope at least, with respiratory infections. Ja, und jetzt, ist das richtig?
Ist das an jetzt? Ist es nicht an, ne? Ach so, okay.
Yeah, okay. And so we will just, the two of us will quickly go through the main consortia dealing a lot with respiratory infections. This is also, it wasn't just the two of us organizing it, but it was also Markus Scholz and it was Jan Hasenauer who did that with us. And we will, I think, hopefully have a nice discussion with all of you later. So you start, right?
Yeah, okay. We will present 4 different research consortia, and this is, of course, not a holistic view on MONID, but just a selection. And we wanted to use this as an introduction what are particular challenges in different research projects on parameterization. And first of all, just very, very briefly, I want to present the Loki project, which is very much focused to the application in local health authorities. So in the upper left corner, there's the LHA, and there is some data that goes to some data platform. We have some optimization pipelines, etc., going through models, and this will be then played back to some visualization that is tested and done with studies with user experience in the local health authorities. And two main challenges here in the parameterization is that we need a high spatial resolution because the local health authority want to see what happens in my region and not what happens in the entire federal state. And another problem is if we talk to decision makers and to local health authorities, we not only have to assess uncertainty, but also to communicate uncertainty. And with that, I want to conclude here. As I said, just very briefly to maybe initiate a little bit the discussion later on current developments and problems. In the Insight project, we have another issue that we are working on. We basically, as you heard already in different talks today, we have two types of models. So we have a more standard compartmental model, testing-based model, and we only know that someone is infected if he or she got tested. And on the other hand, we include wastewater data to infer also from the wastewater data or to make both models inform each other to get a better view on infection dynamics. And of course, an inherent problem is here that we have two different model types that have to be parameterized. And also, as you heard in Nina's talk, that we have a stochastic model which poses additional difficulties. And this also concludes the presentation of Insight, and I hand over to Berit.
Yeah, so Webinar, we've heard a bit about it. I wanted this to go with animations. Obviously, that hasn't worked, so now it's a very full slide. Yeah, that's great. Okay, but still everyone, I think, at this point knows the basic structure of RESPI now. So we have evidence synthesis, we have population-based surveys, we have integrated modeling of multi-pathogen models, and then we also do a forecast hub with a lot of really nice researchers from all over Germany. And just to show a bit, so here, in the first part, evidence synthesis, we have now gone through a lot of the European data and looked a lot into the heterogeneity of different respiratory infections, in particular RSV and influenza, with surveillance data, but also with data from literature. We have already heard a bit yesterday and today also on the population-based surveys that we are doing, where we are really trying to get epidemiological indicators, in particular of reinfection of RSV and influenza, and then integrate that into models. And this also provides us with a bit of understanding of how the 21 and the 22 and hopefully then the 23 season of RSV and influenza actually went on and what the different dynamics in different age groups were. And then we try to build up integrated models, and we also contribute to scenario modeling with that. And we have now built up a forecast hub that has done a better season now and will then do in 25, hopefully first real season, basically. And the questions we are continuously struggling with is this question of what are actually the relevant epidemiological indicators that we need to use, and how do we then integrate them into the models? How do we make sure that the data provision that we have now really nicely set up is then actually sustainable? And how do we automate these data flows that goes a bit together with sustainability? And then which interactive effects in the multi-pathogen models should we really be taking account of? And then for prognosis, Marcus will correct me if I'm telling something wrong, but basically this is something where we also, where Marcus works a lot on RSV, influenza, and pneumococcal disease. And again, there's a part on data collection, and there's also a part on short-term and epidemic forecasts, but very much tailored to the hospital situation. And then there's also a part where the project is trying to generalize to other epidemic models and then actually describing the short and the long-term burden of different respiratory infections. And the problems that this consortium is dealing with is the question of high-dimensional parameterization problems of models to different local scales, and the question of reinforcement learning and, of course, assessing parameter uncertainties. So with that, we go to the first talk. And as I said, so the later discussion that we will have is, and this is why we presented the consortia again, is a lot on what can we actually learn from the colleagues that we have invited towards our consortia as well. So for the first talk, you can maybe get it up. For the first talk, I would like to invite Sarah Kramer. She's a postdoctoral researcher. She has a lot of expertise in the interaction of respiratory pathogens. She's currently at the Max Planck Institute of Infection Biology in Mathieu Domenech de Sel's group, and she has a background in mathematical modeling with a PhD in environmental health sciences from Columbia University. So welcome and great that you're here.
Thank you so much for the introduction. Oh, does this one not work? I will use this one instead then. All right. Thank you for the introduction. Yeah, as was said, I'm going to be talking a bit about how we can parameterize models specifically of pathogen-pathogen interactions. So when we say pathogen-pathogen interaction, what we mean is that being infected with some pathogen A is going to influence your chance of infection or disease with some pathogen B. And these interactions are really complex. There are a lot of characteristics we care about when we're trying to understand them. So, for example, we care about the sign of the interaction. So, is getting infected with pathogen A going to increase or decrease your chance of infection or disease with pathogen B? We also care about the strength of that effect. So, to what extent is it increasing or decreasing your risk? We also want to look at the duration of the interaction. So, how long after your infection with pathogen A is that reduction or increase in susceptibility still present? And finally, we care about whether the interaction is symmetric. So is the impact of pathogen B on A the same as the impact of pathogen A on B, or do they differ? And the reasons we care about these are, first of all, because even though they haven't really been super well studied in the past, it's becoming more and more clear that these interactions, and not just interactions between two pathogens, but these very complex webs of interactions are pretty common. We also care because even though these are operating typically at the individual level, they can sometimes have quite profound effects on the population level. So they may influence how both pathogens transmit throughout the population, and they may also influence the effects of control measures. So for example, if we have a negative interaction and we vaccinate against pathogen A, we may actually expect that there is a resulting increase in the burden of pathogen B, which is definitely something we want to be aware of. There are a few fairly common basic observational statistical approaches for trying to understand interactions. Unfortunately, these methods are very prone to failure. So one such method is the prevalence ratio, and this is looking at comparing the observed frequency of co-infections to what we expect the frequency of co-infections to be, assuming that if there's no interaction, the co-infection frequency is going to be the frequency of pathogen 1 times the frequency of pathogen 2. Unfortunately, what a simulation study from our own group showed is that this metric tends to systematically, or doesn't tend to, systematically underestimates the strength of interaction. So the dotted line here is what you expect to see if the true interaction on the x-axis is actually estimated properly by the prevalence ratio on the y-axis. Again, what we see is that there's consistent underestimation, and in fact that this underestimation gets worse the stronger and longer lasting the interaction is. And this is the case where we have a very simple interaction where the strength of the interaction is the same both during and after infection with pathogen A. If we instead look at interactions where the strength is actually greater post-infection, we see that sometimes this metric even gets the direction wrong. So you could have a negative interaction, but this metric is going to find that there's a positive interaction. Another common metric is the phase difference, so looking at the extent to which the outbreaks of two pathogens overlap in time. And what we might expect intuitively is that this plot on the left might be due to a negative interaction because these two outbreaks are separated in time, and this is due to a positive interaction because those are very, very similar in their temporal dynamics. However, these plots are both from a simulation study by Shrestha et al., and they're both generated using the exact same set of parameters with a strong negative interaction. And in fact, what the authors found was that there really wasn't any reliable way to look simply at phase differences and say anything about the direction or strength of an interaction. So a big reason these methods are failing is because they're very simply just looking at the outbreak patterns that we see, and they're not accounting for the complexity and the nonlinearity that are inherent in infectious disease transmission dynamics. So we thought mathematical models, which can explicitly account for the mechanisms that are underlying transmission and interaction, might be a better tool for trying to estimate these and characterize these pathogen-pathogen interactions. So I want to talk a bit about the main project I'm working on now, which is attempting to infer the strength and the duration of the interaction between influenza and RSV using both observational data on outbreaks in human populations and a model of flu-RSV co-infection and co-circulation, with the quick bit of background that experimental studies in ferrets and mice have shown that being infected with influenza seems to be able to inhibit infection with RSV, so that suggests there might be a negative interaction here. I want to start with walking through our model a bit. This is an SIR model. We're modeling each season basically separately, so we're not accounting for loss of immunity. Here, red is indicating influenza infection, blue RSV, and purple is co-infection. And how we model the interaction then is that if you are either fully susceptible with, say, flu, or if you are fully recovered, from flu and you encounter RSV, you're going to get RSV at some normal rate, so just the standard force of infection. But if you are either currently infected with influenza, or if you have recently been infected with influenza, and that's this transient post-infectious state we have here, the T compartment, your chances of getting infected with RSV are reduced by a factor of theta, such that if theta is 1, there's no interaction. If theta is 0, it's completely blocking RSV infection. And then how we model the duration is with this delta parameter, so the rate at which you leave this post-infectious state and become fully recovered. We also do allow for there to be an effect of RSV on flu, and we allow for the strength and duration of this effect to differ from the effect of flu on RSV. So in other words, we're allowing for an asymmetric interaction. Really quick, the types of data we're using for this are, first of all, virologic data on the proportion of tests that are positive for flu and RSV over time, as well as some syndromic data on the rates of influenza-like illness over time. And so those second ones are purely based on symptoms. No testing is done there. We have data right now from 3 locations, Hong Kong, Canada, and Health and Human Services Region 8 of the United States, which encompasses several states within the US. Here I'm just showing Canada for simplicity. We then fit our model using a maximum likelihood approach, and what we do more specifically is we've separated our parameters of interest into, first of all, season-specific parameters, and these are things like the R effective and the proportion of the population immune to either virus at the beginning of an outbreak that we expect to change fairly substantially from year to year. And we also have shared parameters. These are things like the strength and duration of the interaction, as well as parameters that control the seasonality of the force of infection of both viruses that we don't expect to change over time. And what this allows us to do is to take data from several seasons into account when estimating these key parameters, which we hope makes them easier to estimate and gives us more accurate and more precise estimates in the end. What we do then is first fit to individual seasons to get good initial estimates of these season-specific parameters. We then move on to fitting the model simultaneously in all seasons for a given location, this time constraining those shared parameters to take the same value in every season. And we've been obtaining confidence intervals using parametric bootstrapping. To run through the results we have so far, we have results for interaction strength on the left and interaction duration on the right. Starting with strength, so far what we're seeing is that the data in Hong Kong and the US seem to be consistent with a very strong interaction effect. Again, remembering that 0 means complete inhibition. So we're getting almost complete inhibition of RSV when model individuals are infected with influenza. We're seeing a bit of a weaker effect based on the Canada data, where it seems to reduce susceptibility by a little less than half. If we look at duration, again, we're seeing a few differences between locations. So in particular, we're seeing a duration of 3 to 4 months in Hong Kong, 1 to 2 months in the United States, and this rather wide confidence interval in Canada. I want to touch on this a bit because we don't really expect, of course, to see these large differences in especially the interaction strength between different locations, I don't think. So what could be going on here? And the first thing is that there could be underlying features of the population that differ in these regions. There could be differences in health status or differences in the underlying circulation of some other interacting pathogen, differences in behavior that may confound these parameters that we're trying to estimate. I think it's also worth noting that Canada and the US are very large geographic regions, which could make the signal of this interaction at the population level a little bit harder to identify. It's also, of course, just possible that, these are parameters that sometimes have a very subtle effect at the population level. It may just be that in some cases, data from a single location are not going to be sufficient to estimate these, in which case what we'd like to do moving forward is, first of all, try to acquire data from more locations and fit the model in additional locations, and also explore the possibility of fitting multiple locations at once so that we're able to constrain these interaction parameters to take the same value in all locations, and see if either of these methods is able to give us a bit of a better consensus. I think it's also important over time to do a bit more synthetic testing, so just looking at simulated outbreaks and trying to explore what patterns in data allow us to estimate these parameters and which patterns in data make these parameters difficult or impossible to estimate. So I want to close by talking a little more about some of the limitations of this approach and some of the challenges that we faced. The first is that these models do have a lot of parameters. So we have a lot of season-specific parameters in particular. In some cases, we're fitting upwards of 70 parameters when we're trying to fit these models. And that means that this is very computationally intensive. And that is why we've been using a pretty simple maximum likelihood approach rather than something like an MC-MC approach, which might be a bit more elegant. It's why we're using a deterministic and not a stochastic model. And it also means that it's going to be challenging to add additional complexity to the models, like age structure or like strain dynamics, which might ultimately be really important and interesting questions to explore. We've also found that the identifiability of these parameters is highly dependent on the underlying transmission patterns of both viruses in the population, by which I mean that to estimate these parameters, there needs to be signal of this individual level interaction at the population level. And we can think of a lot of situations where this might not be the case. So if we have a population, for example, where there's a really strong effect at the individual level, but flu and RSV are just circulating at totally different times in the year, we don't really expect to see signal of it at the population level. Same thing if we're really just not doing much testing for influenza or RSV, and we only have a very small number of cases. And indeed, we did originally try to fit our model to data in France, and found that these parameters were unidentifiable, which is not to say that those results are inconsistent with what we've shown in the previous few slides, just that the model could not distinguish between a very strong interaction and no interaction. The likelihoods were essentially the same. And what we see in these data here are that, with the exception of the 2009 pandemic, in every other season, RSV is peaking before influenza. And we believe that this potentially makes it difficult for the model to capture the impact of influenza on RSV, since the bulk of the influenza outbreak isn't really happening until quite a bit of RSV has already finished spreading through the population. Again, I think it would be useful to do additional simulation studies to understand the extent to which this is a problem and to help us be able to look at data from different locations and be able to say, okay, it has this characteristic or that characteristic. This is likely to be successful or unsuccessful with our method. And with that, I just want to thank a few of my colleagues, in particular Mathieu, my advisor, Sarah, who's another postdoc in our group who continued this work while I was on maternity leave, and then Laura, Libby, and Annabelle, who are 3 PhD students who put together that really lovely figure at the beginning showing all of the different characteristics of interaction. If you have any questions or comments that don't get covered in the following discussion, please feel free to reach out to me.
So we would do the main question part while we do the discussion. So maybe just very short questions now. One very short question on,
yes.
So obviously the different seasons that you're getting in have different strains, may also have different RSV groups. So have you looked into that at all with available data?
I mean, we've plotted out to see are there any sort of significant differences in the patterns between influenza A and influenza B, at least, is the data we have. And typically those tend to overlap each year, so we've been combining them. Of course, if those influenzas have different effects on RSV, or if RSV has different effects on those, then that could be an additional complication. Yeah, so only on a very cursory level at this point, yes.
So can I ask one question? Okay, so thank you very much. I mean, this topic is really very interesting. I just wonder if the notification cases of influenza and RSV are not from totally different age groups. I mean, so therefore, if they are mainly the older people, and then you have mainly the children, then I don't know how you can link it.
Yeah, so I guess 2 responses to that. First of all, that is partially why we've tried to include the influenza-like illness data as well, hoping that that sort of helps to generalize what's the pattern among the broader population and not just, in the very specific populations that are going to go and get tested for these viruses. The other thing is that we've tried to conduct a bit of a sensitivity analysis where we have generated synthetic data using an age-structured model at our maximum likelihood estimates, and then fit those synthetic data using our model to sort of do an initial test of, do we expect this to be an enormous problem, or can we use a homogeneously mixed model to fit these age-structured data? We found promising results there. Of course, that is sort of just an initial way of looking into it. Like I said, adding age structure explicitly seems a bit difficult with the computational intensity now, but it would be a very useful thing to do in the future, I think. Yeah.
So thanks a lot. We will go on with the next input, and we will discuss a bit later then. Thanks so much.
Yeah, so let's thank the speaker again. Yeah, so sorry that we have to cut here, but there will be space for questions later on. Now, I'm very happy that we will have a very inspiring talk on recent developments in machine learning for inverse problems from Ulrich Köthe, who is professor in Heidelberg, expert in machine learning and artificial intelligence, and also working on amortized inference. And the stage is yours. I think that just this technical thing has to be set up. We just discussed that we will just take 10 minutes of your coffee break, so we intend to be over by 16:40.
Okay, so hello and thanks for having me. So I'm a bit of an outsider, and after seeing the titles of the other talks, I changed my title a bit and made it mentioned the word outbreak flow, which the talk will be specifically about. Outbreak refers to the outbreak of a pandemic or something like that, right? First, let me thank the team that made all the work possible, and then jump right in. So we are machine learning experts, and one of our goals is to develop the Baseflow library, which is a library for Bayesian inference, simulation-based inference using neural networks, and specifically normalizing flow types of networks. So that's what's the name standing for. And these are very good for solving inverse problems, for training surrogate models, for very expensive simulations to do model comparison and things like that in a Bayesian way and in an amortized way, which means that once we have trained the networks, which may be quite expensive, then the actual inference is extremely cheap because the networks are then fixed. So, and then outbreak flow is our application of Baseflow to the COVID pandemic, the first phase. And so we do not claim that we have solved the modeling problem. For us, it's more a case study whether Baseflow is any good for this type of applications. Yeah? And that what we found, I will show you today. So, and first, I would like to convince you that Bayesian inference is useful in the context of inverse problems in order to solve the ambiguities and uncertainties of the models. Then I will show you that doing it with neural networks actually makes this very complicated approach tractable in practice. And finally, I will show you the results for COVID. So first, how do we do Bayesian inference for inverse problems? So we have observables y, so the things that we can measure, and hidden parameters x, that are the parameters that control the simulation or the reality. And then we can apply Bayes' rule in the following way. So we have the prior, that is our prior knowledge about the hidden parameters. Then we have the forward problem, the likelihood. So how observations arise from the hidden parameters. So that's essentially what the simulation is doing, right? Transforming hidden parameters into observables. And then we have the posterior, which swaps around. So we would like to have the distribution of hidden parameters given our observations. Yeah? And that's Bayes' rule. And there are some difficulties with this rule. First of all, many simulations can create observations from the hidden parameters, but we do not have an explicit formula for the likelihood. Yeah, we can only sample from the likelihood. And this is a problem because then this likelihood term in the Bayesian formula is missing. And it's called implicit likelihood definitions, yeah, in contrast to explicit ones. And the other problem is that even if this is formally very simple, in practice it's very difficult to do. So classical methods are usually not powerful enough for the really interesting problems in practice. So analytic approximations are either too simple to be realistic or intractable, so cannot be solved. Regularization or other point estimators like maximum likelihood and so on lose most of the uncertainty and the ambiguity of the solution. And MCMC was already mentioned in the last talk, is very expensive. Also, it gives the correct results. And our goal is to solve these problems by using normalizing flows or invertible neural networks. Yeah? And this is what the core of the Baseflow library is. So first, a very simple motivating example. So suppose we have an extremely simple simulation. We have two hidden parameters, x1 and x2, which here are sampled from a standard normal prior. And then the observations arise from the simulation rule that we just compute the sum of the hidden parameters. Yeah? So we have y as the observations, the sum. And this is our simulation. And in a probabilistic way, this is just a delta distribution for the likelihood. Yeah? And now we would like to solve the inverse problem, so recover the hidden parameters from the observation, but this is undefined because the inverse function does not exist. And one common solution is, for example, to do the minimum norm solution, which also happens to be the maximum likelihood solution in this case, which says that x1 and x2 should be set to the same value y over 2. But this, of course, hides that there are actually infinitely many solutions to the inverse problem. Yeah? And the Bayesian solution works like this. So we introduce a new variable z, which is the difference between the two hidden parameters. And then we can define a new simulation that computes both y and z. And this new simulation is now invertible. Yeah, so the inverse is very simple. So we have the inverse of the augmented function. So we have the average between y and z and the half difference between y and z. These are the two hidden parameters. And of course, we cannot execute this inverse because we do not know z. Yeah, we only measure y. But we can determine analytically the distribution of z, which is a Gaussian distribution with variance 2. And this leads us to an algorithm. And the algorithm means, so suppose we have an actual observation y hat, and then we repeat t times, we sample some z from its distribution, and then we insert y and z into the inverse equation and calculate a pair of x1 and x2. And then you can easily prove that if this set of xy and x2 that we get in this way are a sample from the full distribution of the posterior of this inverse problem. Yeah? So this sample represents the diversity of possible solutions to this simple problem. And now the goal of Baseflow is to do the same thing, but for much more complicated problems. Yeah? So for nonlinear simulation functions G, for high dimensional problems, and so on. So I only have one slide to explain the principle of a normalizing flow. So it's based on what's called the invertible transform sampling. So that's the algorithm that's used in your computer to generate random numbers in various distributions. Yeah? And so you define a latent distribution, Q of z. Often it's the standard normal or the uniform. And then you define a transformation from z space to x space, which here I also call G of z, which should be invertible. So the inverse is called f of x. And then mathematically, this is called a push forward. So you sample from the z distribution and then push forward the z's to x space, and then you can prove, if you choose the transformation properly, that then the x's are distributed according to your desired distribution. Yeah? And then you can also calculate the density by the change of variables formula. And here's the simplest example. If you want to generate a standard normal random variable, you sample in z from the uniform, and then you push these samples through the inverse arrow function, and then they get Gaussian distributed. Yeah? And normalizing flows are the same thing, only that they do this in arbitrary high dimensional spaces. And since then the function g becomes very complicated, you usually have to learn it. You cannot just analytically derive it anymore. Yeah? And the second thing is that so we prefer the standard normal for z over the uniform because it's nicely differentiable, and that makes learning easier. Yeah, so this is the general principle, and this is now all hidden in a nice neural network black box. Yeah? And that's how the black box looks like if you draw a picture of it. So this is called a conditional INN. So the difference between what I just explained is this, here we need the conditional distribution for the posterior. Yeah, and then we have this transformation from Z to X. So Z is the latent and X, X are the hidden parameters and Y are the observations. And so we train this by generating training data and mapping the training data forward through the network. And then we can do inference by taking an observation and running the network backwards. That's the advantage of being an invertible network. So, and you can ask for all the details in the break if you want. And the important thing is, so we have this condition Y on the observations, and the condition is just an additional argument to the functions that we have to learn. Yeah. So I cannot say more about the neural network part. But how do we use this? So we use this to do simulation-based inference. That means we use the simulation here, the prior for the hidden parameters, and then the simulation to create the corresponding observables in order to create our training set for the neural network. Yeah? And this training set can be as big as necessary or as big as the compute that we can afford allows us to do. Yeah? And then we train this conditional invertible network. So this is the gray box here. So we have simulated training data, and then we train our neural network, the green thing, and then it outputs the approximate posterior for the training data. Once this training has converged, we go to the inference phase. So then we have data from the real distribution, from reality, observed data, y-ops. And then we feed it to the converged network, and then it will also create the approximate posterior now for the real data. Yeah? And we applied this principle to many, many different applications, and it works quite generally and quite satisfactory. And I will now demonstrate the COVID-19 application in the remaining slides. So this is our SIR model. So I think I don't have to explain this here. So we mainly follow the model of the group of Viola Briesemann here. And so we have 6 compartments, and then the incubation period and the infectious period. And what's important, we also have this fraction of undetected infections, right? Oh, time over? Yeah, and then the infection rate is a function of time because we can intervene on it. So this is the differential equation. Then we need to enhance realism. So we need to incorporate the reporting delays, reporting noise, the weakly modulations of the reported cases, and so on. And we also need to model some of the interventions. So by a piecewise linear function, that was what this paper proposed here. Yeah, and then we end up with 34 hidden parameters in our model that we would like to estimate, and we use informative or very wide priors, so in order to not impose a lot of prior knowledge on it. And then the forward simulation is easy. You just run the simulation model, and we did this about 50,000 times, so we have a really big training set. And then we find the hidden parameters for the real data from Germany or from German states, for example, right? And then, so here's again, on the left-hand side, the training phase. Yeah, we have 3 simulated time series of the infected, the recovered, and the dead. And we train the network. So actually here, it's 3 different networks to do feature detection from the raw data, and then the features are fed to the conditional invertible network. Yeah? And then once this has converged, we apply it to the real data for Germany or German states. And so we have 50 megabytes of training data and 1 kilobyte of real data. So you could never train the network from real data alone. That's impossible. Yeah, and here are the posteriors for the 34 parameters. And you see, so first of all, this works pretty stably. So if you train this again, you will get essentially the same results. And so then you also see that some parameters are not identifiable. So where the prior and the posterior are the same. And this clearly shows you, if these are the same, that you did not learn anything from the observations. Yeah? But other parameters are quite interesting. So, and I will show you the fraction of undetected infections on the next slide. But before, I will show you the fit of the cases. So the black dots are the actual observations, and then the blue is our fit, and then the light blue stuff are the arrow bars. Yeah? And that's one nice thing about Bayesian approaches, that you can easily compute these arrow bars, and these arrow bars are also quite realistic. And so this is the fit data up to May 17th, and then we also did some prediction into the unseen region, right? So this still works. So here's the fraction of undetected infections. So we started with a uniform distribution as a prior, and then we got a highly non-uniform distribution as a posterior. Although you see that all possible values of alpha are still not forbidden by the posterior, but the most likely is around 79% of undetected infections. And then later on, we saw these zero prevalence studies for Munich and for some hotspots, which also arrived at around the same undetected fraction that our model predicted at the maximum likelihood value. Yeah, so this was quite an interesting result, and I think the consequences of the undetected infections have not been considered enough. What this means, for example, for case following and things like that, right? And so here is the validation of the model, which we call uncertainty calibration. That means that if the model thinks that it's 80% certain, then it should also be 80% of the time right. Yeah? If it is right more, then the model is called underconfident, so it's better than it thinks. And if it's correct less than 80%, then it's overconfident. And this is, of course, a big problem in machine learning. But here you see that so the red stuff should be uniformly distributed, and it is almost for all except for a few parameters. Yeah? So this says that our model can be trusted. So another thing is how good is the simulation? Of course, our inference cannot be better than the simulation. And so we did what we call ablation studies. So we dropped certain parts of the simulation and then retrained our neural network with the simplified simulation. Yeah, so for example, we didn't model the interventions, we didn't model the reporting errors, or we didn't model the incubation period. Yeah, and then we checked whether our network would be able to detect that the real data is incompatible with the simplified simulation. Yeah, and here you see that the ablation 1, you see it on the first real data set, that this cannot match. Yeah, and for the others, you need 2 or 5 data sets, so maybe for 5 German states, in order to recognize that this will not work. Yeah, so, and that's actually very interesting. So in other applications, we have found quite frequently that the simulations are not as good as the simulations experts believed they were. Yeah, and our method can uncover these discrepancies. So then let's go to the summary. So normalizing flows make Bayesian inference tractable and quite efficient. So by using simulations as training data, we can create as much training data as we need. And we can then transfer the model to real data if the simulation was sufficiently realistic, or we can raise an alarm if the simulation is not sufficiently realistic. Yeah? And it scales quite well, so we have done 10,000 of variables for images, for example, with similar methods. There are also some caveats. So as I said, it depends on the quality of the priors and the simulation, and it also has quite limited capabilities to model non-stationary behavior. And that's, of course, a big problem for COVID. So the virus kept mutating and the countermeasures kept changing and all this. There, our algorithm struggles still, but we have a generalization, which we call neural superstatistics, which we applied successfully to cognitive science so far to model a non-stationary behavior of the parameters that we would like to estimate. Thank you very much.
Thank you very much. Just one quick question.
Thank you very much. It's very interesting. I'm also doing with Bayesian inference. So a question, why your method is better than MCMC? I mean, not the classical one, but with adaptation of prior distribution according to the simulation. Why it should be shorter and quicker?
Yeah, so the thing is that the neural network accumulates the knowledge of all the training examples that it sees. Yeah, MCMC must be started from scratch for any new observations. Yeah, and so what we found is that our training is, as a rough rule of thumb, 5 times as expensive as a single MCMC run. Yeah, and as soon as you have more than 5 queries during inference time, then our training will start to amortize. And since the inference, once the training is finalized, is extremely fast, so like 1,000 times as fast or 10,000 times as fast as MCMC. Yeah? And then you can make as many queries as you want for essentially nothing. Yeah? And then we have also verified in other applications that the results between our algorithm and MCMC are very, very similar.
Okay, let's thank the speaker again. And then I think I will take back my promise from before, but I'm still very happy that we will have Stefan Flasche, who was director at the Center for Mathematical Modeling at the London School of Hygiene and Tropical Medicine, and who is now professor for infectious disease dynamics and global health at the Charité in Berlin. Thank you very much. The stage is yours.
Thank you very much. Let me get this started. Okay. I'm not the only tall person today. So this was the title for this session, and I can't quite remember how this came together. But what I think I meant was something like this. Which entitles the uncertainty in parameterizing mathematical models, particularly for the evaluation of vaccination programs. And so, as a disclaimer, I'm not giving you answers, I'll only ask questions. So, to motivate this a little bit, I'll talk about RSV, and particularly RSV immunization strategies. So, why RSV? Well, RSV is the single biggest cause of pneumonia in children these days, well, thanks to the success in parts of other vaccines. And we have a full pipeline for immunization against RSV. And specifically, there's 2 products that have been licensed. One is a long-acting monoclonal antibody that will be given to kids, or alternatively a maternal vaccine that is then inducing antibodies for children. And there are other products in the pipeline, and specifically there's one that may or may not be licensed soon that is meant to immunize young children directly, and then may or may not, through the prevention of infection, induce herd protection. And so we were part of an effort to prepare for the discussions about how to go about these vaccine recommendations. And our part was to create a mathematical model to model immunization strategies for RSV with the idea to help STIKO and potentially others in their deliberations. And so you see a model schematic on the right, and it's relatively complex and has a number of assumptions and uncertainties. And there's two particular issues that I want to talk about that apply to this work and that apply to many other works, particularly in the fields of vaccination. We've heard about meningococcus earlier. You can ask exactly those same questions there. And I said, these are questions. I find them interesting. I haven't found a solution. Maybe some of you have. But if not, I think we as a field need to spend some time to think about these going forward. So the first issue is the value of information as compared to the statistical uncertainty associated with the data that we're using in the models. And so what I mean is that the key to dynamical modeling is the infection layer. So if we think about things like herd immunity, we need to make sure that our models actually represent the infection dynamics. Unfortunately, we have typically quite little data on the actual infection dynamics. What we do have the data for is the syndromic surveillance. You heard this about the meningococcal model. The same is the problem with RSV, pneumococcus, you name it. To be a bit more specific, if we then have a situation where we do have data from multiple sources, which is arguably one of the main strengths of a model, it brings together evidence from different pieces and makes it kind of one picture. We typically end up with something like this, and this is some early pictures from our RSV work. On the very left, what you see is the number of RSV GP visits per week in Germany from sentinel surveillance. Then in the middle, the number of hospitalizations per quarter, as shared by the Techniker Krankenkasse. And you see the scale. Well, I can't actually from here. So one goes to, what, about 40, 50 per week. The next one goes to about 20,000 per quarter. And then we have the seropositivity on the right-hand side. And here, well, you don't have a scale in the number of samples. It just shows you the proportions, but the underlying number of samples are typically quite low. I can't remember what it was exactly here, but we're typically talking about 50 to 100 samples per age strata for those kind of surveys. And so these, in this case, are the pieces of evidence that we have and the numbers associated. So in the next step, I want you to think about, well, what is the actual information for my model that we'll get from this? And so for the number of GP visits, well, we get a pretty clear picture about the seasonality, which is an important piece of the puzzle for RSV. And we get a pretty clear picture about the burden of disease for symptomatic infections that are so symptomatic they end up in the GP. It doesn't really tell us anything about infection or other things that may be important. So then the next part, the hospitalization data, well, it tells us a tiny bit about seasonality because we only have quarterly data. And it does tell us a lot about the burden of RSV in hospitals. I mean, there's very little statistical doubt that we had not 6,423, but 5,000 more. So the confidence interval on that data is very, very small. There's a lot of statistical uncertainty, but that statistical uncertainty refers to the burden of hospitalization and only that part of the overall model. And then we get to the thing that we're actually interested in, particularly if we talk about things like herd immunity. If we have a question that we want to answer where it is absolutely crucial to get the infection part right, then this is the most important part of the evidence that we have. But the statistical uncertainty on that part is huge because the sample numbers are small typically, not always, but typically. And so if I go and just calculate the likelihood contribution of those three different parts, it's a very rough calculation, isn't actually what we used in the model. You end up with ballpark estimates of, well, -500, so it's log likelihoods, -500, -1,000, and -25. So if you just throw this into an MCMC, what happens is that, and you can see this here from the early fits, the fit is absolute rubbish to the most crucial part of the data because it prioritize the part of the likelihood that has the biggest contribution to the likelihood overall. And I haven't found a good way around this. I mean, we've tried some kind of weighting to kind of bring this to kind of equal level, but it's all a bit artificial. So some of you who have a bit more statistical knowledge than I do may be very helpful to think about, well, how we kind of find a proper framework of including in a statistically meaningful way the data we have at hand. And so, I mean, one idea could be that we run simulations to estimate the actual value of information of that data pertaining to the outcome of interest and use that as a weight of the likelihood contribution. That's just a wild idea in conversations that we had earlier this week, but yeah, you may have some other ideas. The second issue is about structural uncertainty. Once we come up with a modeling approach, we're typically quite bad in thinking twice about the structural uncertainty because it is an absolute pain in the ass. And so in this case, structural uncertainty could be, for example, that we assumed that active immunization works as an asymptomatic infection. And so you kind of keep an immune memory of an infection because that has come from your active immunization. If you're giving passively protecting antibodies, well, you're less likely to have an immune memory of that, and so we'll keep them as a kind of no previous infection. It's a structural assumption. There may be others. There may be better ones. We don't know, but that's what we went with. But then when it comes to policy and making a decision for, in the German case, 80 million people to buy a product or another product or no product, you'd kind of want this uncertainty addressed. And so, in fact, JCVI, the NITAC of the UK, has a policy that there always has to be a second opinion model. Also, Gavi and WHO typically operate on that, and this is in order to address that structural uncertainty. And that's where I don't see anything anymore. Well, okay. And so we thought about this a little bit, and so this is what has come out of a deliberation at the WHO level a couple of years back, where we tried to develop some guidelines on how to do multi-model comparison. I forgot to kind of give the last bit of the intro to this. The problem is, if you have more than one model, you may well get more than one answer. And so the question then is, how do we combine this into something that helps us actually making a decision? So we looked at this a bit, and well, at the time when we did this, we concluded that the field of modeling is too complex to be prescriptive, to say this is how you need to compare models. And so all we could come up with is guidelines on how to report on multi-model comparisons. And there's a couple of issues here. One is harmonization, and the others are how to deal with heterogeneity in results and to decide on whether or not and how to pool results. So to give you an example of why this is potentially complicated, here are two studies. On the left-hand side, this is a dengue model comparison that we did about 10 years ago for the use of Dengvaxia. And we brought the groups together, and they discussed and harmonized a couple of their assumptions, and then surprisingly, they come up with basically all the same answer, which is kind of nice. But it comes with an issue, because then you may as well have just one model. On the right-hand side is the, kind of opposite approach. It's HPV modeling. And they just sent out a number of data sets and kind of key assumptions and key questions to the groups, and then just let them go with it. And they come back with the results that you see here in the forest plot, which are quite diverse, and specifically as one big outlier. And the way they addressed this is then they said, okay, well, we assume that if we ask enough modeling groups, well, the average of all of them is probably somewhere close to the truth. But there is a big problem with that, because if we had done this with the dengue work, we would have completely gotten it wrong. Because there was one group in particular who had a quite clever idea that this vaccine would actually, for those who know dengue, work similar to natural infection, therefore be coming with a risk of antibody-dependent enhancement. All the other groups at the start of the exercise did not think of this. And only in the conversation, the sharing of knowledge, it became clear that this was the only way to model vaccine in this context. So again, no good answer here. And so this brings us to the big question, well, how do we deal with multiple modeled answers? There are a number of methods. I mean, we could weight by the inverse standard deviation as done in the meta-regression work. This will not work for modeling because everyone addresses uncertainty in modeling differently, so there's not a unified approach. So uncertainty intervals on modeled outcomes means very different things between models. Could just weight all the same. That's done most of the times, mostly for political reasons. Again, it comes with risks. Out-of-sample prediction performance was mentioned earlier. Seems to work pretty well for forecasting models, where you fit to a trend and then try to forecast a similar trend. The problem with vaccination is that what is done is you calibrate to, trends before, but then you change that. And so you can't do an out-of-sample calibration to that change because it hasn't happened yet. And even worse, for a lot of the pathogens we're talking about, they're endemic. So there isn't really a lot of difficulty to just delete one data point because it's kind of more or less the same over many seasons anyway. Probably the most interesting approach I've seen is to weight by grading, by grading criteria. But that again is kind of just pushing the problem down the line. It's because it comes with the inherent part of the grading, which is assessing the quality of the study, where we do not have a proper framework for modeling. Okay, so in summary, there remains a lot of uncertainty, particularly in how we deal with uncertainty. And with that, I'll close. Thanks.
Okay, thank you very much. While I ask all the speakers to come on stage, just one question, and you can make up your mind. I promised Jan to have the first question, and then he said, I will circulate the mic. On slide 7, just one question while everyone comes up. You showed that the general practitioners' visits to RSV were different over the different years. Was this maybe also to cross immunity, maybe to make the link with the first presentation, or was this really unclear why the data was so different over the different years?
I didn't actually recognize that it was. It seemed relatively steady.
Okay. Okay, all right. So for running around, I'm allowed to ask a first question, apparently. That's nice. Thanks a lot for that. I will ask a very broad question before handing them over to all of you. I mean, we obviously have various challenges. It's also nicely described, for instance, now in the last presentation. So I'm kind of wondering, I mean, there's this whole topic of guidelines, but I mean, other communities actually came up with standardized ways to encode parameter estimation and even model selection problems. So should we try to do something like that as a community? I mean, there is in the systems biology community certain standards basically to do so. Maybe we should aim for something like that also in the infectious disease community. I'm not sure. Kind of would like to hear your opinions on that.
Yes, absolutely. But the question is how. And I think many have tried, and the complexity and the diversity in the modeling field has been a major hindering factor.
Yeah, I also think, so from my experience in machine learning, the problem is more difficult than it looks. And so one thing is that often we find that all the models make the same type of mistakes, and then integrating them does not help. Another is that many models do not, where you have trained some kind of gateway which will estimate which model, which expert will be the most competent for the question at hand. And this seems to be working quite well. So,
thank you.
Also.
I'm not sure I have too much to add beyond what they've already said on that particular question.
Do we have more questions from the audience? So Jan has one. So the other Jan.
I have a question to Mr. Flasche. Why, I cannot imagine how your network produces also the error bars or the uncertainty. Can you explain how this works? Maybe I mixed. Sorry, I mixed you. Sorry, yeah.
Yeah, there are different ways. The way I showed was that we try to train a network that does not just give a single answer, but returns the full distribution of possible answers. And then we sample from these distributions. So the outcome looks much the same as MCMC, but it's just 1,000 or 10,000 times faster.
So, Elisabeth?
Is this on? Yeah. I mean, this is, I guess, leaning into Jan's question about like best practices, but I mean, with this kind of uncertainty present, should we be encouraging to apply different fitting methods, multiple different fitting methods to different models to better capture this uncertainty?
I mean, I think that's always a good idea. I mean, especially with, what I presented, I've seen only, I think, like one other example of a group doing, or so far publishing at least, this type of work. And I mean, I think it would be very helpful to have a lot of more estimates in the literature. And if we, value those and don't just value, the first couple times it's done and then say, oh, someone's done it already, it's not important anymore. Because, yeah, I mean, that goes into the ensemble modeling a bit, right? I mean, less formally, but a little bit, to then have different estimates from a range of different models and a range of different assumptions and approaches. And over time you see, oh, this assumption is really helpful in estimating these parameters, or this one maybe isn't terribly accurate, and you build that consensus over time. So I think that would be incredibly helpful to have.
Stefan?
Does this work? Yes, it's just a bit lagged. That other group was us, I think. But I think the question was whether we should apply different fitting methods. And ideally, the fitting methods actually return the same answers. It's a matter of speed and appropriately using those methods to actually arrive at a consistent answer. But I think the key really is to have different people think about the same problem, which would then hopefully give a better overall idea of the uncertainty of the problem.
I would like to come back a bit, because you posed these nice questions, so I think we have to at least make some effort to also answer them. And I want to come back to your question on what happens if I have one piece of information that is really, really essential, but basically my uncertainty is very large. Of course, everyone will know my answer, so I said just make your seroprevalence study bigger, but Stefan didn't agree with that. So then we came up with the value of information. I really like this idea of maybe using that then as a way of quantifying also how much uncertainty you want to have in. Have you thought more about this? And what do the other two think about this?
Do you want to start since it is? Okay. I mean, I was actually going to follow up with sort of an additional question of if you think it might be worth including data, even broader data like ILI or ARI data in there that might capture some of those trends in the population, not as specifically, but I don't know how that would help the model estimation, but that maybe builds on the question a bit.
Yeah, I would also say that there are more unsolved questions than answers. So one thing is that often the crucial information will be masked by the bulk information. So for example, in radiology, a very small tumor may only span a few pixels, so it has not a big influence on the loss, but it may just be the critical clinical information, right? And so we are working on, colleagues of ours are working on how you could adjust the estimator to not overlook the small stuff. Yeah? And so it's also similar to when you say that one has minus 500 log likelihood and other only minus 24. So then the one is masked by the other, right? And so we are very interested in, if someone has an idea, in adjusting the training algorithm such that this will be reweighted in the appropriate way. And then we would like to undo the distortion from training without retraining from scratch, right? And we don't know how to do that.
So if I may ask another question, actually, a very evil one, could it actually be that in these cases where this reweighting or this reweighting is necessary, it's actually not the model which is wrong, but the statistical noise model? So for instance, negative binomial versus binomial and so on, basically, which can have a huge impact?
Yes, I agree. I mean, this is part of the issue. If I use this time series and treat every single point as an independent Poisson observation, I do get a very inflated log likelihood. But even if, I mean, adding a negative binomial goes some way, ideally you also account for
autocorrelation.
Sorry? Autocorrelation, yeah, that was the term I'm looking for. Autocorrelation, which we typically don't do, at least where I was coming from in the modeling field. And that might go some way to actually better capture the real information behind that data. Yeah.
I was wondering as well, and this is a question rather than an answer, but is it at all possible to fit the weights, maybe I missed this, to fit the weights to which different data are taken into account? So, you know, somehow fitting over time, okay, if we take this data into more account, we get a better overall fit with all of the data streams. I imagine that would be somewhat complex and maybe not easy to accomplish, but is that a possibility?
I mean, it's essentially cross-validation, right? If you do that, it's cross-validation. I mean, a common approach used in machine learning and also statistical fields, which fit the weights of different objective function contributions.
Yeah. But it's also very much dependent on how you measure accuracy. So the DKFZ in Heidelberg, the Cancer Research Center, is leading a worldwide huge effort into a systematic definition and categorization of metrics for success. And so they are trying to create a decision tree. If your problem is like that, then do that and not do that. Because if you use the wrong metric, you will get totally misleading results. So that's extremely important.
Now the very last and most important question, Stefan.
Yeah, thank you. Yeah, I found it very interesting talking about structure and uncertainty. I think that's a very important point, and I totally agree that ideally we would have many different models and can combine them, but we barely get budget for having one model. So I think having several models is kind of the dream way, but impossible. Would it be a more efficient and cheaper way to just go back to clinical expert? And I mean, sometimes even that figures. I mean, I know that I went to clinical experts and asked them, like, is it with meningococcal disease, is it more like the incidence approach that you only get IMD once you acquire new carriage, or, you know? And then they said, hey, that's a good question. We don't know. So it's also, do we overall need more funding in like the Grundlagenforschung or in the clinical side, and also should we just talk more to identify the subjects that you know, clinical and modeling communities can work on together? Thank you.
Well, I'm not going to say no to more funding, but ideally, everyone who is doing modeling is speaking with clinical experts anyway. So I was under the assumption when I posed this as an issue that each of those modeling groups not only sit in their silos, but speak with disease experts and speak with, well, all the relevant expertises that they include in the model. But there is heterogeneity in those expertise as well. And so you may still end up with different assumptions.
Another comment? Otherwise, I would thank the speakers and also you, the audience, again. And I think it's up to Raphael and Alex to say when we will continue, or Carla. 20 minutes break.
Der stürzt ab einer Folie ab und zeigt nichts mehr.
Ah, okay. Habt ihr es schon?
Ja, wir haben das schon geübt. Nein.
Soll ich euch irgendwie ankündigen oder?
Nö.
Wollt ihr das so durchziehen? Also von mir aus gerne.
Du kannst uns auch gerne ankündigen, aber
Okay.
wir werden es auch versuchen kurz zu halten, damit wir ein bisschen wieder rausholen.
Okay. Ist vielleicht
So, because they introduce each other, like they talk to the ones at the back, because they are quite many, right?
Yeah, that's good.
Okay.
I have a microphone.
Okay, I think I mentioned the Young MONID initiative yesterday, or we mentioned it yesterday and also today many times. So I'm very excited that we have now the session. And yeah, I mean, I somehow predicted it yesterday that our young researchers, they are very well with their time management. And we see today, when we have the senior researchers, it doesn't work so well anymore. And now, yeah, Manuela and Beryl, they just promised me that they will be quite quick with the presentation to save some time, and I'm pretty confident that they yeah, will follow up on their promise. So yeah, these are Manuela Harries and Beryl Musundi, and they are currently the leader of the Young MONID initiative and will now introduce the initiative to you.
Yes, thank you for the nice introduction and giving us the opportunity to introduce the Young MONID initiative. And as you know us now, we kind of have a introduction game for you. Since you know your partner left and right, please turn around for a second, take your partner behind and introduce yourself to him. And maybe if you don't have one behind you, then take the one in front of you and tell him where you are. I mean, you could come closer anyways. And
so please remember to mention your research and your institute. So your research field and your institute.
Okay.
We need them 2
But
minutes.
it's good. Yeah, that's good. If you don't have a partner, you can get up and walk around. So be more active.
It works.
So you want to do the goals?
Yeah, I
okay. Then let's switch sides so you can read.
Okay.
Can you whistle?
No, I can't. Should you like after a minute, give them like
10 more seconds? Sorry. But it's quite active.
It's going quite well.
You want to interrupt them or should I?
Interrupt them and then we go.
But it's so interactive. Okay, that worked really well. But since we have to keep the time and we promise to be quick, thank you for that introduction round. And now we want to introduce our goals to you.
Okay, the goals of the Young MONID initiative is to make MONID sustainable and innovative while also fostering young talent and expanding training capacities. We also hope to establish and deepen interdisciplinary and international modeling collaborations. And to do this, our strategy is to establish junior research groups led by young scientists, and by this we mean postdocs and PhDs, and also master's course, and with modeling skills in infectious diseases. Okay, and to kickstart the initiative, we sent out a survey to just get an idea of what activities the young scientists would be interested in, and also what types of models they would be interested in terms of epidemiological modeling. And we got your feedback. Unfortunately, the slide doesn't show.
It's working there.
Oh,
We
okay.
don't see it, but you see it.
Okay.
And if you haven't filled out the question, I can just...
So we got back some feedback on what people would be interested in so what their expectations of the initiative, and also the type of models they would like or would desire in the initiative. And also we asked who was interested in joining the initiative, and we also got some feedback. And if you didn't fill out the survey, we still have them going round, so you can still participate in the survey. So today we thought to now just get your ideas on what your top priorities of the initiative should be, and what activities you'd like to see, and maybe how often you would want these activities to take place. So to start on that, we invite you to scan the QR code and go to Mentimeter and fill out the questions that are there, and then we can see feedback on what the top priorities are, and also how often we should communicate and do these activities.
So I see a lot of cell phones, that's good, just scan it. And there are two questions. One is a ranking, and the other one is just a single choice question. And we will wait 1 minute, and then we might see the results on the screen. Oh, we already see them. So the first question was, what should the top priorities of the initiative be? So now you have 6 options to rank. So depending on what you're ranking, we will try to initiate a workshop or journal clubs or a hackathon as well. So it depends on you now what we will do in the next few months with you. So maybe 10 more seconds. Ooh. It's kind of a race between workshop and summer school. So of course we would work together with MONID, with the summer school and with the academy, and try to join our capacities and come up with some ideas how to create the summer school or workshops. Okay, and there should be another question on it. I don't know if we have now to switch. Can you see the second question on it? No? No. Yeah, change slide is Carla. Can you maybe? So the question was, how frequently should we offer those activities like summer, winter school, or workshops, or journal clubs, or hackathons? That was great.
Okay.
It's still moving. But this gives us a good idea what you're expecting from us and how often we are allowed to contact you. So I think quarterly, every 6 months, seems to be appropriate. Okay, then thank you so far.
Yeah.
And then we have to switch the screens again. Thanks.
So the others would maybe just, if probably you can contribute to this on the structure of the initiative. What would you like to see in terms of representatives, the board, the leadership? What are your ideas on this? Do you think we should have a person in every university being like a representative of the Young MONID initiative? We would just like to get your ideas, so we will pass the mic around, and if you can comment on this, we will be grateful.
It's now open for discussion.
Yeah, we're open for discussion.
I have to turn it. So, any ideas on cooperation, collaboration, like with Public Health Institute? What do you think should Young MONID Initiative try to achieve and work with? No way. Okay. So, and what would you think about, like, right now we don't have any funding and we would apply for some funding. Do you have any ideas where we can go? Any, how do you say, like, where should we ask for external funding or internal funding? If MONID would be a good, Martin, thanks.
Yeah, maybe just a comment. So we discussed with Jan, Andre, and Andreas yesterday, and I also told it Alex to make it a little bit more that we are committed to this a summer school next year. Maybe this is something we can also team up.
Thank you. Okay.
Now I have the option to find the next speaker.
Oh, sorry. Lilian from the Uni Lübeck. First of all, thank you for doing this. I find it really interesting, and I would just want to propose something, not only to make this shorter, but maybe from all the people you surveyed, you can call some from them and have a group discussion online, because I think this will be more fruitful than this right now, because we're all tired. Thank you.
So on the next slide, we actually have our...
Oh, sorry. One last time.
Oh, I didn't see. Oh, sorry.
So, I mean, if you want to organize something yourself, a possibility would be actually DFG funding initiatives. I mean, in particular for conferences and so on, there are very nice possibilities. I mean, somebody who has to apply has to have a PhD, but beyond that, it's usually very easy, basically, to get money for events if they are scientifically easy to argue for.
It just came to my mind that at the VW Foundation, they have funding for workshops. So maybe we could have a first idea generating workshop.
Okay. Lisa?
I also think, since we need to strengthen the modeling community among the youngsters, so seminars on specific topics would be very helpful. But then further, knowing maybe from more experienced researchers, what can you do with your modeling? So how do you implement your modeling into policy decisions? Or how can policy be informed through your modeling? And especially for young people who enter the field, I think that could be very helpful.
That's a good idea. Yep.
Just to add what
Caro said. So there is actually a call out at the VW Stiftung for scoping workshops. Yeah, I think this is what we meant, right? So the deadline is 4th of June. I think you could directly apply and probably, I mean, it says together with other researchers to look at where you are with your research. And, yeah.
Well, kind of more just a specific recommendation for one of the workshops or something to learn. But the issue came up a lot that there's an issue with science communication. So maybe starting with the younger generation and making sure that we know from the start how to correctly communicate, and maybe also media training.
So, but then within a webinar, kind of online, virtual, okay, that sounds reasonable.
Maybe for building up an international network, you could apply for a cost grant. So here you would get funding for meetings and networking activities.
Thank you. Oh. Yeah. I agree with you, but it's always the limitation of the funding, because in face-to-face is much, more costly than, but yeah, we keep it in mind. So to keep things short, on the next slide we put our contact information there, and we have a Google document where you can scan the QR code, and if you want to participate or be in the mailing list, just add your name and your institute and your email address, of course, don't forget that. And then we will send around an email soon and try first to set up a webinar and go from there. So, yeah, thank you so much.
Yeah, thank you.
Oh, ich habe vergessen umzuschalten. Na gut, okay. Welche kommt jetzt? Infectious? Das müsste der sein, ne?
Genau,
der, ne?
Genau, Moment, das
Kojan.
Der ist die zweite, genau. Den habe ich mal getauscht. Dann Nagel und dann kommt dieser Hanna danach.
Das ist also jetzt erstmal das.
Genau.
Ich würde am liebsten den Viola Priesemann-Talk haben, das ist der erste.
Wen?
Priesemann? Du kannst mich ganz kurz einleiten. Ich hatte es eigentlich geschickt, aber...
Okay, so in the interest of time, while we do technical things, we will go on directly to the next panel, which is on adaptive behavior and modeling. And I'm really glad that Viola is with us. She's leading a research group at the Max Planck Institute for Dynamics and Self-Organization. And I think she doesn't really need a lot of introduction because we all know her and have seen her through the whole of the pandemic and now. And do I still have to talk while...
Von mir? Ich dachte, jetzt geschickt.
Till habe ich geschickt. Meinst du die?
Ich habe dann davor habe ich die andere Mail geschickt mit den anderen direkt davor. Okay, dadurch, dass mein Talk, because my talk is not on this computer, maybe we can short-term switch to the second person, and we'll just make sure that we'll find somewhere in the web my talk again. Is that okay?
Yeah, that's a good idea. So Michael Mess, please come up. And He will talk on protective behavior, opinion polarization, and disease dynamics. Haben wir denn deinen? Das ist das
Ja.
okay.
Yes, welcome everyone. Thanks for bearing with me. So there it's shown, there it's not shown. Okay, perfect. So yeah, great that you're here. I'm a sociologist, and I would call myself a mathematical sociologist, so I can contribute something to modeling. But what I think my field can contribute mainly to understanding diseases and the spreading of diseases is the understanding of how humans influence each other in their protective behavior. So this is also what is central in the InfoExpand project. What I show you here is data from the so-called COVID behavior tracker from Denmark and the United Kingdom. It's data from many, many countries, and what they measured is various kinds of protective behavior in terms of washing your hands, sneezing in your elbow, getting vaccinated. And you see that in these two countries, the dynamics were very, very different. Yeah? So higher numbers mean that people were protecting more, and each of these lines is kind of a box plot. And you see that in Denmark, the average behavior shifted a lot during the pandemic, way more than in the United Kingdom. But in the United Kingdom, we had a strong increase in variance. Yeah, there has always been a quarter of the population that was protecting a lot, but the lower quarter of the distribution was protecting less over time. So that's nice to know, nice to perhaps also explain, but the question is, does it matter? And we come to the conclusion that it actually matters a lot. What we show you here is 6 typical simulation runs of an agent-based model where in a grid network a virus is spreading. It always starts in the center, and these bigger symbols indicate that this agent got sick, caught the virus in that case. And in all these 6 simulation runs, we implemented that agents have a variation of their susceptibility. Yeah, so the probability that if you are exposed to someone who is sick, that you also become sick. I'm a little confused because that screen is going crazy. But we always implemented that this distribution has the exact same average. So in these 6 runs, the average susceptibility is always the same. But in the first row, we varied the variance of that. Yeah? So in panel A, for instance, we have a specific average and a very low variance around that average. And you see that there's quite some spread in this network. If we move to a uniform distribution, a flat distribution with a much higher variance, but the same average, not too much is changing. But if we go to an extreme case with a bimodal distribution, suddenly we don't see a spreading process anymore. What happens is that half of the population is protecting a lot and the other half is not protecting at all. But those who protect a lot also protect those who don't protect very well. This whole thing changes again if you're not only looking at different statistical distributions, but also the distribution of this behavior, of the beta in that case, the susceptibility in the network. If you look at the second row, here we didn't randomly assign the different susceptibility values to the agents, but we implemented homophily. Those with a similar susceptibility also tend to be located right next to in the network. And you see that these clusters of agents either protecting or not protecting form. And now suddenly, if you look at panel F and compare to panel C, for instance, agents, we see again that a big share of the population is infected simply because those who don't protect themselves are not protected by those who are protecting. So behavior and its dynamics matter for our predictions. So how to take care of that in our models? And fortunately, there is already a big literature on models that look both into disease spreading, but also the spreading of behavior. We had a poster here where we kind of summarized our review paper on this. What struck us is that even though there are many really interesting and intriguing models, the literature as a whole is hardly informative. There are many, many different models, They are not being compared, they are not being studied in similar settings, in similar network structures, for instance. It's just a mess. So for instance, many models assume that individuals, agents, do not respond to incidence numbers. Some assume that they do, others assume that they're responding to hospitalization numbers. Some models assume that agents react to their local incidents in their network neighborhood, others to global values. There's also huge variation in terms of how agents make decisions. In some models, it's just a simple herding. I protect to the degree similar to what is dominant in my network. Others assume a kind of success-driven imitation. I tend to imitate those who were successful in the past. So if the incidence is low, I imitate those who did not vaccinate. If incidence numbers are high, I imitate those who did vaccinate. There are many models assuming a game theoretical, a strategic agent, which has the implication that if everyone around me is protecting, then I'm not going to protect because I'm free riding on herd immunity in a sense. So in that case, it's opposite to the herding idea, that in the sense that agents sometimes do the opposite of what the others are doing. And then there are these very nice awareness diffusion models, which again are based on a very different kind of social influence. So the question is, what do we do with all these models? At some moment, we have to pick one for our specific setting. What we are proposing is to use an approach that was developed by Lopez Pintado and Duncan Watts. The idea is that that rather than trying to understand or model, also in our theoretical models, what happens in our brains when we influence each other or when we make decisions, that we boil down the influence to what matters for complexity, which is just how is my behavior affected by the behavior of others. And this is represented in a simple function called an influence response function. So you abstract away from all the psychology and only model the interaction in a way. And then, yeah, we can already show that for some models, these influence response functions look very differently. Yeah, so here's just an example of herding. On the x-axis, you see the share of neighbors protecting in that case. And on the y-axis, you see that the more people in my neighborhood protect, the more likely I'm going to protect too. Rational choice-inspired models, game theoretical models, have the exact opposite influence response function, or the direction of the influence response function. And then there are also various models that have a mixture on that. So for instance, in this very nice paper by Alvarez, Zuzek and colleagues, the slope of the influence response function depends on how many individuals in my neighborhood are infected. So this is a way to compare these micromodels. Another advantage of influence response functions is that this is something we can measure. We have a very hard time measuring what's happening in our brains, but what we can measure is what people are doing and what their friends and neighbors are doing in the network. And this is the dependent and the independent variable of these functions, so this is something we can actually study empirically. Something we are currently doing at KIT is we have online surveys with so-called vignette studies. That's a sophisticated survey technique that allow us to measure influence response functions on an individual level. Another thing that Lilian mentioned earlier today is experiments in laboratories. They have the great advantage that there you can measure actual behavior. In our service, typically giving an answer does not have any consequences for you, so sometimes you can doubt it. There are methods to control for that, but they're also complicated. But in these experiments, people actually lose money if they don't protect, but then get infected, for instance. There's no real infection in these experiments, but you design them in a way that people's decisions, answers to questions have an impact on them in terms of gaining or losing money. So this is further away from infectious diseases, but it studies an actual behavior. And once you have all of that, then you can ask questions about how for instance, dynamics on the internet have an effect on disease dynamics. So you can then, for instance, ask yourself, let's assume that my behavior is not just influenced by the people I meet on the street, but also to a huge degree by people I meet on the internet. And then the structure of this communication network on the internet might have an effect on processes like opinion polarization, and as a consequence also on disease dynamics. You can look into the effects of social bots, and perhaps even bots that target very specific parts of an online community. So to wrap up, there are two take-home messages here. First, if you want to make more than just short-term predictions about a disease dynamic, you're in deep trouble if you don't take into account the dynamics of behavior, of protective behavior. Second, there are nice models for that out there. We found really nice papers also for modelers, intriguing work, but this stuff needs to be compared. Individual models are beautiful. It's really amazing work, but taking all of these models together is as messy as the literature where I come from, I can tell you. So this coupled disease opinion dynamics literature is as messy as the social sciences. But once we've compared these models, we can also test the critical assumptions empirically, and for that, the good news is that we also have the methods in the social sciences. Thanks.
Thanks a lot. Maybe stay up for just a minute if we have any urgent questions. I think the larger questions we'll discuss a bit later. If there's anything that urgently you need to know from Michael, go ahead now. Maybe I have a quick question, just one. So, I mean, for most infectious diseases, of course, the behavior changes that take place have nothing soever to do with the actual infectious disease. So they might be totally influenced by outside things because people are not actually reacting to the infectious disease that is ongoing. In the current work that you do, and how far are you also including that? So let's say external fast-changing behavior changes, but not a feedback loop in that.
So to be honest, at the moment, the focus is on understanding these influence response functions, measuring them, and the next step. So you kind of get me on the wrong foot. It's simply because we try to keep. To be honest, we keep the models. We want to really have that loop in there because we're interested in this loop. So we actually haven't
totally
thought about this at all.
This is what you do. I think it's really, really important. It's just I think we have to keep that a bit in mind. That
yes,
basically
and I agree. But to be honest, from my modeling perspective, I was actually really not thinking about this because I was thinking the loop is the most interesting part. Yeah, it's a good point, actually.
Thanks so much. Thanks so much for a great talk. And now we go to Viola, I think. So, if the slides are up. Thank you.
Bitte das PowerPoint nicht verlieren. Looks good. Yeah, sorry for the hiccup. This was meant to be the first talk, and I really wanted to say thank you to this great consortium and the past years of work, including our hackathons that we had at least twice a year in the past, and also note that in 2025 in the summer, funded hopefully, if we are lucky, by the MPI and RIST, we'll have a workshop also there. So that's the outlook. I'll keep this short, but again, a shout out also to the Lübeck community that organized the summer school that some of you attended to. We would love to do the next summer school. We don't yet know where the funding is, but now where Young MONID is around, we should also really team up on that one. So the effectiveness of mitigation measures is something that has been coming up again and again here. And if you ask about the effectiveness of mitigation, you would love to have this one number. Let's say wearing a mask reduces your R value by whatever, closing schools, at least give a number to how useful that would be apart from all the negative side effects. I think the problem why we are literally unable to do this is the following. Take the example here of mask wearing. It really depends on how well they are implemented by humans. There is not the one number to it. Take mask wearing, people might wear them properly, or they might not wear them because literally all know that masks don't work. So we need to understand this voluntary behavior, the effect of communication and the information and disinformation spread to know how effective in the end a formal policy will be, because it is always the humans that implement them more or less well. We are having that in our focus of the consortium, mainly the voluntary behavior and also the spread of the mis and disinformation. And I want to throw at you very briefly 2 studies. It's tied for a short moment. One is a general framework that we derived to show how ideal mitigation strategy could look like. And the other one is to show how delayed mitigation can lead to chaotic dynamics. Let's start with the first one. So imagine here that you have a disease that is seasonally spreading. Here's the basic reproduction number, already with some seasonality included. Then your infections in red would have this very clear peak in early winter. So we can say seasonality and no mitigation leads to some strong waves in early winter. Now we can take the cost of infections and assume as first order that they are proportional to the infections proper, because people might not go to work because of their health costs, maybe even because of death. Let's say they are proportional to the number of infections. But then we also have the cost of mitigation. And we assume that the more we mitigate, the additionally more costly this becomes. So the first 10 or 20% of mitigation might be almost for free, and then it's more and more expensive. If we put that into a framework, then we can find out what would be the ideal mitigation strategy in such a seasonally changing endemic disease. And this is the result that we find. We do find that, I put a line here, at the peak of infectiousness of that seasonal disease, we should also do peak mitigation in blue. That's, I think, clear. The more there's a spread, the more we should mitigate. What happens? What happens is that the peak of the disease proper moves by exactly 3 months. So exactly by pi half. I mean, it's pi day today, so I had to express it like that. So it basically moves to the spring. And that's quite surprising, because it says you should really strongly mitigate in the winter, and then towards spring you have accumulated some population immunity, you have the advantage of seasonality plus, and then you can relax your behavior again, and that will be sufficient to bring down the wave again. And overall, sure, the waves are lower. We then can quantify these costs. It is not for me here to tell you how exactly each result is. I want just to tell you, we put that for the idea of there might be a vaccination that reduces the basic reproduction number, there might be a change in variant, there must be the cost of waiting if there's a wave coming, and you just wait after the wave. What exactly is then the total cost of whatever mitigation and whatever infections? And what we want to put forward is that what we have here is a general framework that we want to share with you about how to optimize it for different cost functions and also for different type of disease settings, being it endemic in the wider sense, or being it also for outbreaks. That brings me to the second topic in 5 minutes, which is, well, typically people don't react optimally. We know it from the pandemic. They do whatever they want, and typically they are too late. So there might be delayed mitigation. So let's look into that model. You all know that there could be a SIR compartmental model. Then depending on the level of infections, there's a hazard that might be proportional to the level of infections. And this hazard, it's delayed because on the one hand, people have to realize case numbers are going up, and that takes them a while to then also implement some mitigation. And the mitigation might reduce the transfection. So what we basically model is saying, if case numbers are high, people start reducing their contacts, case numbers go down, people again have more contacts, case numbers go up, and you see how oscillation can happen just because of the delayed feedback. In addition, we might put seasonality into that model. What does then happen? The behavior alone leads to a Hopf bifurcation. It says that if the mitigation is strong enough, we'll see oscillations. I depicted down here, it's the infections over time, and the stronger your behavioral feedback, the stronger your amplitudes that occur not because of seasonality, but because of your behavioral mitigation. It's just a tiny bit late. Now, if we add, so delayed mitigation leads or can lead to oscillations independently of seasonality. What happens if we add seasonality? If we add seasonality, then here that Hopf bifurcation changes between winter and summer. This is how we can represent that. And then we find very interesting dynamics. You see that we put these points very close in phase space, and you can see that the wave patterns that come out here can be highly different. And what we actually characterize there is to show that delayed mitigation plus seasonality can lead to chaotic endemic dynamics. What does it mean? That at least in theory, very much a theoretical physicist result, endemicity might be constant incidence or seasonal waves, or potentially these very complex patterns if we do have a disease where people agree that they want to push down the waves, where they react to the higher case numbers. Think 50 or 80 years ago, some diseases were like polio, where vaccination wasn't yet available. There were the outbreaks, people reacted to that in such a state. Now, does it matter? Yes, it matters in terms of the infections. I here have in color for you the number of people infected at a given time, and you can see that already small parameter changes might vary by 50% whether you have more or less infections. This obviously, in addition, has all the noise that we have from behavior and so on, so this is a bit of a theoretical result. So I again ask, does this really matter? And I would argue, yes, it does. Why? Because we can show that if mitigation remains necessary for some disease in the endemic state, waves are most effectively mitigated jointly by the increased immunity, contact reduction, and seasonality. So all these three factors play a role to bring down the wave. And if they jointly play a role, then what comes out is naturally the chaotic state. Let's again go to the cost function. We had that before. We assume that the higher the mitigation, again, the cost of mitigating is overall higher. If we then put it in a dynamic model, then this is the overall cost of infection that we get out. It's relatively flat as soon as we have a certain level of mitigation. We assume, again, like before, that in terms of the cost of mitigation, not the cost of infection, the cost of mitigation increases the more you mitigate, and effectively this is how it looks like for the overall dynamic model running. If you put the two together, then they find a clear minimum of the two costs. This minimum depends, obviously, how you weigh cost of mitigation versus cost of infection, so we just change them by a factor of 5, and the minimum is always at the same place. So I don't obviously know how much death is worth a unit of mitigation, but I can tell you, varying it by a factor of 25, you're always in the same region, and that region happens to be the chaotic region. Why? Because it is in the end most effective to put all the three forces of breaking waves together: the acquired immunity, the contact reduction, and the seasonality. So if they all jointly play together, we get these unpredictable wave patterns. And here a reminder of how this then can look like. It means that sure, we have a good short-term prediction, but on the long term, we have not a good prediction how this wave might look like. I want to stress this all holds if mitigation remains necessary, or if the population agrees that they want to react to high case numbers. If they don't, we get seasonality, classic seasonality. So I showed you a bit how ideally one could mitigate and how delayed mitigation might lead to chaotic endemic dynamics. As a small outlook, we now really want to also introduce what is the effect on information and disinformation on COVID, and what's a better place to go to if you look for disinformation than the beautiful Telegram network. We looked at Telegram, we downloaded a few billion messages, and this is how it looks like if one looks for then COVID-related content on the different channels. One finds that the fraction of them are clearly COVID-related, the others are not so much. We have been looking there now at the spread of information and disinformation, what basically pushes that, how that relates to COVID. I can't go much into that. I'll present it basically next week, Monday, already at the DPG spring meeting in Berlin. The reason I put that forward is because this is really a cool data set, I would say. This is only the first glimpse I can give you. And if anyone knows someone who really wants to dive into that long term, we are happy to accommodate them in Göttingen. Thank you very much for your attention. Thank you especially to Laura, who brought home the first project, and Joel, who is the one driving home the second one.
Thanks so much, Viola, and same thing. So any urgent questions for definitions similar? Maybe just, if I got it correctly, the way that you implemented seasonality is basically just by reducing the effective R at certain time points.
The way we introduce seasonality at the moment is to have a sinusoidal variation on the R value. Why do we do it? Because then we very clearly can say what's the phase in our oscillation, but any other periodic signal would do and would give us the same result. We also changed in terms of the seasonality. We wondered what makes this delay of 3 months with the peak, so peak seasonality versus peak wave that we have in the ideal case. And that delay of 3 months is not it's a quarter year. So if you would go to another planet where maybe the year doesn't have 300 something days, but double or triple, it's again exactly a quarter year. That's why I wrote P half as the delay between the peak of infectiousness in seasonality and the peak of your wave that you should ideally have.
Thanks so much. And I think it's something we can discuss a bit later, because of course for us often the question, what is seasonality really in the infectious disease, is something we are looking a lot into with real data. So next speaker is Lilian Kuljan, and she has a communication background, and she's a researcher at the University of Lübeck, and I'm looking forward to your talk, Lilian.
Hello again. I hope you don't have enough of me talking about behavior, because I'm going to do it again. And also this time more from the evidence side, how can we use behavioral science for epidemiological modeling is the question I'm trying to answer. Okay, I don't think I have to motivate why behavior is important, right? So Michael has done that already, Viola has done a great job of that. And Michael has already introduced that when we look at how agents decide about behavior, and here I talk about compliance behavior, compliance with these mitigation measures, we utilize theories from a broad range of social sciences, from economics, from sociology, from psychology. And I want to hammer home, I think, the point about the need for empirical validation of model assumptions and model results. This has been long an ask in the agent-based community of like social simulation, and unfortunately it is not done very often. So models assumptions about decision-making. These are two very prominent psychological models of bounded rationality. I mentioned those before. I don't want to go into depth, but basically they assume your attitude, your perceptions of risk, about like the efficacy of an intervention, they influence your behavior. And these are like tried and true theories, we use them a lot. And now let's look at the evidence from the epidemic context. So there have been many efforts. For example, I mentioned the COHERE group already. They looked at many studies conducted on COVID-19 and what are factors associated with different kinds of protective behaviors. This is the example of hand washing. And if you look among the most effective or the most stable evidence and the most stable positive effects we find, these are like standardized mean differences, by the way, there are just these factors we see in those models. Attitude is there, perceived risk is there, subjective norms are there. That's great news, right? And we also did a review of reviews, and we also just looked very like on the surface, how often is this mentioned and is the direction of the effect mixed or positive? And again, we see like perceived intervention efficacy is there, perceived risk is there. I think that looks great so far. So we have solid theories, right? Well, maybe. I talked to some of you already about like the general problems with social science methods. But if we look at the studies that have been conducted during COVID-19, most of them are cross-sectional, and those findings then are purely correlational. And we are not interested in correlation, we are interested in causation, right? So what causes compliance? And even though those theories I just mentioned have a very long history and a very strong support, I think if a theory is developed in the context of making someone take their medication, it might not perform as well in the context of making someone wear a mask in a global pandemic. So we just have to ask, are those theories the same? And then what it burns down to is like, how do we even run an RCT to test the influence of beliefs? How do you manipulate beliefs in an experiment? Well, there is this thing called a behavioral intervention, actually. What is a behavioral intervention? That's an intervention to change your behavior, duh. Okay, in this case, for example, intervention compliance. And you have all seen these during the pandemic. These are like nice posters that say, please wear your mask, it's actually really effective. And when you look into the theory of that, those interventions actually rely on manipulating beliefs and attitudes, and they draw on psychological theories, but actually also like economic theories. There are many economists' papers out there. So there are not really RCTs, to my knowledge, about the health belief theory in the COVID-19 pandemic. If you do have some papers on that, please reach out to me. But there are many tests of these behavioral interventions. So I thought we'd look at them as kind of proxy RCTs for the underlying theories. I think intervention scientists might have to say something about that, but let's look at that. So we did actually a review of behavioral interventions, how lucky. And we did this together with a team from the University of Belfast. Thank you so much to them. Started out with about 700 papers and then screening out many papers with behavioral interventions. It's not a great search term, and ended up with about 30 studies we included in there at the end. Yeah, and the results are kind of sobering. I don't know if you can see the dashed lines, but that is like, from Cohen's classification, a small effect. So maybe the effects of all these theories are not as big as we hoped. Why? I think there are 3 possible reasons that probably contribute all a bit to that. So one thing is, again, study design. I just said, well, all these studies are correlational and cross-sectional. Most of these studies are cross-sectional as well. So if we manipulate a belief, it might take some time for the behavior change to manifest, right? So maybe it's due to the study design. The second point, and I think this is very important, is intervention design, right? You just saw that poster. Do you think that changed your belief? Maybe a poster is not enough to change a belief, so maybe the intervention design is not optimal. But I think we do have to ask whether the predictiveness of the theories we are so used to using is insufficient for pandemics. And what does that mean for modeling? Do not abandon behavioral science, please, but I think empirical validation is really important, and especially using experiments, and especially in novel contexts. And there, I think theories can then inform simulation modeling, but simulation modeling can also drive theory development, because if a theory implemented in a way that is plausible, produces plausible behavior, it might make more sense to invest resources for experiments, which is very expensive, and please give us funding for that, but it might make more sense to invest resources in that if then the theory does not really do anything in modeling. And before I am done and take your question, some shameless bit of self-promotion on decision-making, but in a different context. We are also looking at science communication and how visualizations of epidemiological models go into decision-making. And for that, we want to talk to experts. You are all experts. If you follow this QR code, you can register, give us your email address, and then we will contact you for the study. You won't buy anything. You can also opt out. But with that, that is my, that's my short talk, I hope. And now I'm happy to take questions or take questions later.
Yeah, thanks so much for a really nice talk. Questions? Anyone? Go ahead.
Thanks for the interesting talk. I think from the standpoint of causality analysis, what you did is known as instrumental variables. And as far as I can tell, they are based on a very large set of hard-to-check assumptions. Have you also considered quasi-experiments to check your theories?
Can you give an example for that, please?
So a quasi-experiment is that something like RCT occurs naturally in reality, and then you try to identify the subpopulation that is subject to this RCT-like decision-making?
Oh yeah, that's definitely a possibility that we could look into as well. And I think looking into different kinds of causal inference definitely makes sense, not only experiments, but I think experiments are, well, easiest to think of. Yeah, thank you for that question. Thank you for that proposition as well.
Thanks so much, and I think we go to the next speaker, who I think is Miriam now. I think you should swap places, yes. So thanks so much, and Miriam will be talking about impact of adherence and stringency on the effectiveness of lockdown measures.
Okay, hello everybody. I know everybody's tired by now, so I'll try to keep it as short as possible.
But we are well in time, I have to say. So I think this is
really?
the people in this panel have been adhering to time perfectly.
Yeah? And now? Okay.
Diese große, vorwärts, rückwärts. Und das ist hier der Pointer.
Ah ja.
Okay.
Okay, so I will talk about some modeling work that we did in Utrecht in my group, and actually the work was mainly done by Joren Brünekreef and Sascha Teslia, who are postdocs in my group. And originally Joren wanted to come here to this conference and talk about this work, but he couldn't come, so that's why I'm now giving this talk. The work was done in the context of a project which we had already actually before the pandemic to look at feedbacks between behavior and epidemics. A project in collaboration with Vincent Buskens, who is a sociology professor in Utrecht, and also Hendrik was involved in this project, who did his PhD on this project and is now in Lübeck working on the InfoExpand project. So it's all related to each other. Yeah, so the background is that we wanted to look at the impact of lockdowns during the COVID-19 pandemic and to see how lockdowns and feedbacks with behavior, for example, lockdown fatigue or people not adhering to lockdown measures, how that would interact with each other, and with the question in mind, what is the best way to actually implement a lockdown so that it's most effective? And for that reason, we wanted to build a model that includes disease dynamics and also behavior in the sense of opinion spread in a population network. The work was actually based on earlier work that we had done with an ODE model, so a very simple model where we had just an SIR dynamics and two opinions in the population, and we looked at how the opinions and switching of opinions in the population would influence the epidemic dynamics, where there could also be assortative mixing by opinion, and these opinions were a health positive opinion, meaning that people who held these opinions protected themselves better and had a lower risk of becoming infected during the outbreak, while the red part of the population were the so-called health neutral people who didn't care that much about whether they become infected or not, or at least they weren't willing to take protective measures. This is, of course, a very simplified system, but yeah, it is something to start with. And the work that Joren then did was to extend this ODE version of the model into an agent-based model where we could really look at the individual contacts within the model. So this is an agent-based model with an SIR epidemic dynamics. And in addition to that, again, two opinions in the model, the so-called health positives, or that are the blue guys in the network, and the health neutral people. And health positive ones are actively engaging in self-protective behavior, while the health neutral ones don't do it. So health positive people have a higher risk of becoming infected. And then in this network, we looked at edges connecting individuals, and these edges could either be physical plus informational contacts, so physical meaning that infection transmission could take place, and informational that opinion spread could take place. And in some cases, then these edges can also only be informational edges where no transmission of infection can take place. Yeah, so then to look at lockdowns in this type of situation, we basically looked at two parameters. Again, a very simplified version, of course, of what informational only, so in a sense, no physical contact, but only informational contact for the duration of the lockdown. So that's physical distancing in effect. And then we had another parameter that we called adherence, and this only applies to links of two health neutral individuals, and describes the probability that two health neutral individuals actually reduce their physical contacts or not. So if adherence is low, they just keep on having their physical contacts, while if adherence is high, they also reduce their physical contacts. And lockdowns are implemented as soon as prevalence in the total population rises above a certain threshold, and lockdowns are lifted again when another lower threshold. The network structure that we used was a small world network. So in a sense, you start with a network where everybody has the same number of contacts, and then you rewire some of the contacts so that there are some long distance connections. So it's a network where there's local clustering, but also some long distance contacts. Also, again, a very idealized sort of network, but you have to start somewhere. And switching of opinions can take place with three different mechanisms. One is peer pressure, so if there are individuals with the opposite opinion in your direct network environment, they can lead to switching of your opinion to their opinion, and that's a symmetrical process. Then there is so this peer pressure, that's something that's always going on, even if there's no infection in the population. Then there is the mechanism of health scare, which means that if prevalence is high or increasing, then this makes the likelihood higher for adopting a health positive opinion. So people are more likely to start protecting themselves. And then the third mechanism is lockdown fatigue, which means that the longer a lockdown takes, the more the likelihood of adopting a health-neutral opinion is going to increase. So that is going in the opposite direction. Yeah, I'll show you some results from the simulation. So, of course, it's a stochastic model, so we did a lot of simulations, and this just shows some trajectories of different situations. So in the upper two graphs, you see here the situation with no lockdown, so just the disease dynamics in this situation. So, and we looked at a time span of 1 year with parameters that we took from the literature, basically reflecting SARS-CoV-2. So here you see the waves of the epidemic, and at the same time here the proportion of health-neutral individuals, which is going down in this case with no lockdowns, because people are aware of the epidemic and start taking self-protective measures. So the opinion of health-positive individuals is actually spreading in this situation. In the lower row, you see some simulations where we have strict lockdowns. So this parameter Q is high, and high adherence, so in a sense an ideal situation. Again, you see the outbreaks, but they are now somewhat lower, and you see that here, through the lockdowns, that people don't that much switch into this health protective behavior, because there's kind of balance between self-protection, but also being fed up with the lockdown and people switching back to the health-neutral opinion. Now, if we look at a situation where we have a medium strictness of the lockdown, so here this parameter Q is 0.5, we see that we will have actually, even if there are lockdowns, ongoing transmission, and the lockdown fatigue is kicking in, and people actually, the proportion of the population in this health neutral state, which also means then lower adherence in the total population, is increasing, which again, of course, contributes to having increased transmission and the necessity to having longer or more lockdowns. So if we kind of look at more aggregate results, here we see the relative final outbreak size, so with respect to the lockdown-free baseline situation in different, how do I go back? I was here. So on the x-axis here we have the stringency parameter, on the y-axis the threshold when the lockdown is implemented, and here for 3 situations with respect to adherence, so high, medium, and low adherence. And the blue colors always mean that the situation with lockdown is better than without lockdown, and the red means basically that you make the situation worse with the lockdowns. And so here you can already see that only in situations where stringency is relatively high, so the strictness of the lockdown is high, and also adherence is high, or at least medium, you get to a situation where it is positive to have these lockdowns. And this shows the situation at the end of the year, or at the end of the simulation, with respect to the proportion of health-neutral individuals. So they become high, so the willingness of the population to actually take protective measures becomes lower in the situation where you have lower stringencies and also with low adherence. Yeah, and this shows the total duration of the lockdown, so how many weeks of the year did the population actually spend in lockdown. And again here, the similar situation with high stringency and high adherence. This can be kept at a lower level, so shorter lockdowns, while if adherence is low, and well, here stringency doesn't matter actually, there is the population basically has to be in lockdown all the time. And this kind of shows a sort of aggregate picture of this also. These are the dots here are single simulation runs, and on the x-axis here we have lockdown duration, and on the y-axis the relative final outbreak size, so in comparison to the baseline scenario, and again for 3 different adherence levels. So if adherence is low, then basically the total lockdown is long in all situations, and yeah, you don't really get any better to the situation without the lockdowns. And only here in these situations where stringency is high, so that's like blue or orange color, and also adherence is high, then you really, on the one hand, have shorter lockdowns and also a higher or a high impact on the epidemic outcome. Yeah, so the conclusions are basically it's good to have strict lockdowns imposed quickly, but of course it always remains a bit for the policymaker a difficult decision to when to actually implement it. But yeah, if these lockdowns are not strict enough, they may actually lead to worse outcomes than if we don't have them at all. And yeah, so also for medium and high adherence, stricter lockdowns could decrease the time spent in lockdown, which potentially has a high economic benefit. Of course, the limitation here is that there are many simplifications in this model, and it would be nice to have data to look into more detail, but well, I think the difficulty is also that there are many parameters that are very hard to measure. So this is more of a kind of, yeah, I don't want to say theoretical, but kind of qualitative result. Yeah, okay, that was that much what I wanted to say here, and then I still wanted to make you aware of a new summer school that we are planning on the European level, so with a number of people from different European countries. So Tom Britton in Stockholm, he got some funding for starting this up, and the idea is to have a summer school that is similar in format to the Seattle summer program that they already have for many years, which means that there will be short courses of 2.5 days, and in every week there will be then like 2 courses after each other, and you can put together a program. So if you would stay a week, you can put together a program of 2 courses, but they are in parallel, so there are 3 courses in the first half of the week and 3 in the second half. And the idea is that this is, I mean, we are doing this for the first time this year, but the idea is to have this also in future years and also extend it possibly, if there is enough interest to extend it, include more courses and maybe have it for 2 weeks, like it is also in Seattle. But we wanted to have something like that also in Europe, so that people can have the opportunity to also meet people from different European countries who are working on or trying to get training on infectious disease modeling here. Okay, so with this I'm going to stop. Thank you.
Thanks a lot, Miriam, for a really nice talk. And it makes, of course, a lot of sense what you have shown, and also it was something we discussed a lot during different waves of COVID, this question of how short should a lockdown be, how adherent will people be if we have it long. Yeah. So questions, direct questions, yeah.
Thank you for the talk. I have a question regarding behavioral adoption in your model. So if I understand correctly, the health neutral or the health positive behavior is assigned randomly at the start of the simulation.
Mm-hmm.
And then there is the peer pressure that can trigger behavioral change. Is there also the possibility that edges between individuals that have a different health behavior break off? So like, I was thinking about it in the way that if I have a connection to someone who doesn't show protective behavior, but I am like very health conscious and want to protect myself, then I would probably not see this person as frequently anymore. So is this possible in the model, or is it just this peer pressure dynamic?
Mm-hmm. It's not possible right now because the protective, in this version of the model, the self-protective behavior means that, for example, like something like mask wearing or hand washing, that people have a lower risk of becoming infected, but it doesn't apply to the frequency of having contacts. But that would be a kind of logical extension, of course. You could think of many ways to make this process of influencing each other more complicated. For example, in the sense of, like Michael talked about in his talk, you could have these influence response functions that determine how people in your environment influence the way you think about or the way you behave. But we just here implemented it in the, let's say, most simple way we could think of.
Thank you.
So thanks a lot, Miriam, and we will discuss further in a bit. And now Kai Nagel will talk to us for the last one, and then we will go to discussion. Thanks.
All right, somebody else needs to operate the machinery, but maybe I can already get started. We put this last because I'm talking more about the downstream end now, assuming that we're actually able to influence behavior. What can we achieve by doing that? And it actually turns out we can do a lot. So we thought about an appropriate title for this presentation yesterday, and the title will hopefully show up in a second. It's at least there, but then everybody has to walk around the screen. That's not the title. The title is one before that. So it's this here, actually, that we actually have a model that has an adjusted R-square of larger than 60%, which is something that I have found rarely in my scientific career, at least after I left physics. We essentially never found that. Now, there's a little more wordly title behind that. This is that we can actually explain more than 60% of incident growth by out-of-home duration and weather. And the out-of-home duration here is behavior. Yeah, it's expressed behavior, and that's certainly something that kind of taking this apart is not totally easy, but I think it's a really good starting point to see this. And this is mostly work by Sidney Paltra, and then Inan Bostanji was also involved in that, and myself. This has essentially two steps. The first one is just looking at behavior, and there's stuff like this here. Let's see how we can do this here or this here. There's this, yeah. So there's three types of models, and the model is that we say incidence growth. Yeah, so this is like 30% from 1 week to the next. So it's a multiplier. something like 1.3. And we try to describe this by a constant plus a factor in front of either out-of-home duration or out-of-home duration to the 2 or out-of-home duration to the 3. And this has a little bit to do with that you could say, okay, maybe we have out-of-home duration, but it's also a proxy for other things, like wearing masks. So people are more, if they stay at home, then maybe they're also doing other things on top. And then we kind of run these things through the data we have, and you see kind of what we have here. So we have out-of-home duration here, and we have the growth multiplier here. So you have this cloud of dots there, and you estimate the models, and I took out all of the other statistics here to save some time, but the adjusted R-square between these three models is pretty much the same. So you can't differentiate that. And so this is kind of the thing you always have. You have a cloud of points here. This talk doesn't have it, but you can also look at other people doing the same type of thing. As long as you can kind of put it together, they all find the same thing. And that is essentially, I mean, you have a bunch of dots here, and you can do whatever you want to. You can put a straight line through this, and then you have a valid model, and the only thing you kind of have from that, I will get back to this, that is relatively steep, so it kind of ends up below 0. Now that can't really be the case. If the out-of-home duration goes down to 0, our R value can't be below 0. That's not possible, So this has to go to 0, and that actually means if you have these 3 models, kind of the quadratic model, which ends up close to 0 here, is actually the most plausible. So we would need data down here in order to verify that, but this is really the most plausible to have this. Now there's also a theory to back this up, why this actually makes sense. This is roughly the same argument as Viola had on the household size, is just the other way around. Assume a meeting like this here. If only half the people come here, the probability that an infection gets carried in is divided by half, or maybe just the number of infected people coming in is divided by half. But then there's also half of the number of people who can get infected, which means that the effect is actually quadratic. So if you reduce like this the gathering, so half of people stay at home and half of people actually come in, then your infection is actually reduced to 25% of what you had before. Now what that actually means is if you say I reduce something by a 30%, then 70% still come, times 70% is 49%. So kind of the first 30% of thinning things out gives you actually half of the benefits. And then kind of the benefits actually get smaller and smaller. So if everybody is sitting in the school with half classes and masks and windows open, the additional benefits of sending everybody home is actually pretty small, because this is not linear, it's quadratic. This also argues a little bit actually against this lockdown thing, because this means if you thin out stuff appropriately, you can actually get pretty far. Now, there is one caveat with this, is you have to do this thinning out. If you say half of the gatherings are closed, the other half operates at full steam, then you divide only by 2. Whereas if you keep everything open, but only half of the people show up, then you get this going down to 25%. So it's a bit tricky to actually get this right in order to get this effect. If we add weather, this is what we get. It's relatively quick, but I think it's quite interesting. If you look at this equation here, it's pretty much the same thing. So we say the growth multiplier now is 0.02, let's say 5 or 4 times what we had before minus this. And so the way you can actually see this is we have a base model, which is this. And then we have a seasonal correction. Now the out fraction is something where we say how much people spend out of home, so doing gatherings outside instead of indoors, or maybe it's also open the window or something. That is essentially a function that saturates at 0 for very low temperatures and saturates at 1 for very high temperatures, no air conditioning. And then what you find with these numbers here is that you have a base model, and then this model takes away 20% of this here. Which then also says that the dynamics is mostly driven by out-of-home duration and to a relatively small extent by seasonality. Seasonality in this model is only about 20%. And so we get some idea of where we are with respect to the effect size. We can't say seasonality is doing everything and behavior is doing nothing. Most of this is actually behavior, mobility or out-of-home duration being behavior. And then some of this is actually seasonality actually helping us. And this is kind of what we get down here, is this R square of 63%. Now, if you look at this, there was a plot on top, which I took out because of time, but this is the first year of the pandemic. So we took the first year because there's no immunity stuff involved, which makes this a lot easier to actually get some data. And the dots are the data, the weekly incident growth, and the black line is the prediction we would make based on mobility data and based on this, essentially the weather effect, so you get this kind of model. Now the thing you have to keep in mind, during summer incidences are pretty low, so the error bars of the dots are actually pretty large. This is something the model doesn't capture, yeah? So there's some variance or variability in there that we will not be able to explain, which means out of the missing, whatever this is, 35%, some of this is kind of in the system. We will never be able to explain that. There's one area where we don't get it right, which is this year, is the beginning of October. Yeah, the first fall wave, which seems to have been stronger than this model would predict. And we checked a couple of things and couldn't come up with a result, but Viola has a good idea. Might have been higher incidences in the neighboring countries kind of seeping over into Germany at the end of the summer. So this is something we need to check if putting that in makes this even better. So that actually means the whole thing seems to have been pretty simple. I mean, you know, we have this complicated Asian-based model and we can kind of close schools and do whatever, but in the end it seems like, at least for Germany, is just this relatively simple thing. Now this has to do with mixing, yeah? Some of the talks before were about mixing. It seems to have been pretty well mixed, yeah? Essentially it doesn't look like we had like some people doing very strongly, or at least it didn't have much of an effect, that we possibly had different subpopulations. Just very quickly, we're now looking into the opposite effect, which is kind of trying to explain out-of-home duration by these other variables, and there were talks about that before, so I don't want to spend any time on that. And so this is what we have, yeah, this kind of, remember this, if you look at models in the literature, you always will get this cloud of points. We never get over there, so we can't estimate over there. But all the models kind of get this slope. The slope means you have an elasticity larger than 1. You're reducing out-of-home duration by 10%, essentially gives you 20% of reduction of the R value or of the incidence growth. And yeah, I mean, this looks amazingly, at least for me, like explaining. It doesn't mean it will explain the future, but at least for this, it seems to have worked pretty well. Thank you, that was it.
So thanks a lot for, that was, yeah, it has explained actually a lot, so thanks so much for that. Any questions?
So in this plot here, you showed the R values are approximately the same for different orders of polynomial fitting. And then you show throughout the rest of your talk using quadratic and saying that this, because it fits the explanation that you had, it works. Does this not show that taking any polynomial order is approximately as good? Like, I don't see the evidence for the quadratic outperforming cubic or quartic.
I mean, in the end, it depends on how much you believe into mechanic models. Yeah, if you say everything is data fitting, then you're right. But if you say, okay, if you go to out-of-home duration at 0, my model should remain plausible, and plausible is that at that point it should be then at 0, then essentially you get another very strong data point exactly here, yeah, and then you would fit against a model which essentially needs to be here at that point, and then quadratic. I mean, assuming you do polynomial, this is the only good fit that you get. So we tried this actually, that we said, okay, we want a model that goes through 0, but we leave the exponent open, yeah, and then what we actually get is 1.9 something something. So it's really very close to 2. Yeah, but clearly it depends if you trust that it needs to be 0 at 0 or not.
Great, thank you so much. And then I would ask all of the speakers to come up, and we have a few minutes to discuss a few questions. Ich leite ein und dann. Okay, so thanks so much for really nice talks and I think lots of insight. So we would ask you first for any questions, and if you don't have any, then Viola has threatened that she has 2 for you. So go ahead.
1098, this is her. I always wondered how much is there influence of the NPIs, so the governmental interventions, and how much is the voluntary part? And obviously, I guess we all agree that depends on countries, and I think we all know Germany best. So now you all know this format of a forced choice. You have to choose one of the 3 options. Who thinks that the majority was, one option is who thinks the majority was the influence of voluntary reduction? Was the most influence the mandatory one, or was it relatively balanced? So you are allowed now to stand up. I give you the options in a moment. And I define this now for the very first year, 2020. I should have gone by waves. But let's say, okay, the very first wave, then we can do it 3 rounds. The very first wave, how much was voluntary, how much was mandatory, how much was it balanced? Who's for the voluntary? Please get up. So you basically say that people did much more than the government wanted you to do, less than 0 contacts more or less. Okay, who is balanced? Okay, I shouldn't vote, I guess. And who thinks it was mostly the NPIs? And this, I think, shows that we really have to understand also the voluntary part, I guess. And then we could ask basically for the winter. Remember the first winter, case numbers went up, testing wasn't there yet, vaccination wasn't there yet either, or we didn't have Schnelltests, but we did have the PCR tests, but you could only get them if you were really symptomatic. Hospitals were kind of full. How much was voluntary? Who's for voluntary? The first wave, the second wave, first winter, yeah. Second wave, first winter. How many people think it was mainly voluntary? Who think it was balanced? Yeah, I don't know. I want to keep out. And who thinks it was mainly the NPIs in that winter? Thank you. I find this personally surprising, if I may comment on it, because my impression was it took until hospitals were full and then people realized, oh, we have to do something. So it was, in my view, very much the hospitals being full. But apparently the community here thinks different.
But isn't that the same thing? So if people did not react, then... But the NPIs at the second wave at the beginning weren't very harsh. So I think people were I mean, it's all opinion-based, right?
So you see how difficult it is to disentangle. My view often is with inference that if you don't even see it with the naked eye, it will be difficult to quantify it afterwards. Michael.
So I think it's really hard to disentangle the effect of the voluntary, of the preferences of people and the restrictions they perceived. Because so there were of course many people obviously who really wanted to stay at home and get vaccinated and so on. But if there had not been the interventions by the state, many people would not have been able to do it. So it is the combination of the two. So why did people, for instance, stay at home? Because they wanted and because it was possible at that moment. So the behavior that we've seen was a function of both. No, I'm right.
Well, I mean, what we can see in the data is that the out-of-home duration was lowest during all of the pandemic in the first wave before the government mandated the lockdown or the stay-at-home obligations or the contact changes. And then government was discussing if they should keep these, and people were actually drifting back to normal behavior. And we had this pattern, I mean, variations of this pattern all through the pandemics.
Actually, this is also something we see in the study of Cornelia Beetsch, and it's one of my informal take-home messages. Cornelia Beetsch had this question whether the current stringencies are too strong, just right, or too weak, to simplify it. And you always saw that when case numbers went up, at some point this survey showed that people thought the current NPIs aren't strong enough. And then a couple of weeks later, stronger NPIs were implemented. Then case numbers at some point went down, people's opinion changed, and then government acted. So my impression was that it's very much this order of first people wanting something and then the government reacting, which makes total sense. One politician once told me, you can't implement any of these measures if people don't want them, because if they don't comply, what you have is even worse. Because you have the first time a measure that is not, it was in German, reasonable in the wider sense. And if it's not reasonable, people might start not to comply, and it might be the first time that they don't really comply to a rule. They might be stopping at red lights, they might be paying their taxes, and suddenly they do something against the government. So you really have to be careful to try with the government to track what in principle the majority of population wants. And that's what I find very, one of the take-home messages. Neil, maybe you can get a microphone, that would be great.
It was very different for different age categories. What we saw in the first lockdown in Belgium, and we had a questionnaire running, is that especially older people actually followed the rules before they were introduced, and younger people in general, because even within the age brackets there is still quite some heterogeneity. But we really saw it that older people actually followed the rules much better, much faster, and then the young people actually were very late in that process. And that was very apparent from the first wave. And my interpretation was always some people need guidance from external forces, let's say. Certainly when in the second wave, that was really necessary because the messaging was very clear, hospitals were indeed put under pressure and so on, but a lot of people did not follow that they needed a signal from the government. And that was not coming. It was too late in Belgium, for sure.
Thanks a lot. I would like to make a last round now, because I think then we are closing a bit. And with a bit posing the question I asked at the very beginning. So you showed a very wide array, I think, of different ways to include behavior in the models, and quite a few of them depend on people actually reacting to what is given out as information about the infectious disease. And of course, this will be, or this is very, very different for different infectious diseases. We have infectious diseases where basically the only one reacting is maybe the immediate family of the person that has the disease and no one else. And then you have diseases where no one's reacting, and then you have diseases where it's really, really dependent on what's happening in the population. And this is, of course, also epidemic phase dependent. So my question is a bit, in the work that you do, and we can all comment now, how are you looking to expand a bit the methods that you have to this wider array of how different infectious diseases come into it?
So for us, indeed, it's very much focused in this funding period, so to say, on the question of this behavioral feedback to an acute outbreak. And there, I think Neil also put it very, very nicely. Some people reacted because they wanted to protect themselves, others reacted because they wanted to protect others, but typically they only do it once the governmental indication is given, because why should you do it alone? You don't know, it hardly helps, so you wait until everyone, in quote, is doing it. So how do we include that? So this is very straightforward in a way, because only if we have this collective behavior, that people are reacting collectively to that information, we get relatively complex dynamics. If we have only the single person or their family reacting to it, like you proposed, it's straightforward because you effectively reduce the R or R0 value. We can discuss what R0 exactly is. And you do that for every single of the cases. But you don't have any behavior in those people not affected, and therefore you'll not have these complex dynamics, or at least the effect will be very, very low. Sure, it does reduce the local spread, but it's basically not having the emergent complex dynamics because it's only localized and it's not via this global feedback. It really is a different class then, and a much simpler class of models. And then it's more about communication strategies. How can I get there? But you look skeptical.
Just because families were just one example. So you might have also a population, a specific population group where this does make a difference. So I think it's a bit of a scale rather than a one. But thanks so much.
No, it's really a big difference of whether you only have your local group reacting, because this is one-to-one only the incidence, or whether you have the full population, in quote, reacting, sure, with some variance. And think about the first or second waves. We had incidences of 200. That sounded high to us back then. But it was 200 per 100,000. So that's, I hope I do the math right, 0.02%. Hardly anyone in a given week. Nonetheless, you have, in quote, everyone acting. That's a bit like when we talked about soccer a few times. People went to the stadium, and it hardly matters if there are 70,000 people in the stadium, but what matters is everyone going to the pub and screaming in the pub. It's just a sheer number where then this overall collective dynamics comes in, and that's why we have the reason to look. If it's about reducing, it's about informing people, and then it's communication science, it's social science, it's something where I can contribute a bit less, but others can contribute.
So I couldn't agree more. So what is interesting for us is this loop between disease dynamic and behavioral dynamic, and there's a reinforcement there. And your comment is extremely relevant because also these other diseases are important. But just from a modeling perspective, it's a little less exciting, at least for the social scientists. It's a stupid point, actually. A point that is going, however, that is supporting your point, is coming from what comes from the social sciences, is that it's not just that diseases are different, it's also what kind of protective behavior we are studying. So for instance, when we talk about vaccines, I do not know whether people here are vaccinated. What I do have is national vaccination rates. For mask wearing, it's the exact opposite. I do see people wearing a mask, but I do not know the national values. And this has a big impact on the spreading of behavior in a network, if I can be locally influenced or only globally. So it's going that direction, but it's not only depending on characteristics of the disease, but also on the kind of protective behavior.
I concur. I also want to add, I think then opinion dynamics maybe come to the forefront a bit more because you have like small disease like clusters and then large opinion clusters, and I think these are very important because something I try to like bring home with the talk is that communication and information, it is hard for us to understand how to really use that and utilize that and bring like behavior change out of information, and then opinion dynamics and like social pressure matters much more. So I think that is where that might go.
Yeah, thank you. I also agree with everything. I want to add that that's my intuition. It's a research question. I think sampling plays a role. I mean, if you have an incident of 100 per 100,000 for 10 weeks, it's 1,000 of 100,000, which means 1 out of 100. So you probably know somebody who knows somebody who knows somebody who had the disease, and then you get some feedback if this was really bad or not, and then you can kind of see if this is equivalent with what is reported, and then maybe you have a friend who had no problems, and then you say, okay, all the media is saying total bullshit, and it's actually an easy disease, or somebody nearly died, and then you say, okay, it's even worse than what they are saying. And I think some of this is also with the way it's represented. When we remember these images from Italy, where they had these military vehicles, like putting the coffins across the street. I mean, if you have 1,000 out of 100,000, and then maybe you have 1% severe cases, is 10 people. If you put these 10 people in a kind of a truck queue and put all the video cameras on them, you get a totally different sampling than if you kind of put them to the side and never talk about them. So this kind of sampling, I think, might be important, but I have no idea what you can do out of this. But I think you can start discussions. Like, I had 2 friends who had COVID and they didn't have any problems, so something like that, and you can start your Twitter group on that.
Yeah, I also agree with everything. Maybe I can still add that, well, we also have this experience with HIV that in the beginning, when there was not yet any treatment, so this perspective of having this really severe and deadly disease induced quite a lot of behavior change, at least in some risk populations. And at the moment when an effective treatment became available, you saw that risk behavior was actually going up again. So it has a lot to do with the risk perception and how severe the disease is perceived and the danger to the individual.
I'm quick, but I think it's important. Something that I took home from the pandemic is that people like you, Viola, actually had a huge impact on human behavior, and also Kai. So just explaining the science behind decisions of governments, giving people the feeling that they are smart people thinking about stuff, gathering data, informing politicians, getting trust in institutions. And then people were, with distrust in institutions, were talking to others, convincing them. And that's something we've actually seen, that societies, free societies, were really dramatically changing their behavior. So we can influence people's behavior. Everything has limits, and we need to do that better in the future, even better. But I think you guys really prove that it is possible. It's a very powerful tool.
So I think this was a very good last comment, and we really have to close. I'm so sorry. We really have to close because we need to go to the next bit. Thank you so much, everyone, and I learned a lot, and it was great. Thank you so much.
Sorry, I object that you finished the discussion.
Alexander, you come up here, and Raphael, you come up here, please. And then we close this, I think. Hi.
Yeah, now we come to the final part of the conference, and we still have one award left, the oral session award, or oral presentation award. And yeah, the prize goes to the talk Guidelines on Quality Assessment and Reporting of Mathematical Modeling Studies for Infectious Disease Dynamics by Antonia Barth. Yeah, and yeah, we just had the idea to create another award, special award for best organization, and we have two first prizes, and one goes to Carla and the other one to Sabine, because without them, I think we couldn't have done this conference. Then, yeah, maybe could you show now the QR code on the big screen? Okay, now here it is. Because before Young MONID, this code that was a wrong one, so this is now the correct QR code. So please, yeah, scan this QR code. And yeah, then I would like to say thank you to everybody for attending the conference. I think we had great keynotes, 2 fantastic keynotes by Julia and Neil. Thank you very much. And also thank you very much for attending the full 2 days here at the conference. It's really great honor for us. And I think we had a lot of speeches, and the quality, quantity of the research which was presented here, and also the broad range was very impressive. And if I see all the researchers here, I think we were quite successful in building up modeling capacity in Germany. And the goal now, of course, for the next months and years is to maintain this capacity. And that's something we are currently working on, to come up with a strategy so that we keep on going. So thank you very much. Okay.
Okay.
I think.
So see you in Berlin next time.
Yeah.
But yeah. Thank you very much.